Okay, folks, we're going to get it started for the day. And I'd like to say I had this hat in my closet, but I didn't. A week and a half, 2 weeks ago, we were at the National Alliance of Healthcare Purchaser Coalitions in Dallas, Texas. The theme was Wild, Wild West. We had our theme first, but it doesn't matter. And Chris Severson, where are you? Chris is with my sister coalition in Nevada. She took pictures of line dancing. And it was a lot of fun. Dawn, you were in those. Good morning again. I'm Cheryl Larson with the Midwest Business Group on Health. We are so excited to have you here today. We had record-breaking numbers of people registered in person and online. We always have a jam-packed program, and today is no exception. And this is one of my, other than our annual conference, one of my favorite programs because the topic is something that MBGH and staff and myself have been very, very passionate about for many, many years. We like an informal gathering, so get to know your table mates. We like you to enjoy the food. We like you to meet with each other and most importantly, meet with our sponsors who allow us to have it at this really, really stunning location. This hat, by the way, will be off for the rest of the day, just so you know. Making sure it doesn't last too long and ruin my hair. We're going to get started again, and I'm going to start by changing the slides. That's me. If you're new to MBGH, we're one of the largest and oldest employer coalitions in the country. We see ourselves as catalysts for change. We represent well over 5 million lives, but we keep it at 4 million because we can't always be sure of that. And we are a community of your peers and a trusted source. And our members have fun together, and they work together, and they learn from each other. We have some upcoming educational programs. On September 24th is our next full-day conference on tackling the chronic condition trifecta of cardiovascular diabetes and obesity. We also want you to save the date for our May 5th and 6th, 46th annual conference. Again, it'll be at the JW Marriott. More details to come. Look on the far right. If you're a member, you have access to all of the programs we've done so far this year. We have the recording and the PowerPoints so that you can be, if you missed anything, you can fast forward, you can just listen to one section. You need your username and password, but usually you need that anyway because when you register for these events, that's a requirement and it's probably saved. We are still doing monthly employer-only roundtables that are facilitated by leading experts, and you can see on July 10th, Cracking the Code on Catastrophic Claims. We have a panel today with Chris Severson of Nevada and Dr. Christine Hale. And they're going to talk about a high-cost claim project that they worked on. And we're hoping and crossing our fingers to get some funding to do that for our mid-size employers. And when we talk about mid-size employers, we're talking about 500 to 10,000. So it's a pretty big range. But we would love to give them an opportunity to make sure that they can get their data or use data to make good decisions. And then we have other roundtable scheduled for August, September, and October. Today's program, if you haven't turned your phone off, please turn it off. Use the Q&A function to ask questions of the speakers on the app and the chat function. And we're going to talk about how to pull that app up if you have not yet done so. We will have a survey at the end. It's only 3 questions. So I'll remind you, or Dawn will remind you, and we'll get that taken care of. HR Certification Institute, we get credits. They apply to SHRM as well. That's your information. If you need more information on that, see Allison in the front. And again, we can't do these programs without the support of our sponsors. These are our forum sponsors. Thanks to all of them. We'll be getting a message from each of them shortly. MHPC Forum, Midwest Health Purchasers Collaborative is our purchasing arm. The 3 organizations that represent pharmacy benefits for that arm are with us today. We're thrilled. Visit them as well. And then we had a wonderful dinner last night with board members and the speakers that Slate RX sponsored. And we also have some wonderful other exhibitor sponsors. Prize drawing. We love, love, love our prize drawing. I can see a Yeti tumbler, a Wild West theme prize pack. Boy, I want to know what that is. Another Yeti, some gift cards. Another Yeti. That's popular. I love that. Prize drawing. Did you pick up your prize drawing card? If you don't have it, go get it. The very top entry, Affirmed RX, They have decided that they couldn't get their stuff shipped here in time so that you don't have to go to their booth. How this works is that you have to visit all of the sponsors. They will initial your card, and then you want to submit that by 3:40 this afternoon. Any questions about that? Just ask Allison, she can help you. And now we have a word from our first sponsor, Right Way.
At Right Way, we've reimagined what it means to be a PBM. That's why we're the only PBM with pharmacy navigation. We believe pharmacists are key players in healthcare. Our care teams guide members through every step of their prescription journey, getting to know them and building trust. They don't just answer questions, they listen. We're available whenever our members need us, by phone, email, or through the Right Way app. We find joy in going the extra mile for our members, like calling their provider and following up with their pharmacist. We source all available savings by guiding members to lower cost medication. Our clinical programs help members with chronic conditions, like diabetes, take control of their health and develop ongoing relationships with our pharmacists. Together with our transparent, aligned model, Right Way helps our clients cut their pharmacy spending by an average of 15%. Right Way, your pharmacist in the family.
Thank you, Right Way. I love these vignettes because they give us an opportunity to learn a little bit about the people who are in the room or in the adjacent room next door. And then you can decide, do I want to visit everyone or do I just want to visit a few? So I really appreciate those. If you haven't downloaded our event app, do so now. Here are the QR codes. You can use this to look at the agenda, to see who is in attendance, to participate in the polling, to do the evaluation. So if you need any help, raise your hand. We've got staff here that can help you download that. Anyone need help downloading that, or are we all doing pretty good? And I think it might be, the QR code might be in the middle of the table. So that you can still download it as I move forward. We are going to be asking mostly business-related questions, but we do have a fun one coming up. Let's try this. Who is your favorite old school country western actor? Is it John Wayne, Clint Eastwood, Ronald Reagan, Sam Elliott, and I wouldn't watch a country western if you paid me? Thank you. So let's see what you guys said. And hopefully you're all on. If you need help, Dawn is available, Paula's available. I love these. It's like, I want to play the Jeopardy music. Which one is it? Which one is it? Goes back and forth, goes back and forth. Looks clearly like you do have a favorite, and that would be Clint Eastwood. Thank you for participating. All right, we're very quickly going to go through some of our results of our 2024-25 employer survey, pulse of the purchaser survey that are related to pharmacy benefits. If you want the full survey and if you're a member, you can have access to the full survey results, but you can access the infographic on the app. So what did we learn about affordability? Drug prices are the number one concern for employers at 98%. They see it as a significant threat. High cost claims comes in second, followed by hospital prices third. You know that MBGH and our sister coalitions have been looking at all of these key areas and bringing this knowledge and information to you. And then you'll see employers view lack of transparency and PBM health insurer conflicts of interest as additional threats. What about high cost claims? 67, what are the strategies employers are using to address high cost claims? Disease-specific vendors for things like diabetes and cancer, et cetera, are using these strategies. Also enhanced screenings and early detection. I know we talked last night about cancer, and I always think of cancer sort of end of life, but employers, you guys are focusing appropriately on the preventive side of that. And then finally, 58% are using navigators and enhanced case managers. The top strategies being considered are promoting precision medicine for cancer treatment and COEs and bundled payments. Pharmacy benefit strategies. Interestingly enough, over half of you are planning to take your PBM out to bid in the next 1 to 3 years. because they're not meeting your needs. And we've seen a significant increase of the use of transparent PBMs. At the bottom, you'll see PBM strategies employers are using. The number one is biosimilars. 67% of you are using biosimilars. 23% are considering it. I think we're going to hear a little bit about that in a panel I'm going to have, and we're going to learn about the importance of maybe actually replacing things, because that's when you see real cost savings. So we've got this year's survey coming out in the next few weeks. We're working on it in collaboration with the National Alliance of Healthcare Purchaser Coalitions and all of my sister coalitions that are part of that. So please make sure to complete that and get it back to us. Today you'll hear me talking about a project off and on throughout the entire day. It is our National Employer Initiative on Specialty Drugs and Biopharma. It's a 15-year-old employer-directed employer research project that represents an employer advisory board that helps us look at everything in the marketplace around specialty drugs, high-cost claims, and what we're calling ultra high cost therapies. These are the hundreds of thousands of dollars therapies and the millions of dollars therapies, and the value of those therapies and the challenges employers face. You'll see here work stream 1, which took place in 24 and 25. We did a number of initiatives, and you'll hear about that research later. Work stream 2 starts now and will continue through the end of the year, possibly the beginning of next year. If you are here today, you will likely get invited to the webinars that we have planned this summer. But it is an exciting project because in the end, and you guys know I've always said this, how the hell are we going to pay for high-cost cell and gene therapies? We're finally having some ideas on innovation and solutions, but we need to know if they are actually working, and we'll talk about that today. Here is a brand new employer snapshot and action brief. On June 5th, many of you participated in an employer webinar. It was open to everybody. Fantastic. We launched a brief, but then we realized there's 10 pages. We were reminded by a few colleagues and friends, that's not a brief. That's 10 pages. That's long. That's not what a brief is called. So we put it into 2 separate documents. When you click on this link, and you'll see it again later, you can access this. One focuses more on the overall picture of cell and gene therapy, and the other on the employer project and what employers have to say about it. And now I have a word from Scripta. Thank you, Scripta. Now I am going to introduce our first speaker. Brett Jackson is not only a colleague and my counterpart in Michigan, but he's a good friend. And I always am excited when I can invite my coalition colleagues to join me on podium at our events. Let me tell you a little bit about Brett. He's the president and CEO of the nonprofit Economic Alliance for Michigan, which is an organization comprised of businesses and unions working together for the continued growth of Michigan's economy by creating an atmosphere that inspires job growth and maintains competitiveness for attracting new companies and talent. Let's welcome Brett. Come on.
Good morning, everybody. Good morning, everybody. All right. So the first thing we're going to do is we're going to start off. I want you to get your apps out because we are going to do poll questions first. That's how we're going to get going. And I really want your participation because I want to I want to know what you're thinking. I'm Brett Jackson, as Cheryl said, and I very much appreciate the opportunity to talk to you today. We're going to talk a little bit about what's going on in Washington, D.C., and kind of what the policy landscape is around prescription drugs. But first, I want to know what your focus area is. If you could pick any of these three things in any order, what would your top three be? So you're not just necessarily picking 1, 2, or 3, but just of these things, what's the order that you're most concerned about? Or top 3 things? I will. I don't want them to see what everyone else is picking. Oh, it doesn't activate the question. Oh, yes, it does. See? There's people who already voted. We'll just give this another minute, and then I'm going to go forward. All right, I think we've aligned on price transparency, GLP-1s and metabolic therapies. Oh, and there's a tie. Let's see if the tie gets broken. Cell and gene therapies. I'm going to call it. Okay, price transparency, GLP-1, cell and gene therapies. This is important because we're going to reference this to something else. Okay, have any of you, ever been to DC and advocated on behalf of yourself or the organization you work for? Yes or no? Now, Rosa, don't answer because I know you've done it, because I've sat next to you. Few of you, couple. That's great. Okay, would you ever consider going to DC to advocate for policies that protect and improve employer-sponsored health benefit plans? Would you think about it? Really? That's what I'm asking. Yes. Hey, this is really good. I'm happy about that. Okay, if you would not consider advocating in DC, why not? Are you intimidated? Maybe you don't think you can get your travel approved. These days, that makes sense to me. My company would not approve of me meeting policymakers instead of their government relations folks. That also makes sense to me. Or is there something else? Okay, most people are thinking that, the company wouldn't approve of me meeting with policymakers. What is interesting about that, very quickly, is that your government relations folks are focused on lots of different things, and helping them understand how health benefit policy impacts the company and the company's bottom line, they would be shocked to find out how much money is involved in how important it is, and they actually would approve you to do it. Okay, last one. If you had a guide, let's just say you were coming with me, and you didn't have to do any heavy lifting, meaning we laid it all out for you. Would you go to DC? And it wouldn't have to be me, like someone from MBGH, because you're their members, not mine. Yes, that's a great answer. I really like that. Okay, so let's go back to the first poll. That same poll that I asked you, the very first question, was asked of 3 different groups at the National Alliance event in June, a couple weeks ago in Dallas. And all 3 of those groups said that PBM was the number one. Our number one was price transparency, which you can see was on the list of the employer and on the coalition leader and staff. The second was GLP-1s, right? GLP-1s was the top employer, or the second most employer thing in Dallas, was the number 2 here as well. And then the third was cell and gene therapy. And you can see that none of the 3 groups, whether they're industry, and NHLC is predominantly industry groups, and then you can see employers and what coalitions thought. I just wanted to see if yours were different, and they were, and that's perfectly fine. Okay, now let's get to the meat of the presentation. And by the way, I didn't get the memo. I'm sure the memo was sent to me about the Western theme. I just didn't see it. And in fact, I also didn't get the memo that I was going to be the only gentleman here with a tie on. Oh no, hey, there's my guy right there. Thank you for making me feel better. So the reason why I picked this particular picture to find out or to demonstrate what is going on is because if anyone comes to you or says something definitively about what they think is going to happen in Washington, D.C. this year, they are full of baloney. This baby has as much idea of what actually will happen as I do or anybody else. And so this quizzical look is a symbolism of that. So what didn't happen last year around pharmacy policy is that there was a bill that was about to pass. It was on the 1 yard line. And the night before there was going to be a vote on it, and the bill dealt with PBM reform that included these 4 parts of PBM reform. And the night before the vote was going to happen, Elon Musk tweeted something out that killed the bill completely. Totally. Had nothing to do with PBM. By the way, the tweet had nothing to do with PBMs. It had to do with how many pages there were in the bill. And of course, when you regulate something at the federal level, and especially when you regulate healthcare policy, each healthcare item has to be done in triplicate. There are 3 different acts in federal law that have to be amended. So for every page, there's going to be 3 pages, right? And so when you're talking about, it wasn't this, the bill had things to do with healthcare, it had transportation, immigration, that all sorts of stuff was in this bill. And it was thousands of pages. And Elon said, well, that's too much. You guys can't deal with that. And you shouldn't vote on it because you don't understand what's in it. And that killed it. But so otherwise, these 3 things would have passed the next day, or 4 things would have passed the next day. But because there was a bipartisan, bicameral agreement on these things, we expect them to still be in play, and potentially there could be a vehicle in September, I think is the earliest time this year, that we think that these things could still happen. So what's happening in DC right now? Well, there's a lot of whack-a-mole being played, and this is intentional. The administration, whose supporters had been planning this for the last 4 years, have put together a series of policies on everything, whether it's healthcare, as I said, immigration, transportation, energy, education, all of the things that federal government can touch. They have been writing what the federal government should do, putting it in a drawer, and waiting for President Trump to get reelected. And then, as needed, they pull out a policy in a cadence that is likely planned to flood, and they're literally flooding the zone. So instead of the whack-a-mole board being looked like this, it looks more like this, and actually probably like 100 times this size. This is, like I said, very intentional, because if their opponents are being kept on the backs of their feet, the Trump administration is setting the agenda, and their opponents are having to react to everything that they do. So the president has done, specific to drug policy, 4 different executive orders. And I want to talk about what an executive order is before I go into the specifics. Executive orders are directives to the federal government, to different parts of the administration, to do things. They do, by themselves, do not have the force of law. Now, if the president is telling someone in the administration to do it, they better darn do it, right? And they would have a significant impact on the country. So if the president's executive order said for them to completely shut down a border, well, the federal government controls the borders would be shut down. So while it doesn't by itself have the impact of law, obviously in that particular case, it would. When we talk about executive orders, they're, again, and when we talk about prescription drugs, they're telling HHS and CMS to do certain things. The question is, does CMS and HHS have the legal authority to follow through with the things they're being directed to do? So let's talk through the four items that you see in front of you. So in April, the president directed CMS to, through the Congress mandated Medicare drug prescription negotiating program, to lower prescription drug prices for seniors. That is something that Congress did pass, and they're going to take advantage of to try to do that. The programming would include measures to align the payment of the cost of drugs with hospitals and provide discounts to low income patients for certain medications like insulin and epinephrine. The president also emphasized that the drug transparency requirements that actually he put in place in his last administration needed to be fully implemented. On May 5th, he put out an executive order encouraging domestic pharmaceutical manufacturing, so making it easier for plants to be built, for regulations to be set aside for new drug manufacturing to take place. And that's across the spectrum. It could be generic drugs, it could be specialty. Every single thing is on the table, and he wants it to make it easier for the United States to be able to manufacture any drug in the country. I would say the more controversial are going to be the last two. And that is a most favored nation drug policy. Most favored nation means if it's priced a certain price over here, we want that same price in this country. And he's directing HHS and CMS to do that. Where I think HHS and CMS have the authority to do that today is, well, Medicare sets payment rates, right? For what Medicare can pay for drugs. And so they could take a very draconian approach to what Medicare can reimburse for drugs, even probably to Medicaid. What they could not do, though, what is called out for specifically in the executive order, is for anyone to buy drugs at a most favored nation price. Even, as the second bullet point says, direct to consumer. So any one of us could go to any drug company and say, hey, we want to buy directly from you, and we want the same price that Canada or Germany or France or whoever buys. Cutting out potentially all of the middlemen that have, that work in the United States. And that could be, I'm not just talking about PBMs, it could be hospitals, right? It could be that you buy a drug and then take it to the hospital. What I don't believe there is authority to do is for all of those things to apply to us. I think Medicare can set reimbursement rates. I think Medicare can set what the cost share is for patients that are in the Medicare or Medicaid program. What I do not think they have the ability to do is transfer it to private health insurance. So I'm going to talk a little bit about 340B, and I know this is controversial, and there is likely a hospital in the room. I want to first say that no one through the National Alliance or any of our coalitions are talking about getting rid of 340B. That's absolutely absurd. What we want to see happen is we want the program to work as it was originally intended, to help those providers who are serving an underserved population or a rural population to be able to have certain benefits or discounts, in this particular case, on drugs, to make the dollars that they're getting go further. So that's what we hope is happen, or what we hope to happen by any PBM reform. Right now, the 340B program is the second largest drug purchasing program the federal government has. It's a $66 billion program. It's costing employers, and this is why you should care, It's costing employers $36 billion more than if the 340B program didn't exist. So what I'm saying is there are 340B hospitals, there are non-340B hospitals. From what you are paying in extra markups at 340B hospitals, and that they're prescribing higher cost drugs, and because you're not getting rebates on drugs through the 340B program, employers are paying $36 billion more than they otherwise would. So commercial, as it says, commercial prices are 20% higher for common outpatient procedures at 340B hospitals than they are at non-340B hospitals. And here's the rebates. Employers are losing $6.6 billion in rebates that would have otherwise come to you through your PBMs if they weren't going through 340B channel instead of your PBM channel. And for public employers, like there's at least one school district in the room, they're losing out on $1 billion of rebates. Humira, you can see the drug markup. They get to buy Humira for a penny through the 340B program. The average amount that insurance is paying for Humira is $6,900 through 340B hospitals. There's a hospital in my state. We just released a report on this a couple weeks ago that's charging, and it's not just one hospital, there's several, that are charging between $10,000 and $15,000 for Humira. So obviously the hospitals are making a tremendous amount of spread on that. So we are going to go to Washington and talk about this and see if Washington can get engaged on 340B. Senator Cassidy, he's the chair of the Senate Help Committee. He's from Louisiana. The Help Committee is a very powerful committee that deals with healthcare, labor, employment, and pension issues. And they just released a report on 340B. I'm just going to give you one factoid from that report. The Cleveland Clinic has a net revenue from just 340B of $1 billion over a 3-year period. That's how much money is involved in this program. That's net revenue above what they would otherwise have if they did not have 340B. And we're just buying drugs at a normal price and selling it to consumers like us for just regular market rates. So why is advocacy important? Our members have asked the Economic Alliance for Michigan to engage in advocacy since our inception in 1982. It's been part of the fabric of what we do. And so obviously our members are very comfortable with us engaging in advocacy and participate in that. It's important because often when you have these policy discussions in Washington or in the state capitol, there's only a couple people in the room. There could be insurance companies, there could be providers, there could be other people in the healthcare delivery system. What is typically missing in the discussion is your perspective. That's why it's so incredibly important for you to be engaged. And okay, listen, I get that a individual company or entity doesn't want to be the face of an advocacy. I get that. That's why you're members of MBGH, right? Because collectively, you can tell MBGH, hey, we want you to go do this. We want you to be the face of employers and purchasers in Springfield or in Washington, D.C. And you can, I don't mean this in a negative way, you can hide behind the coalition, right? Because you can do it together instead of doing it separately. And together, you're going to be stronger. I absolutely promise you can do that. And as I said earlier, health benefits are incredibly expensive, right? They're absolutely impacting the bottom line of each one of your companies and entities. And if you communicate to your government affairs officials and to your C-suite about how much a particular policy issue is going to impact your company, I guarantee they're going to be with you. And they're going to want you to speak, or they're going to ask you for the information so that they can go and advocate on the company's behalf. So now that you've heard a little bit more, whole question again. And if you had MBGH or me or any of the coalition folks on your side, Sean, my colleague who runs the National Alliance, if we were with you and we did the heavy lifting and we asked you to do one thing, and that's not to talk about the ins and outs of Bill A or Bill B or what the policy does, what we ask you is, can you tell your story about how something is impacting you? If you could just tell your story, would you feel comfortable going to Washington, D.C. and doing it? Let's see what the answer to the poll question is. Overwhelming yes. I really appreciate that you guys would be willing to do that. And so I'm going to give you an opportunity to do it. So on July 23rd, we're going to go to the Hill. Coalitions around the country and the employers and other purchasers who are members. We're flying in, really, we're going in on the 22nd. We're going to have a really nice dinner, and then we're going to go to the Hill on the 23rd. We will pay for your hotel. We will pay for your travel to get to DC and back. And so we want to talk about hospital and health plan transparency and accountability. We're going to talk about 340B reform, what I talked about just a few minutes ago, and the PBM reform, the 4 bullet points that I shared earlier in the presentation. If you are interested, talk to Cheryl or any of the staff members at MBGH. They will get you set up. We would love to have you. And is there any questions about anything that I said? This was the hardest speech I've had to give because I'm not used to being tied to a lectern like this. I like walking around, but I know that there's people watching online, so I knew that if I just stood here, then they could see me. That's why I did it.
Okay, so as both an employer and the person in charge of our plan and a 340B covered entity, I want to ask you a question about 340B.
Sure.
Because we are a hemophilia treatment center, so we're original covered entity. We have a point of working with employers directly to save funds using the 340B program. Have you considered, when you look at 340B reform, looking at value-based agreements, working directly with covered entities? I'm not going to say there are not bad players in 340B. There absolutely are. But the original covered entities who have that transparency, who are serving those underserved populations, there is a very real way to work directly with employers to save money. We've worked directly with a number of large employers in our area. We serve the entire state of Illinois. And we've seen considerable savings with those employers by working through those value-based agreements. So have you considered that when you look at that advocacy piece?
So I need to ask a clarifying question. So are you saying that you buy the drugs at a discount and you're passing on some portion of that discount to employers?
Absolutely.
Okay. While that sounds appealing, that is not what the program was intended to do. The program was intended that you buy drugs at a discount, that Medicare reimburses you for the drugs at the full Medicare rate, and that you actually get to keep the money between the discount and be able to use that money to take care of a patient population and say and help those people. Passing on the discounts to employers would, again, while it sounds great, and I think some of the other policies the administration is working on have the goal of helping employers buy drugs for a lower cost. I don't think the 340B program is really intended to be used in that way.
I would argue that it is because it lowers the cost for the patients as well, because their copays are based on a percentage of what the insurance is paying.
I totally agree, and that's why we have been pushing for Congress to lower drug prices on employer-sponsored health plans to lower the cost of the copays, coinsurances for Americans at large. Cheryl, I know we're.
Let's thank Brett. And I would agree with Brett. I'm surprised to hear from a very large nonprofit like a coalition that they were going to get drugs at 340B pricing for the employers. But the problem is it doesn't fix the problem. Brett, where are you? Way in the back. Your outlaw. Brett and his friends were snowshoeing in Colorado and stumbled into a military reservation by accident. They were escorted out by military police and questioned thoroughly. In the end, it was all okay. Well done. We actually have a 340B resource that I'll be sharing a little bit about. There's 4 or 5 things that employers can do about this. So I'll share what those 4 or 5 things are. But if you don't know about the 340B program, look at what he shared, go online, understand it. This is serious business. Again, the second highest cost behind Medicare Part D. So now we are going to move forward for a word from one of our sponsors, Walrus Health.
My Walrus pharmacist found the issues with my medications right away. She helped me figure out what wasn't working and stuck with me over the months to help me stay on track. One time, Dr. Tiffany, my pharmacist at Walrus, she sent me a message asking if I was feeling tired during the day and mentioned it might be from one of my medications. I had actually been feeling tired at work for months. She had me start taking one of my medications in the afternoon, and we started tracking my fatigue together right in the Walrus app to see if the change worked. It actually did. Another time, I had stopped taking my cholesterol medication. It was just too expensive and it wasn't covered. Dr. Tiffany found one that was covered. She worked right with my doctor to get it sent to my pharmacy, and it was hundreds of dollars less. I'm so thankful that my employer made this program available.
Thank you, guys. That would give us the opportunity, because if I, as a 501c3, we're only allowed to send one piece of paper to the state or the federal government once a year versus being able to talk to people in a room and say, this is the real problem and we're representing employers. So more to come on that. Let me introduce our next speaker, Matthew Madaferi. Hey, Matt, did I say that correctly? Madaferi. I never would have guessed that, so sorry about that. Madaferi is a seasoned trial attorney and partner at Fryer Lovett, focusing on complex healthcare and life sciences litigation. He is a former assistant U.S. attorney, represents medical providers, pharmacies, labs, health systems, and plan sponsors in civil litigation, government investigations, ERISA disputes, and False Claims Act matters. You've probably met his colleague, Jonathan Levitt, a number of times. Jonathan couldn't make it, and he said, Matt's your guy. And Matt is also going to share some great resources and talk a little bit about what's going on in the market. Come on up, Matthew. Well, Matthew's coming up there. Here's his wild and outlaw thing. He bungee jumped and skydived in the same day. Are you insurable? I don't know. Come on up. Thank you.
So I have my notes here, but let's see if I can.
What do you need?
No, just a place to hide my notes. Good morning, everyone. As Cheryl said, my name is Matt Madaferi, although if you look at the outlaw name generator sheet, my name is Shaky Rawhide. I don't know how I feel about that, but this is my first time here speaking at MBGH, so respectfully, if you can hold your tomato hurling till the end, I'd appreciate that. So I want to get my PowerPoint up here. There we go. I have one goal for my presentation today, and that is if you can walk away with even one tip or one tidbit of information that helps you in your role as a fiduciary, then I consider my presentation here today a success. Oh, I think it's leaning on there we go. Thank you. So as Cheryl said, I'm an attorney, and obviously as an attorney, we have to put up a disclaimer. So essentially, this is for informational purposes only. This is not legal advice. One other thing that Cheryl mentioned in my bio is, in addition to some of the entities that we represent, we also represent some 340B covered entities. And we also, a lot of what I'm going to say here today might seem anti-PBM. We're not anti-PBM. We are pro-transparent PBM. Rightway, who's in the room, is actually one of my clients. So Rightway, good to see you. Tell Frank T I said hello. Okay. So learning objectives, right? What I want to do is talk about some contract terms that you'll see in a pharmacy benefit services agreement. Maybe some of the hidden losses, ways that you can negotiate a better agreement with your PBM. Audits, I use the term meaningful audit. You're probably saying, what does that mean? And I'll get into that. But meaningful audits are the key, not just audits, but meaningful ones. I'll share some common issues and some war stories that hopefully you can glean some information from. And then finally, we'll finish with just some action items. So first and foremost, right, if you have a PBM, you're an employer plan, you should know the vertical integration of that entity, right? You may have, your contract is with United Health or UMR or Aetna or Cigna, but understanding the subsidiaries and affiliates of those entities is critical, right? So if you are, your contract is signed with UMR, right? You should know, right, that Optum is the PBM. You should know that MSR is the rebate aggregator. And you should know that your specialty drugs are probably being filled through Optum Specialty Pharmacy. And the same thing is true if you're in any of the other columns. By a show of hands, I know this room is not filled with all, employer plans or plan sponsors or HR benefit folks. But for those that are here, who by a show of hands actually knows who the rebate aggregator is for your pharmacy benefit plan? Okay, some hands. How about the specialty pharmacy that handles? Okay, good. If you didn't know and you don't know, I suggest you find out or speak to counsel that can kind of help you to learn what's going on behind the scene. Okay. So moving on to those contract terms and hidden losses. The first term that I want to focus on is when the contract talks about specialty drugs, and in particular, specialty generics. It's almost like an oxymoron, right? Like jumbo shrimp. Specialty generics. I don't know what's so special about a generic, but we're going to see how some of the larger PBMs handle that. That definition, right, unless you've actively negotiated it, you're at the mercy of the definition of the PBM, right? Some PBMs will call a specialty list whatever they want, and they'll attach to your pharmacy benefit services agreement their list of specialty drugs. So you'll be able to see what they consider specialty. And again, beware, they do throw generics into that specialty bucket. And why is that important? Because some contracts will say that all specialty drug claims have to be filled through their specialty pharmacy. So essentially they get to pay themselves when you fill those specialty claims through their specialty pharmacy. The next few slides are publicly available. These are snippets from the FTC's interim and final reports on the big three PBMs. The first slide that we're looking at here is just a heat map of the percentage markups on specialty generic drugs, right? So the sort of the light blue color there is the markup over NADAC, your national average drug acquisition cost. That's basically what plans should be paying for these drugs, right? And I think the PBMs even purchase these drugs below NADAC. So if you're at or around NADAC, there's still a small profit margin for these PBMs. But just look at this, right? So for some of these drugs, these specialty generics, on the sort of all the way to the far right, you have the Medicare markup, and to the left of that, you have the commercial markup. Medicare is slightly better, but for example, if we look at imatinib, which is an oncology specialty generic, third from the bottom, right? The markup in 2022 to Medicare was over 4,000% higher than NADAC. If you look at commercial 2022, it's 5,200% above NADAC, right? So again, this is publicly available information, right? Again, another chart, again, publicly available, created by the FTC. Now, I looked at imatinib on the chart before, so that's B on the right. And there's another specialty generic there, abiraterone on the left. And if you look, these are the costs that a plan would pay if filled by a pharmacy that is not affiliated, so the unaffiliated column there, with a PBM versus an affiliated pharmacy. And what you see, so we have NADAC all the way to the left, right? Those values are pretty small. And then for commercial payers, right, for abiraterone, we're looking at, about, you're paying around $2,000, $3,000 for if it were filled at an unaffiliated specialty pharmacy. But if it's an affiliated pharmacy, you're paying almost double that amount. And compare that to NADAC, right? And it's the same is true for imatinib on the other side. A huge markup over NADAC. Again, this is just another way of looking at the last slide. You can see sort of the NADAC cost for the two drugs, that's in green. And then the prices that, or sort of the extra revenue in excess of NADAC if filled at an affiliated pharmacy. Again, this is all public information. And why do I say it? Because if it's public information and you're a plan sponsor or a pharmacy benefit, a HR benefit manager, you should be aware of this, right? You should know what your plan, your members are paying for these types of drugs. Okay, here's another example. On this one, the drug that we're showing here is teriflunomide, right? So if you look at the bottom, if you were to just buy this cash, right, from Mark Cuban's Cost Plus, it's $28, right? But and if you had the Johnson & Johnson plan, again, it's not, I'm not singling out Johnson & Johnson's, pretty much every plan that uses one of the big threes, you're paying around $10,000 for that drug. So again, why am I bringing this up? It's because, the hope is that there's, you will look at this and strengthen your fiduciary duties to your members, right? And then the little key takeaway box there, right? The fiduciary duty of prudence requires that I manage my formulary. Am I allowing the PBM to charge the plan 300 times the retail price, right? Is that in the best interest of the plan's members? Okay, so we talked a little bit about one key area, right? Specialty drugs, specialty generics. Another key area to look at is rebates, right? How is rebate defined in your pharmacy benefit services agreement? Are there carve-outs? Where the contract says we pass through 100% of rebates received, 100% of rebates, who receives, right? Think back to that vertical integration chart. When those rebates are getting passed from one player to the next, you might only be getting the rebates received by the last player in the game of hot potato. So just keep that in mind. What does the contract say about rebate aggregators? What does the contract say about the fees that they make in their role in rebates? Right. So this is just an example that I prepared. 100% of rebates administrator receives. Again, this is public information. This comes from the FTC. And what the FTC has said about the use of rebate aggregators is that the big three, now through GPO respondents, those are the aggregators, they take administrative fees from drug manufacturers as part of commercial rebate negotiations. And then moving down to the next paragraph, because administrative fees are typically calculated as a percentage of WAC, the wholesale acquisition cost, the PBMs and GPOs collect higher fees on a drug with a higher WAC than a drug with a lower WAC, even though they're performing the same service, right? Why is that important? You probably pay a per member per month administrative fee for your pharmacy benefit services, right? That is a flat fee. This fee is not a flat fee, right? It's a percentage of WAC. So the higher the WAC, the higher the drug cost, the more the PBM or the GPO or both are taking for the same exact service. Okay. The third contract term to just bring to your attention is spread pricing, right? An example of that might be administrator may retain the difference between what administrator reimburses the network pharmacy and customer's payment for a prescription drug, right? That right there is saying we are taking a spread on your drug claims. Random war story. I represent a hospital system, and hospital systems are sometimes unique in the fact that they have a plan and they also have a pharmacy. So what you can do is say, okay, client, that's great. Can you give me all the data from your plan and give me all the data from your pharmacy? And I can match them up. And right, so if the contract says all claims that were submitted through your affiliated pharmacy and paid for by your plan, there will be no spread. It'll be 100% pass through. I cannot tell, well, I think I'm batting a 1,000. Every single time I looked at those two metrics, there is a spread, right? And that's a unique time where you can go back to the PBM and say, wait a second, the contract says no spread, but now I actually have the data, right? Which is a rarity, and I see spread, right? So there's that unique time where there's a gotcha moment. But again, just for purposes of your fiduciary obligations, the third key item or term is spread pricing. Okay. I don't know how I'm doing on time. Oh, okay, excellent. So again, why am I mentioning all of this? It's because that goal that I talked about at the beginning. We want to work with you, want to work with plans in meeting your fiduciary duties, not breaching them. So here are some things that you can do. You can put out an RFP, right? Select a new PBM. You can negotiate or renegotiate your contract. You can do audits, right? So there are things that you can do to meet your fiduciary obligations. Right, so this is just a continuation. Again, not to pick on J&J and their lawsuit, but the lawyers on the other side of that matter put together, a paragraph on what they feel prudent fiduciaries can do. Right, so again, key takeaways: fiduciary duty of prudence requires RFPs, even market checks, finding a PBM that fits your plan and your members' needs, audit rebates, right? That's a great idea. Audit your rebates, audit your claims. Negotiate the contract so that you have more audit rights, that you have the ability to get involved in some of these terms that the PBM contracts include. So you're probably thinking like, Matt, yeah, that sounds all, good and fine in the abstract, but in practice, how do I conduct a meaningful audit? How do I obtain the data? I tried and they say, no, it's proprietary and you're not allowed to look at it. And that happens. That is, hopefully we can get more legislative reform but also it starts with that contract, right? So if you can negotiate the ability to conduct meaningful audits and have access to the data, that's a great first step. Again, just, second bullet point there, the contract tends to limit audits, even though the Consolidated Appropriations Act would be contrary to that, right? So that's another tool that you can use to ask for a meaningful audit. Like, yes, your contract says one thing, but the law says another. Some plans might say, but yeah, I already use an auditor. I'm good, right? Not always the case, right? One thing that we would recommend is, to do a little research on the auditor, right? Oftentimes auditors have to be pre-approved by the PBM. Make sure that, you are using someone that you trust or an entity that you trust, and that the audit is conducted in the plan's best interest. I'll actually share a war story on that. We have a client where they wanted Friar Levitt to conduct their audit. So we said, that's fine. We do audits all the time. We reached out to the PBM and we said, we would like to conduct an audit on behalf of this client. And one of the PBMs came back and said, no, we don't agree. We don't approve of Friar Levitt as an auditor. So I picked up the phone and I said, why? Why not? Because you guys will advocate for the client. I said, isn't that the point? So you just want somebody that's just going to look at stuff and say, yeah, everything looks good here and move on. And they had no response. There was literally no response to my question, my rhetorical question, isn't that the point? Again, so this is just another slide that outlines some of I'm not saying every audit is incomplete or improper, but there are issues, right? So some auditors have relationships with PBMs, right? They get to say who the auditor is. So just be careful about that. Auditors are often subject to the contract, right? So they'll say, oh yeah, my contract allows me to conduct an audit and my auditors have already conducted an audit. I said, okay, great. Can we take a look? And we look and it's like, wait a second, your audit was limited to 50 claims? You have millions of claims. So your audit only was 50 claims. And they're, oh, I didn't know. Right. So really just kind of review and take a look at not only what your contract says, but what your audits, how they were conducted and what they've shown. Because again, this all reverts back to that fiduciary obligation that you have, right? You owe it to your employees to conduct a meaningful audit. Right. One other, these are stories that were personal to me. I asked on behalf of the plan for the plan's own data, right? And we want to conduct an audit. We want to meet our obligations, our fiduciary duties. PBM responds, all right, we'll get back to you. Completely ghost you, right? So then you have to follow up. We're looking into who owns this data. PBM never responds again, right? So then we bring in arbitration for the data, right? We say you breached ERISA, we are entitled to our own data, right? How crazy that sounds. And And then the PBM says that the plan is not entitled to its own data as per the contract, right? But you can conduct that audit that's set forth in that agreement. And by the way, that's only for claims, right? Anything having to do with rebates, you're not entitled to any of that either. And long story short, the arbitrator granted us the ability to look at both. But the point here is, hearkening back to my example with the hospital system, where there's a unique opportunity to look at both ends of the equation. That's what they're trying to do. They're hiding the data because they operate and profit off the lack of transparency. A lot of what I'm saying here today, again, through the FTC, it's public. I should not be stating anything that's new and unknown. But it's also not unique to commercial plans, right? Here's an example of an audit conducted by the government into a government plan, right? And the results were the same. The government found that there were overcharges to the health plan, many millions of dollars, right? And also there were rebates that were retained. So again, we saw the chart in the markup for Medicare, right? So again, it's a little worse on the commercial side. Same thing here. The same issues that we see and we find on behalf of commercial plans also happening to the government. Right? So this is just another slide that details some of the findings in that particular OPM audit. Right? That percentage down there might seem small, right? 4%. Before, but the way that's supposed to operate in practice, right? That the PBM's compensation must be reasonable. And they also must disclose their sources of direct and indirect compensation. What does the CAA mean for plan sponsors, right? It means you should have the ability to audit. And we'll see on the next slide, the CAA also requires that PBMs provide de-identified data. So demand access to the data, you're entitled to it, and audit. Again, this slide, again, just covers what I had said earlier, and I'm apologies for going a little fast here at the end. I want to just leave a little time for Q&A. But yeah, here, access to claims data. ERISA prevents plans from contracting with entities like PBM if the PBM contract directly or indirectly restricts the plan from electronically accessing de-identified claims data. These are known as the gag clauses that are not permissible under the CAA. So again, how do you conduct a meaningful audit? How do you meet those obligations? Get your data, conduct your audits. There are other things that I had mentioned as well, but so before I wrap up and see if there are any questions, there's one more thing. I didn't include it in the presentation, but it's available. We have a fiduciary duty self-assessment. It's like 40 questions or so. Yes, no, I don't know. That self-assessment is on the Employee Connect and the app. And I just ask if you have a few minutes, just take a look at it, answer some of the questions. Because if your answers are no or I don't know, then you're really vulnerable to some of these, potential fiduciary duty employee lawsuits. And we can help with that. We can help with, making sure that you're doing everything that you possibly can to meet those obligations. So with that, we're open to continuing the conversation, whether it's via email, phone, in person. And, to the extent that there are any questions, I've managed to save 3 minutes.
That was excellent. Thank you so much.
You're welcome.
We have a couple minutes for questions, but I want to thank Matt for working on that fiduciary checklist. We've seen several iterations of it over the years, from just, bullet points to actual questions that you've got to ask yourself. And I use the F word a lot, and that's fiduciary. And it's important that you look at that checklist, because there may be things in it that you think you're taking care of and you're not. So thank you for making that available. I also wanted to mention that my colleague Cora Upsahi, who is with 32BJ, which is a union based on, I think, state workers in the state of New York, she has created a medical contract for when you're contracting for medical benefits, and she's right in the middle of doing one for pharmacy benefits. And when she does that, I'm going to have an employer webinar on that. And then just a quick reminder that all of the slides from today are on the app, including the fiduciary checklist, I believe. Otherwise, for members, it's also on Employer Connect. Any questions for Matt?
Cheryl, I'm just going to add for the group, if you're looking for those slides and the checklist on the app, it's under agenda. So it's that top red card, right card.
Anything Matt said that you don't agree with, remember, he is an attorney, so.
I get that all the time.
But I know him enough after last evening that, you'd want to have a robust discussion if someone didn't agree with you. Anyone have a question or a comment? Okay, let's thank Matt again.
Thank you, everyone.
Okay. I'm going to introduce our next speaker, and then I'm just going to tell you a small story about what I learned when I first saw him present. Drew Wilkins is a managing director at Deloitte's commercial strategy practice. In this role, he helps clients solve the strategic challenges associated with growth, innovation, and ecosystem disruption. He also leads their efforts related to innovative financing models for advanced and emerging therapies, including cell and gene therapies. His recent work includes designing a novel supplemental risk pool to spread out the cost of gene therapies across multiple payers. We're going to be hearing today more about this access landscape and innovative financing models. So my story. Let me tell them. Do you have a? I believe you have a Wild Wild West. I don't even see it here, but maybe I have my pages misordered. Let me just get to the story, though. Last year, I was at the IBI Integrated Benefits Institute conference in Chicago, and I saw you present. And this person was speaking about the same things that MBGH has been working on, this person, Drew, for years. How the heck are employers going to pay for high-cost therapies? What are the models going to look like? And he was talking about a multi-employer risk pool, which is what we were talking about, which we are still talking about it. But going down that path, we recognize that employers really needed a tremendous amount of education for them to understand the direction that things were going. And the number one most important thing to us was making sure that the vendor community or the vendor partner community or whoever you want to talk about it is not bringing solutions to you that don't work and that also only benefit them. So Drew, I approached Drew. We got together earlier this year. He's got more information to share. It aligns very, very well with the work that we're doing on this project. And I am excited to have him share his story. Welcome, Drew.
That wasn't the story I thought you were going to tell, but we can save that for later, Cheryl. Thank you so much. Thank you so much for the warm welcome. I've never seen my face on a wanted poster before, and I think there are a lot of people that may want that. So thank you for having me. I really do appreciate it. As Cheryl mentioned, my name is Drew Wilkins. I'm a managing director at Deloitte. I spend all of my time really focused on access and affordability. and the impact that that has on patients. And that can be, as we think about high-cost drugs, all the way through to as we think about things like health equity. So I'm not a lawyer, but just like Matt, I have my own set of disclaimers here. So Matt, I was taking notes. Mine looks remarkably similar. I wonder if you actually wrote this for our firm, but we'll move beyond that. So I thought I'd talk about a few things today. First of all, I thought I'd zoom way out from where Matt was. And I thought his presentation was fantastic, but I want to take a higher level view. I want to talk about how the innovation ecosystem is changing. I want to talk about how the access landscape is changing. And I want to talk about how that's creating some challenges. Those are challenges for people in this room, but they're challenges for all of us. They're challenges for patients as they try to access these really amazing therapies that are coming to market. And as Cheryl mentioned, I've spent a lot of time thinking about solutions to some of those problems. And so I want to throw out some of those ideas. They're very similar to the ideas, Cheryl, and that you would have seen at IBI and elsewhere. And so others in this room may have seen some of these in the past. But then I'd be remiss if I didn't end with, what do you actually go do? What might you consider doing based on where you sit today, and how is this landscape starting to change? So over the last 10 years, biopharmaceutical companies have introduced some really amazing therapies. And these therapies are growing. We're seeing more and more of these amazing drugs come to market, and these are changing the lives of patients and members. So of the drugs last year, 2024, that came to market, more than half had an orphan indication, meaning that they were for very small populations and populations that needed these breakthroughs. And over a third of them were designated as breakthroughs. And these breakthroughs mean there's no good standard of care for these patients. It's an opportunity for us to bring drugs to market that are going to profoundly impact the lives of members and the lives of patients. Let's take cancer as an example. If you look at cancer death rates over the last 35 years, they've declined by almost a third. And of the gains that we attribute to that, almost 3/4 of them have to do with treatment advances, including the medications we're bringing to market. If you look at overall survival across many different cancer indications, they're amazing. If you look at where we were in 1980 to where we are today, you look at things like prostate cancer. If a man was diagnosed with prostate cancer in 1980, he had about a 40% chance of making it 5 years. That number is now close to 90%. That is an amazing scientific gain that directly impacts people in this room, people in our communities. We see the similar types of gains in breast cancer and myeloma and leukemia, et cetera. We are changing the way diseases are thought about, and we're changing the way we're able to take care of people in our communities. So while we have seen those gains over the last 30 whatever years, the pipeline is even brighter as we look forward. And so you see a lot of the therapeutic gains, a lot of the different technologies, the scientific gains that we brought forward over the last 30, 40 years. And then you look forward to where we're going and where the science is going to take us, and the future is very bright. And I think about my grandmother, who in the mid-80s died of lung cancer. And if she had had access to the types of therapies that you see on the board today, her prognosis would have been much, much different. So it's a very personal story for me, but for all of us as well. At the same time, we're seeing our biopharmaceutical companies be challenged. Now, nobody says that biopharmaceutical companies aren't profitable. That's not where this is going. But we are seeing them being challenged. So we all talk about how drug prices are going up, and they are. But we're also seeing while list prices are going up, the net prices that biopharma companies are realizing are actually decreasing. That means biopharmaceutical companies are putting more and more into that rebate bucket that we just talked about. And that's impacting their net sales, and that's impacting their ability to reinvest. And I think people in this room probably know, but it takes close to $2.3 billion to bring a drug to market. And the probability of success for an asset entering the discovery phase all the way through to launch is about 10%. So this is a highly risky business, and it's a highly capital-intensive business to bring these drugs to market. The numbers on the right-hand side of the slide show 15 different biopharmaceutical companies and the amount of rebate and other discretionary funds they put back into the ecosystem. So 70% of the list price goes back into the ecosystem for company number one on that list. So these create distortions. It changes the incentives that we think about. It changes the decisions that are made from the plan side, from the physician side, from the patient side, and it challenges the innovation. And these distortions come from several different things. Some of them come from things like new to market blocks. It takes longer to get the product into the market and get uptake for that product. As you move through the product, companies are expected to pay more and more in rebates. You see things like price controls. However, it fundamentally impacts the patient as well. So a lot of the patient out-of-pockets are set on that list price, even though that net price is what is actually being paid. So let's look forward. Going back about 4 or 5 years, about 40% of the new launches were for, call it specialty therapies. If you go forward 2 or 3 years into 2028, we estimate about 55% will be for specialty indications. That tells us that our drugs are getting more complicated, they're getting more costly, and they're getting harder to get into a patient. At the same time, prices are going up, and the median price for drug launches has increased by about 40% on a compound annual basis. So what do these pricing distortions mean for all of us in this room, regardless of what chair you sit in? And what are the impacts that they create? The first is there's a fundamental misalignment of the cost of a therapy and the timing of when that therapy, the benefit of that therapy is realized. So take a GLP-1, for example. We all talk about Mounjaro and Wegovy and the obesity drugs. If you administer those today to a member, you're going to have a cash outlay. They're not cheap. But the benefit that that patient will see will manifest over the next 2, 3, 5 years. We're talking about prevention of diabetes. We're talking about prevention of cardiovascular issues. And so there's a fundamental misalignment of when those things are administered and when that benefit is received. There's also an issue related to the predictability of claims. And we'll talk about cell and gene therapy in a few minutes here. But when we talk about cell and gene therapy, we're talking about really lightning strike claims. These are things you can't predict. They strike suddenly, and then they move on. And that predictability makes budgeting really, really hard. And then the other side of that is the third issue, which is the magnitude of the cost. And we talk about drug prices rising. Cell and gene therapies are a prime example of that. These are highly expensive drugs, highly expensive treatments. And going back to the first point, they're misaligned with the timing. And so if you have a cell or a gene therapy claim show up, the outlay from a cost standpoint for the drug alone, let alone the administration of that drug, is anywhere from, $500,000 to $3 million for one patient for one claim. But it's a one-time cost. And a one-time cost that then leads to essentially, we can't prove it out yet, but essentially a cure. And so again, you're manifesting it over many, many years. So the unpredictability of that claim, the magnitude of that claim is creating a problem. And then the fourth is around the knowledge gaps that exist in our system. There are knowledge gaps among all of our members and patients. They don't understand their care. They don't understand how to navigate the system. They don't understand the financing side of things and how to pay for drugs. But they also have knowledge about their own self and their own care that you don't have. And so there are knowledge gaps that are multifaceted in this space. All right, so I started talking about cell and gene therapy. I kind of jumped the gun here a little bit. What is a cell and gene therapy? In the simplest form, and these are not simple, but in the simplest form, this is modifying a cell or the expression of a gene in a cell to drive a therapeutic effect. It could also be things like using a living cell to administer a therapeutic effect. So we'll focus on gene therapies and cell therapies for the rest of our presentation, knowing that there are other very specialized types of drugs out there as well. So why are they so complex? In many cases, not all, but many cases, cell and gene therapies are customized to you. You are an N of one. You go, you receive, they take cells out of your body, they manufacture them, and they put them back in your body. That means they're very complicated to develop, but they're also very complex to administer. You can imagine the logistical expertise alone that is required for these types of drugs. Because we are taking cells out of your body, shipping them to a manufacturing site, shipping them back and putting back into you, think about the chain of custody that has to happen. Think about the logistics. Think about the quality that has to go into a product like that. It is exceedingly complicated. So despite these challenges, they really offer amazing potential. And we sometimes talk about the beacon of hope that these have created, or the triumph of innovation that exists as a result of these. The first is, in many of these areas, we'll show you some of the pipeline and some of the indications in a minute, but in many of these indications, these are drugs for which no other treatment exists. These are patients who otherwise will die or experience ongoing care, but never quite reach back to the potential. These drugs have a demonstrated ability to slow or halt the disease progression. Again, they're not curative because we don't have the long-term data to demonstrate that, but all signs point towards essentially a curative therapy. We talked about the misalignment of cost versus the outcome, and that's the third question here. These reduce the long-term burden of care. And it's a one-time therapy, meaning you never have to treat that disease. In many cases, you never have to treat that disease for that patient ever again. And so we're reducing that ongoing cost burden. And then importantly, we're improving the lives of these patients. We're reducing the caregiver burden. We're allowing them to be productive members of society. And we're reducing their pain and suffering. So I know this is an eye chart. It's in your slide packet. But over the last 5 years, we've seen nearly 30 approvals for cell and gene therapies. Most of these are highly specialized, rare diseases, things like spinal muscular atrophy and other such diseases. You've probably read in the press about things like hemophilia or sickle cell. Those are probably the more common diseases that you see on this chart up here, multiple myeloma as well. We believe that over the next 3 years, we'll see about 2 times as many of these therapies approved. And so there is a wave of these that is coming. Some of those will be for rare diseases. But if you read the news coming out of the American Diabetes Association conference this week, there are trials going on for things like type 1 diabetes. And so while that is incredibly exciting for that patient population, that's clearly a much broader, more common disease than some of the things we look at here. And so we need to figure out, how are we going to think about these as a society? How are we going to value them? And then how are we going to cover them? So I often get asked, how likely am I to experience one of these claims? And so we did some modeling, and this is probably a year or two old now, but we did some modeling thinking about, by 2029, how likely would each of you who own plans in this room, how likely would each of you be to see one of these claims? And depending on the size of the company, we see that it's somewhere between 25 and 55% chance that you will receive at least one claim for a cell or a gene therapy. I was talking with a large employer yesterday, and he told me that they had 2 or 3 last year. And so they're starting, he's much bigger than this 20,000 employees. We're starting to see these claims pop up. We're also starting to have a conversation around how to cover them. And the way that we've covered them so far has really been through things like stop-loss insurance. But there's a real concern about, will stop-loss insurance be able to cover them when we get back to this chart and we talk about, an additional 60 or however many in the next several years. So why is it a problem to cover these? And I'm sure you all are aware of this, but why is it a problem? Our system was not set up to cover a one-time, highly expensive therapy. Our system was set up to cover chronic care. You're going to pay for that diabetic's insulin for the rest of his life, for example. You're going to pay for a statin for the rest of somebody's life. Instead, now we're concentrating all of that cost at one time. So we've seen some programs emerge. We don't think we're quite there yet, though, with the solutions that exist in the marketplace. But some, and I'll talk about why. So some of the solutions we've seen some risk pools emerge, and Cheryl highlighted this idea of a pool of risk. We'll talk a little bit more about that. The ones that are out there are good. They're a good step in the right direction. From what I've seen, though, they're expensive, and they're really limited in what they do cover. We talked about stop loss. We talked a little bit, kind of put reinsurance in a similar bucket as stop loss. It's fine when we only have a few claims, but as these things grow, the cost of stop loss has to increase to keep pace. And because you are paying that premium, regardless of if you get the claim, it can be a very expensive proposition. And then sometimes I get asked about patient assistant programs. And while patient assistant programs are really important, they're very targeted at individual patients. They're very targeted, especially at patients with lower incomes, to make sure that they can get access to these types of drugs. They're not meant to be a solution more broadly. And so we thought about 3 different models. And the supplemental risk pool is the one Cheryl mentioned. It's probably the furthest along of these 3, and I'll go into more detail on all 3. But I'll also highlight that we thought about additional insurance products. And we thought about kind of a novel financial instrument that we've called a therapeutic health credit. And as we've looked at all 3 of these models, we've really tried to focus on different stakeholders, knowing that this is a multifaceted problem. So we've certainly focused on the self-insured employer. That's really the primary audience. But we focused on the member or the patient as well, because that out-of-pocket, that time away from work, that burden of other familial responsibilities is hard and can limit access to these types of therapies. So we wanted to make sure we were solving for that population as well. So let's go through all of them. And there's a lot of detail that exists on this page, and there's a ton more that sits behind it. But at the highest level, when we talk about a supplemental risk pool, the idea is each of you would continue your plans. You would offer the same benefit package that you offer today, or whatever you decide. When it comes to cell and gene therapy, though, you would say, we're going to cover it, but we're going to carve that out. And we're going to put that into a third-party entity. And instead of paying that claim as a self-insured employer, we're going to pay a per member per month fee to that third party. And the closest proxy I've heard to this is probably fertility benefits. And some people in this room probably offer fertility benefits in a similar model where they pay a per member per month fee. If and when a claim came through, your member would call your plan and say, I have a claim. And they'd say, great, go through this third-party entity. And the idea is that third-party entity would take care of everything. They'd take care of the drug cost. They'd take care of the travel and logistics. They would take care of the administration fees through these qualified treatment centers, because we want it to be fully covered. We don't want to try to split the claim between what's a drug cost and what's a administration cost, because the complexity of doing that and the risk of a piece of that falling through the cracks could be catastrophic to these patients. I don't have a price. I always get asked, okay, so what's the PMPM price? I don't have a price. However, we've done pricing research, and we've done that pricing research, and we've done some of the modeling about what this would look like. The employers we talked to said, yeah, that's reasonable. That's reasonable as I think about the increase in my stop loss. That's reasonable as I think about the value that this provides to my member base. And that it's not insignificant, but it's not a significant cost to me. And what they really value here is being able to take this off their hands, because it is so complicated and it is such a new area that they are all struggling to reckon with. So the second model is around new insurance products. And I don't know how novel these are, but we think the application of them to cell and gene therapy is really important. And so we've thought about it 3 different ways. We thought about an accelerated benefit on existing plans. And if I needed a cell and gene therapy, could I accelerate some sort of employer-provided life insurance so that I, as a patient, could have the benefit earlier on to be able to cover my familial needs, my out-of-pocket costs? The second is a supplemental insurance policy that you might add to your plan, and that would provide cash to the patient as they go through this process. And then the third is what we've called an optional or extended warranty. Now, many of these cell and gene therapies already have a warranty associated with them that is provided by the manufacturer. But that warranty would pay out to the payer if the drug didn't work. And so we thought a lot about, well, what about the patient? What about and the investment that this patient is making? And what about the disappointment of, I have this terrible disease, there's no cure, there's no other treatment, I've put all of my hope into this therapy. How do I make sure that I can make sure my family is in a good place if it doesn't work? And so what if we offered some sort of extended warranty to the patient? And then the last one is likely more focused on larger self-insured plans, but we've thought about a financial derivative. We've thought about more of a futures contract. And so if I'm going through my planning cycle, can I buy a cell at an option essentially on a cell or a gene therapy today, and then at a lower price, and then have that option available to me if one of my members needs it over the next 2 or 3 years, whatever the right time period is. And then if I don't, and it's starting to expire, could I sell that on a secondary market? And so create a secondary market for this lower cost to allow people to trade those for employers who might need that. We've also thought about loan contracts. And the loans are really interesting because it takes a one-time cost, say $1 million, and could you spread that over 10 years to really amortize that, to make it look more like a chronic care type of product? There are complications certainly with loans. What if a patient dies? What if a patient leaves the company? How do we think about portability or transferability of that loan? And so that one, while I think is a really important and good idea, I think is harder from an execution standpoint. But it's one I think we've got to continue to talk about, especially as we see more and more of these therapies come to market. All right, so what should you do? First of all, none of these are in the market today. We talked about some of the solutions that are, but none of these emerging models are in the market today. We're trying to change that. We're going as fast as we can, and we're hoping to get some of them in the market. But what do you do today? The first is really start to understand cell and gene therapies. They are an emerging class. They are never going to treat millions and millions and millions of patients in a single year, but they're an important part of being able to take care of your members. And so understanding how they work, what they are, how to think about them, and educating your team about the potential benefits is really the first thing I would call out. The second thing I would call out is to really understand the authorization process. If one of your members needs one of these, what is the process they will go through? And we've had lots of conversations with employers who say, I didn't really know how to help my patient, my member, until they needed it, and we had to figure it out together. I would argue that's not really where you want to be, given the criticality of some of these therapies in a patient's lives. And some of them are really time-bound. You look at things like spinal muscular atrophy, that has to be delivered within the first 2 years of a patient's life for it to be effective. And so the clock is ticking for many of these patients when they get a diagnosis. The third thing is really think about your access policy. How are you going to cover these? What is the financial strategy you are going to use? Is this covered by your stop loss policy? And if it's not, how are you going to make sure that you can fund these? And you want to make sure that the contracts, and maybe you call Matt for this, but the contracts here that you are setting up have the right levels of coverage. We have in one of the panels I served on, Cheryl, I don't know if you were there, we had an employer talk, and they had a supplemental policy, stop loss policy to cover cell and gene therapy that they were considering. They agreed to do it. They never signed the contract. And months later, a patient needed a cell or gene therapy. Their stop loss provider was incredibly gracious and provided them coverage, but I think that is the exception, not the norm. And then the final thing is to start to explore these models. Start to think about which of these models that we talked about or others is most applicable to you, and start to advocate for these. Talk to your employer benefit consultants. Ask them about how they are covering cell and gene therapy, what they are recommending, what models they are seeing emerging. We need to drive this dialogue in the ecosystem to really emphasize the importance of this and to make sure that we have the coverage that we need for our members. And so with that, I think I've got 10 minutes or so. I'm happy to take questions. I'll highlight two articles that we published that might be of reference. The first is the paper on which these three models is based. And that's been out for about a year now, but it goes into more depth on how we've thought about these models. And then the second is a paper that we published a couple weeks ago talking about the future of healthcare financing. So it's a much broader view. It breaks down a lot of the barriers that we see existing in the system today and starts to talk about what some broader solutions to healthcare financing might look like.
Well, let's start with thanking Drew. That was fantastic. What I really love about his presentation is some of what he is talking about that you've been analyzing internally is a little different than what we are doing. And so I think there's an opportunity for us to be sharing with each other. I know you'll likely do the research behind all the things, and things are evolving. It has taken years for us to get here. Not a lot was happening. And now don't you feel like the last 6 months or year has been blasted? The number one thing that comes up when we talk to our employers about these concepts is, why should I pay a lot of money for a therapy, a cell and gene therapy, for someone that's going to leave the company? And it's the first time that we've been talking about, and we're not saying it's going to happen, but employee contracts, or how do we get the entire system integrated in supporting that patient, and at the same time, they're going to leave. Have you had conversations with employers about that, and what are they saying?
You're 100% right, Cheryl. It comes up every time. Every time we talk about this, portability, we call it portability. Portability comes up. We've addressed it a couple of ways. First of all, some of your membership bases stay for a long time. Some of you have an average tenure of 5, 10, 15 years. And if you look at the payback period for a lot of these drugs, it is well paid off by the time your average member would leave in that case. Now, if you have a member who's going to be around for a year, 2 years, that's a whole different story. And that's a population where you're going to want to really reevaluate what benefit you're providing. So employers are thinking about it that way. They're thinking about tenure, they're thinking about the applicability. We have spent some time thinking about what are some models that help address portability and how might that work. And so if you go back to like the loan idea, for example, if you're providing a loan, if you are taking on a loan to provide one of these therapies, can we start to think about transferability of that loan? Now, of course, you have to think you don't know where your employee is going to go. So you can't pre-negotiate that you're going to go from working for Coca-Cola to working for Pepsi, because you just don't know that that's going to happen. But could employer coalitions play a broader role there? Could we establish a standard that says, Fortune 1,000 companies agree that we're going to have transferability both ways? That's a complicated solution, but it's a complicated problem that probably warrants that type of solution.
And I think it's not going to be just one solution. It's going to be many solutions, and it'll probably be complicated, and it will probably be convoluted, and it will probably create new vendor partners. And we wouldn't want any waste built into that piece as well.
Agree.
Audience questions.
And maybe while we're waiting for the question, Cheryl, if we go back to the supplemental risk pool, I think the piece I didn't mention is one of the critical design principles there is that we would work with one of the transparent PBMs, or we would work with a public benefit company, or we would work with a not-for-profit to stand that up. Because what we don't want to do is introduce so much of cost to the system. We think there is a real role to be played by an intermediary here. But let's make sure that we're being smart about how we're setting that up and not introducing complexity and not introducing cost.
Couldn't agree more.
Kirby Yang, Outcome RX. And I just wanted to take a little different slant on the patient portability challenge. And so you mentioned that a number of cell and gene-based therapies have value-based agreements, outcome-based agreements, or therapy warranties. Have you seen any best in case or best example of how a warranty or a value-based agreement can address that patient portability challenge?
Your question is, does the warranty travel with the patient? Is that the question? Yeah, no, I haven't. I think that's a critical part of it as well. Because the warranties are typically designed to benefit the payer, once the patient leaves, the view is kind of like, it's gone, right? That money has been spent, and I'm no longer tracking that patient. So there's no way for me as an employer to create the claim associated with it. But I think that can be part and parcel of the broader solution that we talk about for sure. And I also think we're seeing these warranty models start to emerge. They are by no means mature at this standpoint. And most of the biopharmaceutical companies that have them, it really is focused on a specific piece of the puzzle that they're trying to solve. But I think we are going to see many more of those as we see, more of these cell and gene therapies come to market.
I also think they're going to have to be simple because they have never worked before, because the carrier or the hospital delivery system or the manufacturer all want too many things out of it. Got to be simple. Paula, you had a question on the line.
Someone just asked if you could talk about the work MBGH was doing in the risk pool area.
You know what? I'm going to save that for Tom. He's got a couple panels coming up. We did look at a multi-employer risk pool. Our first work stream of the National Employer Initiative of Specialty Drugs and Biopharma was on that risk pool. And then we realized last year we needed to pivot to focus on education. That it was too much in the future, and there were too many things that were in the way of it. But it is an important element. And again, Tom is going to talk about a few other things. I know that our report that two reports we're launching today, we talk about the marketplace, and at the bottom, there's text that said, if we don't kind of solve this, employers just won't pay for these therapies. So we as a community have to solve this, and hopefully we can solve some of it together without the waste, right? Dawn.
I have a question about clinical integration. How does that work in this process? In other words, who clinically is making a decision about the therapy being effective and how the process would work, and potentially referring to centers of excellence so we get the very best outcomes?
In the supplemental risk pool model, is that the question? Yeah. We have seen the manufacturers stand up these qualified treatment centers. Now, there's not 100% overlap between every single manufacturer. It tends to be on a product by product basis, but there is decent overlap across them, and they would be the centers of excellence that you would think of. We are not seeing today, cell and gene therapies administered in the community setting. And so as we are thinking about the supplemental risk pool, we want to make sure that we have access to the right treatment centers, as well as making sure that patients have the choice to be able to go to the center that matters to them.
So if you were to engage in this risk pool, you would be transferring that responsibility to the clinical folks within the risk pool, as opposed to arguing with your carrier about whether or not there should be coverage for these types of services.
Exactly. The decision and the responsibility to maintain that treatment center network would reside with the risk pool administrator. Now, they need to work with the manufacturers to make sure that the centers are qualified, et cetera, et cetera. But no, it should not be made by, if you're an Aetna plan today, should not be made by Aetna, should be made by this third-party risk pool, of course, in conjunction with the patient's physician.
Let's see if we have time. We do have time for other questions. Hi.
Hi, Randy Vogenberg, Only Healthcare Podcast. And what I was interested in is, because you mentioned you talk with employers about some of these, and the PMPM was acceptable. The PMPM was acceptable. So I was curious, what was the appetite in general, given where we're at in this market? There's not a lot, but there's becoming real fast, as you pointed out. And we're probably going to see a lot of change in the technology that allows for more community use as well. So what are your thoughts around where we're really going to head in the next 3 to 5 years?
Yeah, I think the community aspect is a real question. But I will say all of the employers I've talked to have been interested in these types of models. It is a need that they are wrestling with. Many of them say that they are talking to their employer benefit consultants and they are hungry for even more information. They're not getting the education that they desire. And so when they see solutions like this, they're grateful to see that somebody is thinking about a concept that would allow them to be able to cover their patients, or at least give them a financially viable option to be able to consider it.
Any other questions? Let's thank Drew again. Outstanding. I feel like we're in kindergarten with this whole thing, but you've elevated us to maybe second grade. And our resources and the research that Tom Sondergeld and I did on this over the last several years were right behind you. And there's a lot of alignment, and I want us to stay in contact because we're exploring other options, other potential options, but I appreciate how thoughtful you guys have been about what you've done thus far. So I am going to now introduce another word from one of our sponsors, Johnson & Johnson.
Healthcare. It's more than a system. It's a fundamental human need, essential to our collective well-being. But healthcare has become disconnected. At Johnson & Johnson, we want to restore it to its true meaning. And the answer is right in front of us, in those two simple words, health and care. Connecting the best of both to deliver innovations for patients. Industry-leading product solutions that move people through recovery with greater ease. Advanced treatments for today, unlocking potential cures of tomorrow. Let's connect the best of health and care for every provider, for every patient, for everyone, and show all the amazing things those two simple words, health and care, can do. Johnson & Johnson, the health and care company.
Thank you, Johnson & Johnson. And before I move forward and before we go on our break, I want to tell you that I found Drew's outlaw quote. It said, "My work focuses on market innovation and disruption. Doing this in a Big Four firm requires me to lean into my outlaw side while staying compliant with my risk team. Definitely takes an outlaw spirit while being totally compliant, of course." Well done. Thank you. So we now are moving to a break, but we want a few reminders. The outlaw generator sheet on your table, you introduce yourself to your table mates very quickly using your outlaw generator name. Visit all of our sponsors. We've got several in here and more in there, and get your prize card initialed by them, and then make sure to submit those by 3:40. And then we're going to reconvene at 11 a.m. And Paula, what do you have? I mentioned that earlier. Affirmed RX is not here. Do not look for them. Don't worry about that, and go have some fun.
Yeehaw. Welcome back from break, everyone. We are so grateful for all of our partners in pharmacy. And now here's a word from one of today's sponsors, Affirmed RX.
We made the decision, hey, we could sit along the sidelines and continue to complain about the PBM industry, or we could do something about it. Every decision we've made since then is to say, how do we create a PBM that's completely unconflicted and always working in our client and their members' best interests? Most corporations have to work in their shareholders' best interest, and that's part of the problem with healthcare. Why aren't we talking about total cost? We don't need to talk about discounts and per claim rebates. Do the right thing and get a better outcome.
Okay, it's my honor to introduce our moderator for this morning's fireside chat, focused on successful employer strategies in pharmacy benefits. Kim Dwyer has been my lifetime, I should say, not lifelong, but 30 years, Kim, colleague and friend in our joint quest to make a difference in health and benefits. I had the privilege to serve as Kim's strategic relationship manager when I was at ADP, and she was VP of benefits at Advocate Healthcare. And today she is still working to be a positive change agent in our industry as vice president for Inspira Health, a health improvement company that is focused on managing cost and risk for claimants with multiple chronic conditions. Kim is a past MBGH board chair and a current board advisory member. Welcome, Kim.
All right, I'll just keep talking. And the button is up. Okay, I can do this on my own. You have an exciting panel of, okay, you're motioning to me. Bring it closer to my mouth. Okay. Okay. All right, that sounds much better. We have three esteemed panelists today, and I will introduce each one of them. And I'm going to ask them 5 fairly specific questions. I think they're questions that many of us in the room as employers want to know. What's their secret sauce? How is the sausage made? What are they getting done that we could potentially use and take back for ourselves? So first, I would like to introduce Jason Smokey Duhan. He is the director of Total Rewards for Caterpillar, and he leads a team of highly talented and passionate professionals in benefits and health. The team has a long history of rejecting status quo and taking an innovative approach to benefits design. Jason currently serves as the secretary of our MBGH board. Please welcome Jason. Okay. So Jason, many of us know you as being one of the first pioneers in a cost plus model in your pharmacy plan. But let's talk about the benefit you were trying to address for your organization and how did you solve for that?
Yeah, thanks, Kim. So even before I got to Caterpillar in around 2006, 2008 timeframe, Caterpillar had been looking at data and noticed that the prescription drug trend was on the way up, just as many other companies were experiencing. And not to mention, there was starting to be discussion about that time of specialty drugs and how that could eventually represent 30%, maybe even 50% of your drug spend over the next few years. And so that was on Caterpillar's radar at the time. And but we didn't have a pharmacist on our team. We didn't really have that clinical depth embedded with us. But at the same time, there was a local pharmacist in the area who was, he jokingly says, he had a sign that says, "We'll work for data," and was interested in working on some of the supply chain issues as well. And so we saw an opportunity to partner with him. And so what we did is just kind of get together and try to figure out what the RX supply chain looked like and what opportunities we may have to bend that trend.
Super. So tell us a little bit about how you're measuring the effectiveness of this strategy and what do the outcomes look like?
One thing that we do is, because we negotiate our own drug prices, we were able to eliminate things like spread pricing and managing our own formulary, take away some of the misaligned incentives. And the way that we typically measure that is we look at benchmarking from the PBM. And so the PBM publishes like their average cost per prescription. And I find that a good way to understand how effective our strategy is working because, and this is not the real number or anything, but just as an example, if the average cost per prescription is $200 for employers that use the PBM to lead their strategy, and ours is $100, just as an example, then you can clearly see the total impact that you're having by doing things like custom formulary management, direct contracts with pharmacies and those types of things. So that's one of the key measurements that I look at to understand if all the things that we're doing are worthwhile.
That's great. So let's talk a little bit about the relationship. We'll do a reveal for you at the end to let you know. But talk about the relationship that you have that you might think you wouldn't get from a typical PBM with the vendor you have today.
The relationship's really good because what we found when we first started looking at this is that there were very low value drugs that were being used by our population. Some of them were very expensive and were not best in class at all. In fact, they might not even be considered on par with some of the other drugs that were available in the marketplace. And so that came back to misaligned incentives. And so part of the beauty of the partnership is that we get access to PharmD pharmacists and internal medicine physicians who help us review the drugs that are coming to market in an unbiased way. So there's nothing in the consideration about trying to optimize rebates. It's purely based on the value of the drugs. And so the beauty of that relationship is, first of all, we get to evaluate the drugs and decide for our members and for our company what products are being used. Second of all, contract language is extremely important. An and instead of an or instead of your contract could cost you a lot of money. And so they bring the ability for us to get best in class contracts.
Super. So I think you've described what makes your approach somewhat unique, but what do you value most about this relationship?
Well, there's a lot, but I would say that, and I've said this recently to my team, we work so closely with our partner that sometimes it's hard for me to distinguish who's actually reporting to me from my team or who's from the consultant because they actually they have people that sit in our wing with us in our building, and that's how close the partnership is.
That sounds like a real true partnership. Finally, because you're such a great thought leader in this space, where do you think the industry is heading? What do you see as some key future initiatives?
It's a really tough question, but I think what we're starting to see is hundreds of brick and mortar retail stores that are starting to close. And the margin for the pharmacies is tough for them to operate in. And so if you think about where does the industry have to go as far as prescribing and dispensing medications, it sure seems like artificial intelligence and robotics and things of that nature could be in the future. When you look at the types of drugs, it's pretty clear that large molecule complex drugs, gene and cell therapy seems to be the way we're going in the future. And so there's not too many of the legacy drugs that are being worked on anymore that are inexpensive. And so just like we were talking about earlier today, I think we're going to have to figure out if the therapies are getting a lot more expensive, how do you plan for that?
Looking at those financing techniques. Okay, thank you so much, Jason. Now I'd like to introduce Christina Whiplash. And Christina is a pharmacy benefits practice leader for the Midwest segment of Lockton. And her focus is to develop, oversee, and implement effective strategies for employers to lower their drug costs and improve clinical outcomes. Christina is experienced with complex PBM marketplace and has extensive knowledge with each of the vendors' benefits and their program options. So Christina, I'm going to ask the panel the same types of questions, but in this case, you're going to be letting us know how it works on behalf of the clients that you service. So what are some of the primary pharmacy benefit problems you're trying to address and help your clients with?
So we help every day our clients with a situation that is not unique. And by that, I mean high specialty drug spend. So we're always going to have specialty drug spend on our plans. It's unavoidable. This is why we offer benefits, right? So we can help these people who have these really complex conditions. But where things start to get really interesting is that when we notice we have a lot of clients, specifically with particular PBMs, who have really high specialty utilization. So typically the norm is around 1.5% to 2%. Sometimes our clients see 2.5% to 3%. And that makes us think, what's going on? How can we find a strategy to help mitigate that?
Okay, so interesting. How are you measuring? What do you deliver back to your clients that says this is working or this is effective?
Yeah, so this particular vendor that we work with helps us reduce the specialty utilization by doing an independent prior authorization. So as you know, many of the PBMs out there, they own their own specialty pharmacy. So how closely are they really looking at the prior authorization criteria if they stand to benefit from the claim? I think the answer we found is they don't really look at it very closely at all.
So help us understand a little bit about the value that your clients are getting through Lockton and the relationships, and what you feel you offer that you wouldn't get from a typical PBM.
So forgive the sort of elementary analogy here, but I almost feel like I'm getting a babysitter to help me watch my PBM partners. So PBMs, I like to say, are kind of like toddlers. If you're not watching them really closely, they might do something that's going to cost you a lot of money. And I will say my PBM partners in the room are excluded from that particular analogy, but I feel like I'm getting a good babysitter and not just the teenager down the street. I feel like I'm truly getting the nanny, the educated nanny, the one that's been working for a very long time in like childhood education and that kind of thing, to really help us manage our relationships with our clients, our PBMs, to make sure that they're not spending more than they need to on their specialty drugs.
So you do have a special relationship with a vendor, which we will reveal in about 14 minutes. But what makes your approach unique with this relationship that you have with this vendor?
So when we look at specialty cost containment issues, there's a lot of things out there. But what we're looking for at Lockton is kind of three things. We want to look for high impact on the savings or cost avoidance. We want to look for low member disruption, but we also want to look at clinical outcomes as well, because we don't want to just deny specialty drugs for the sake of denying them. We also want to make sure that we are approving drugs that make sense, that work. Sometimes this particular vendor might find a drug that's actually more expensive, but it's better for the patient clinically. So this particular vendor hits all three of those. If you're looking at like a patient assistance program or international sourcing, sometimes it doesn't hit all three of those things that we're looking for. And in addition to that, what I think is really unique about this vendor is that there was, with the Humira biosimilars that came to market this year, and I'm sure all of you have noticed this, your utilization for Skyrizi and Rinvoq probably went up quite a bit, right? So with this particular vendor, we have about 20 clients with them all together. For one in particular, we did this really interesting case study, and we found that for this particular client, Skyrizi and Rinvoq utilization, there was some migration to that. However, it was 12% less than Lockton's entire book of business because of the work that this vendor was doing for our clients. So that is very impactful and something that we're not going to get with anybody else.
Okay, and finally, where do you see the industry heading? What's the future?
So I think transparency, we already heard that this morning from a couple of the speakers, right? I think this is going to also fit in very nicely with maybe potential PBM reform that's coming down the line, because again, we have to watch them. PBMs can't own their own specialty pharmacies. That's a conflict of interest. I think it's the removal of those conflicts of interest that are going to start coming down the pipeline here very soon. And I'm very happy that we have a vendor that's already doing the right thing in that space.
Thank you, Christina.
Thank you.
Okay, now I would like to introduce Stephen Wyatt Svikas, and he currently serves as the Director of Global Benefits at Morningstar. As part of the Global Total Rewards team, he leads the development and execution of Morningstar's global benefits strategy. He has been with Morningstar for over 8 years, but I thought I heard you say somebody more closer to 10. And I do have to mention that Stephen had a very special Father's Day this year, welcoming his daughter. So, Stephen? Okay. What is the problem that you were trying to solve for when you decided to engage in this vendor, which we will disclose in about 7 minutes?
Yeah, thanks, Kim. So, our problem probably goes back about 6, 7 years when, and I'll try to kind of represent maybe a mid-sized employer's perspective here, but it goes back 6, 7 years. We were looking at, rising pharmacy costs, how we wanted to address that, kind of considering different strategies. We were really interested in carving out at the time, but we were, just for some context today, we're about just under 4,000 employees, roughly around 6,000 plan members. We were maybe a little larger than half that size back in 2018, 2019, when we first explored this partner. And so when we were looking at sort of, different carve-out models, we were just struggling to even, in some cases, be able to actually get a bid at our size. And so let alone a competitive bid. And so we started exploring kind of different ways we can address that. How do we manage the sort of the cost equation? And then how do we manage the sort of issue of our sort of leverage and size? So we found a partner that it works in sort of a group purchasing arrangement that sort of lets us address kind of both those issues.
Great. That's good insight for our small to mid-sized employers who are struggling to find a relationship that is effective for them. How do you measure the effectiveness of this vendor and whether or not they're achieving the strategies you have for your organization?
Yeah, I think probably like most partners in the room here, I mean, it's a mix of kind of clinical measurements and financial measurements. So regularly we're getting reporting from our partner that actually helps us do this. But we look at the obvious things like our rebates and how they're performing relative to our guarantees. We track a variety of different clinical metrics throughout the year, like many of you do. We look at generic dispensing rates, generic utilization rates. We look at the mix of our drugs, specialty versus generic. And so it's just a variety of those factors that we track throughout the year to make sure we're hitting our targets. And then in terms of sort of outcomes that drives, I think, one thing that was interesting for me, we did a big marketing exercise last year on our PBM relationship. We hadn't done it in about 5 years. And the market's changed a lot between 2019 and now. So I was wondering, how would sort of the group purchasing arrangement stand up with some of the changes? We looked at carve-in models, carve-out models. We looked at one transparent partner. We did ultimately kind of retain that relationship, but we saw, at least projected out for the next 3 years, a 30% savings through that group negotiated contract. And it was about a 13% difference between that and the next closest bidder. So, there's complexities here, but we felt pretty strongly about renewing that relationship.
Yeah, those market checks are just invaluable. And it's always important to validate that what you have, because you don't know what else is out there and what has evolved. So it's important to evaluate that you stay in the relationship for all the right reasons. So good support there. What makes the approach unique, and what do you value most about the relationship you have with this vendor?
Yeah, I mean, I would say, it's not a set and forget relationship. I think one of the most valuable things that we've seen, it's paid dividends for us every year, including last year, obviously, is this partner does annual market checks on their PBM relationships and contracts. I think that puts a lot of pressure on the model to make sure, at least with respect to the drugs in the plan, we're getting good pricing and strong negotiated terms. So that's been an annual. Sometimes it's surprising how much we save from one year to the next. I don't think it necessarily diffuses the need for our team to be rigorously evaluating what's on the formulary and how it's being managed, but it feels like it takes a little bit of work off my plate in terms of managing that with a small team. So that's kind of one component. And then just the benefits of leveraging a large group for the sake of placing the business. We just get a different level of support on issues that we have with the PBM. Many of you are probably working through your GLP-1 strategies. Some of the big three have introduced strange pricing models where if you wanted to, for example, explore a COE approach to manage your GLP-1s, that might introduce additional cost for you to do so. Navigating some of those issues, we've had a lot of support from this partner in addressing those problems, which has been a benefit too. And the last thing I would just say is, they sit in addition to our PBM and consulting teams. So again, if you're someone like me who's not an industry pharmacy expert and we're generalists, we have to manage a lot of different balls in the air. Having that kind of third perspective in the room that's neutral, that's guided by another group of large employers is a nice kind of a pat on the back, a level of support that you might not otherwise have.
Well, and it's also a reassurance because you're part of a larger group of people who are all in alignment with getting the value out of the product. So that's important. And finally, where do you see the industry heading? What are the big things that are on your radar screen?
Yeah, I mean, not to maybe echo some of Jason and Christina's comments. I think maybe I'll take a look at it quickly from like the member's perspective. So, looking at transparency models last year was interesting, and I've talked to a couple of our peers that might be here in the room about their experience kind of migrating to the transparency approach. One thing, cost structures aside for a moment, that has been a bit of a head scratcher for us is how do you navigate the member experience there, where at least through a traditional PBM model, you sort of have one source nationally and one experience regardless of which pharmacy that you go to. And depending on the model of the transparency approach, you may start seeing different treatment and different pricing at the pharmacy side. And that could be, if you're a good consumer, challenging because you now have to navigate multiple different sources for your medications. That's just one example. So thinking through like how you start reintegrating the member experience after some of the industry changes over the last few years. Do you look at, your navigation model and figure out how you incorporate pharmacy back into that, which can be more challenging if you're carved out, things just like that on the member experience side. I think that's going to be a challenge that has to get resolved as these kind of disparate issues in the industry get figured out over the next couple of years.
Yep, that's a very good point. And I'm just going to add, as Cheryl calls it, the F word, fiduciary. Our roles as fiduciaries, what we were doing 5 years ago with our pharmacy strategies is very different than what we're held accountable to do today by our participants. So it puts a whole different spin on looking at the palette of services that you need to make sure that you are compliant and that you're getting your data and that your audits are effective and they can stand behind you as a fiduciary in the plan. So that's my 2 cents for what it's worth. So Mark, are we going to do the reveal now or are we going to take questions?
What do they all have in common, Kim?
Oh my goodness. My big line and I blew it. Okay. So I am on the board of directors as an advisor for the Midwest Health Purchasing Collaborative. And that is an arm of MBGH that provides vetted vendor relationships and brings best in class with favored nation pricing to all of our membership. And I am proud to say that all three of these folks are representing vendors who are business partners with MHPC. So the first one, Jason, is using Health Strategies. Where are they located? So if you want to go and talk to them. Okay, and where are you? Are you outside there? Okay, in the corridor?
Find Brandon.
Find him. Okay. And RX Results is here today, supporting us as well.
LG's in the back there.
LG's in the back, and they also have a table out in the corridor as well, so you can talk to him about his solution. And finally, Employers Health is the group purchasing arrangement. And where's Eric? Is Eric in here? There he is. And Employers Health also has their table here as well. So if you have any more detailed questions, you can go directly to the table. But now we'll see if we have any questions from the audience for any of our panelists.
Thank you. I know you guys talked a little bit about specialty drugs. And we've heard from several speakers this morning about what's going on in the ultra high cost therapy area, the really expensive drugs. Could you share your philosophy? And in your case, Christine, is it? Huh? Your representative perspective on that area.
On high cost drugs in general? Well, so first of all, the RX Results program that comes into play, this is mostly going to be on the drugs that are dispensed on the pharmacy benefit. I think where the really high cost drugs come into place is when you're filling them on the medical benefit, right? The cost management there is definitely much different, right? I think right now our clients are really focused on site of care. They are really focused on provider contracts, sometimes direct contracts in those cases. For example, like with hemophilia, we work a lot with like the Hemophilia Alliance. So it's very specific to what type of high cost drug we're talking about. And then even within Locked-In, we have some wonderful folks that will help us on really high cost claims, those like 1% of the 1%. They can help negotiate the cost down there. So definitely something that's top of mind for all of us, but we do have a lot of silver bullets in our briefcase for that.
That was really helpful. Any innovative ideas you guys are talking about internally that you can share? It's okay if you say no.
I was going to say I'm kind of the wrong person for this one because it's medical specialty drugs.
No,
but we do have we have a lot of thought leaders at Locked-In around that. I can give you some names to speak with.
No worries.
Jason's got some insight there too, Cheryl.
Yeah, I think when I think about high cost drugs, we're trying to get people to the highest value drugs, first of all. So get them the best in class drugs. And that's a combination of cost, quality, safety, efficacy, all of those things. And whether it's RX benefit or whether it's medical benefit, we still have that in mind. But the second thing is the supply chain. If these are already very expensive drugs, how can we cut the cost of those down? And so that's where things like directly contracting with pharmacies or now directly contracting with manufacturers is part of our strategy. So if you think about the supply chain and all the margins built in at each step in the supply chain, if that's not adding value to you, then how far back to the manufacturer, how close to the manufacturer can you get? So we're working on our second direct to manufacturer contract right now.
And I did a project with Jason on biosimilar conversion. And I was amazed to find, I think it was 97% conversion rate to biosimilars. And this is when they first emerged in the marketplace. So they're doing some very innovative things through their P&T committee.
Yeah, and so part of that was working with our PBM and our carriers. We had good discussions with the carriers to help us do that, and it really came back to the value prop for the drug. If you're getting same level of safety and efficacy, but at 50% or 40% of the cost, just as an example, then why not pursue that strategy? So we were very effective in getting people to use biosimilars.
We'll take a question from Dan Densler from United Airlines.
So Jason or Christina, from a perspective of small, medium, large employers, think words like custom formulary or direct to manufacturer contracting seems like an incredible lift. How do you propose people begin that process or really think about that and think it through before they go down that path?
Yeah, so for me, what I've heard people say is we don't have the time or the money or the people, the resources to put into something like that. But as I think about what we've done, if the savings are measured in tens of millions of dollars a year, I think you should flip that around and say, I can't afford not to invest in those resources to be able to do that. But if you can't get pharmacist and physician support and all those things that come along with it, I think that's where working with a good consultant that can take some or all of that load off of you comes into play. So they can make it turnkey to where they do all of that work on formulary management and contracting for you, or you can be as involved as you choose to be. And so I think that's how you kind of step into that area.
And I would say too, I don't think I have a single client that really wants to manage their own custom formulary. You mentioned HR teams are slim, and you have to think about all of these other things just besides pharmacy benefits. So I would encourage you to think about a PBM partner that is not necessarily aligned with pharma, because the whole point of a formulary, right, is to align with certain drug manufacturers. And we need to obviously maximize that where we can. But in some cases, some PBMs are a lot better with formulary changes. Like, yes, they have a P&T committee that makes those formulary changes every year. However, they can also make those formulary changes optional for you. They don't make you do it. There's a lot of them out there that will say you can accept or you can reject them. So that's almost like a nice middle ground to, instead of having your own formulary, just partnering with somebody who allows that sort of flexibility on their formulary.
Stephen, any parting thoughts here?
No, I mean, I think I actually agree with a lot of kind of Christina's comments. I mean, I think, we're in the category of folks where, I've got a team of two. We manage global and US. And so besides maybe the time commitment in navigating that on our own, there's also sort of the competing interests of our leadership team and what they want to focus on for the year. But actually, Dan, I'll bring up something that maybe you and I talked about a couple months ago. At least operating in the traditional PBM sphere where we are right now, there are some new partners in the space that are looking to for plan members where, earlier we heard, there are cases where in your specialty formulary, you may have a generic that's being charged at significant excess rates. It would be a fiduciary challenge for your plan members to access those drugs at those rates. There are some partners in the market now that are operating in sort of the space in between where you could sort of deliver a pre-purchase, company-sponsored cash benefit to cover those generics through another source, like a cost-plus drug or another source sort of outside the plan, still get it covered by the organization, but allow the member to kind of navigate the best cost option for them and balance that fiduciary due diligence within the context of a traditional PBM arrangement. Those are things that I think are attractive for us right now, and we're thinking about if we keep this model in place, for the future. So.
Well, I want to thank my esteemed panel this morning and make sure you go out and visit the booths of these vendors because they have now been vetted by your peers.
Hello, I'm Paula Sheehan. I'm the Director of Member Engagement at MBGH. So good to have you all here today. So my outlaw name is Rusty Bullseye, which seems pretty appropriate because my bullseye is quite rusty. So I'm happy to welcome our next panelists up on stage, but we do have another message from one of our sponsors who we are so grateful for.
Introducing Slate RX. We are the industry's first PBX, providing a pharmacy benefit experience that delivers unmatched value. Our model delivers the financial incentives of a large PBM and matches it with the concierge-level service of a PBA, giving plans the control, transparency, and flexibility they demand. Discover how PBX by Slate RX does pharmacy benefits better.
All right, great. So panelists, if you want to come on up and take a seat on stage, I'm going to introduce Jason Perot, who is the Senior Vice President of Growth and Partnerships at Vida. And he led the healthcare and wellbeing strategy at the Boeing Company and AT&T. He's also been a past MBGH board chair. And we were joking last night at the speaker dinner, once you're an MBGH board chair, you never get to leave. So most of them have stayed on, and he's an advisor now to us and very valuable. So with that, I will hand it over to Jason.
Thank you very much. There we go. Awesome. Thank you, Paula. Welcome, everybody. We're going to spend 45 minutes, and I am going to introduce very briefly by name and what they're going to focus on. Each of our three panelists, they're going to spend about 7 to 8 minutes, go through some slides, and then we'll do a big reveal. I'll open up for some Q&A from me to them, and then we'll open it up to all of you. How's that sound? And then we're off to lunch. Okay, so without further ado, I want to introduce Amy from Fortune Brands, and we also have Elisa from the Cato Corporation. We have Andre, who's going to speak on behalf of Tyson Foods today. So just to get started, Amy, feel free to go through your story.
Hey, hello, everyone. Can you hear me okay? Yeah. So my name is Amy Hakowski. I'm a senior benefits analyst at Fortune Brands Innovations. If you don't recognize that as a name, I promise you might recognize a couple of our brands. So we offer brands in 3 different categories: the water, outdoors, and security space. Some of our brands that you may recognize are Moen Faucets, Larson Doors, Master Lock, Century Safe. We're a global company. We have about 11,000 associates globally, with 7,000 in the US. And we're based not far from here in Deerfield, Illinois. So my role has a focus on our healthcare strategy, design, and innovation in our benefits space. We ensure that our benefit partners align with our strategy, which I'll get to here in a second. So we have three main guiding principles that we focus on: are managing cost and utilization, embracing innovation, and driving value for all of our benefit partners. Under these guiding principles, we also have pillars and objectives that we ensure all of our benefits align with. So these include plan design and costs, network and vendor utilization, healthcare delivery, employee experience, and population health and well-being. We also ensure that our benefits are competitive. We like to remove barriers to care, consider social determinants of health, and using best-in-class benefit partners to simplify where we can. So now that I've given you a little bit of backstory into who we are and our strategy, I'd like to get into the topic at hand, how we approach some of our pharmacy challenges. As is the same for most of you, I'm sure, prescriptions are a significant driver of our cost trends. These trends have been significantly increasing year over year. So in 2024, for example, our prescription trend was 12%, which compared to about 2% in our medical trend. For 2025, year to date, our prescription trending is at 19% compared to less than -2% in our medical trend. So in order to manage these costs, we needed to take a look at what's actually driving this trend. I'm sure it's not surprising to most of you that GLP-1 use is one of our main drivers of prescription trend. So in 2024, we actually did do a strategy around our GLP-1 use for weight loss, using a center of excellence to manage our prescriptions in that space. So the 2025 trend number does include some transition into that new strategy. But we also do still see a GLP-1 increase for diabetes, where you see high complex chronic condition medications and people with multiple medications that are also driving these trend numbers up. So there haven't been many resources available to these complex cases for people taking 5 or more medications and those with these complex chronic conditions. So to help solve these costs of managing these costs and filling this gap in care that we identified, we really wanted to find an innovative vendor to help us mitigate these issues. So as I talked about in my introduction, we also needed to ensure that they align with our healthcare strategy and guiding principles. So with our members driving spend in these complex medications and conditions, we found a solution to give them access to a personalized pharmacist that empowered them with the extra support they needed to take charge of their health. Targeting these complex cases, helping to control these costs, helped our employees feel better as well. Many solutions out there simply suggest just changing your therapeutic alternative that claims issues can identify. But the vendor that we found develops a relationship with our employees, helping look across their entire health portfolio and all their health needs. Many issues surface as a result come from this communication with their personal pharmacist, which are pieces that can get missed in these typical guardrails that legacy pharmacy solutions use. So what follows are better health outcomes for our employees. These personal pharmacists may suggest those lower cost alternatives, helps them save money. They may just deprescribe drugs that aren't needed, or maybe they're feeling unwanted side effects, and so they can help find a different solution to help with those side effects. Our vendor also helps improve adherence by sending reminders to take their prescriptions, which leads to proactive changes with our employees' healthcare and leads to less future problems down the road. Maybe eliminate future health conditions that require more medications or further doctor visits. And of course, all of this saves our employees money as well, which no one's going to complain about. Our vendor also works really well within our ecosystem. So they work with our other vendors to help members get the best care, in many ways unlock the value of our other programs so they can help them with referring out to our other vendors. And ultimately, this translates into savings, financial and clinical in nature, with an ROI that makes sense. So we've been with this vendor a short time, but we're already starting to see savings. So just over 5 months in, we've already been seeing an annualized number of over $320,000 in prescription savings. And as more people on board and engage with the program, we expect this number to grow. And these are prescription savings only. So we do expect to see medical savings as well, as those improvements are tied with the pharmacy spend. So this translates to $1,355 per RX savings per engaged member. But again, we expect to see this to grow as our program grows. And something that we really value with working with this vendor that I already touched on briefly is that while they're very easy to work with, they proactively work with our other vendor partners. And in just these few months, we've seen over 31 referrals to our other vendors within our ecosystem. So helping get our employees access to our other programs to address additional care that they need. And I will mention that a lot of our utilization has been tied to targeted claims. So we did do an introduction around annual enrollment and a home mailer, but we've really been focusing on targeted email campaigns to really reach members with these specific conditions that we feel this vendor can help with. And I just wanted to quickly mention a quick story and a member example to highlight some of the key focuses of what we feel this vendor can help us with. So we have an employee who is dealing with osteoarthritis, obesity, and hypertension. This person has multiple providers they work with. They have an appointment down the road, a ways out with a rheumatoid arthritis specialist, but they were living in significant pain. So they downloaded the app for this vendor, reached out, started that communication with our personal pharmacist, mentioned that they were living in this significant joint pain, which is a hindrance to everybody in our daily lives, but also our manufacturer employees specifically. So once this person started talking with their pharmacist, the pharmacist recommended an over-the-counter medication that has low side effects. And after using this treatment for some time, the employee reported that they were significantly feeling better. It mitigated a likely urgent care visit and got them through to their next appointment with their specialist. And in the meantime, this pharmacist is there for day-to-day support and to help check in with the employee as they go along their treatment path. And without further ado, I'd like to reveal Walrus as our vendor. So they're back in the booth in the back room. So please stop by and say hello. Thank you.
So we will have Elisa present on behalf of the Cato Corp.
Thank you and good afternoon, everyone. So most of you many of you already know, I am with Cato Corp as indicated. We are a retail organization. So we have about just over 7,000 employees. We have we have three offerings. So we do Cato, It's Fashion, and Versona. Retail, we do women's fashion as well as some men and children's. We have online and we also have a bank as part of our credit offering through purchases. In today's competitive job market, offering comprehensive employee benefits was a #1 goal of mine as the benefit manager for Cato. We needed to, obviously, we want to attract and maintain the best talent, being that probably about 90% of our employees are out in the stores. So we've got about 300 stores across the United States, here in 30 states. Unfortunately, not in Chicago, but I'll have to talk to someone about that when I get back. One often overlooked but highly valuable benefit is prescription assistance. And our associates contact me quite often to indicate that they're having an issue with a particular drug as part of our pharmacy offering. And so I'm tasked with helping them to navigate those concerns. And so, of course, I'm going to rely on my broker. And so thus, as a caring employer, oh, I do have slides. Well, sorry. Is this it? Okay, thank you.
But yeah.
That's
So there we go. That's Elisa.
sorry.
Yeah.
All right. So yes, As a caring employer, we knew we needed additional options to offer prescription assistance. And so we looked at how can we lower prescription costs, create medication options as part of that awareness for employees that I'd identified, and just have that transparent pricing to keep our benefits competitive. We knew and were advised by our broker that there would be about a 9% expected increase going into 2025 last year as we were planning during open enrollment. And this meant about 16,000 per employee per year increase on the average, where we were currently at about $14,823 per employee per year. So we needed to plan for that. And that cost increase was being driven by many medical factors. Or three key factors, one being medical services, high costs with claims, and pharmacy. I don't think it's not a clicker, I guess. Some assistance, please. Thank you. Oh, okay. So, and our pharmacy, demand was the growth of expensive specialty drugs, as well as utilization, as we've all heard today, GLP-1s and rebates, not keeping pace with the increased cost with scripts. They just didn't solve all the problems. So with clinical innovation driving these rapid changes in the pharmacy landscape, specialty drugs, and in addition to that, weight loss treatments and biosimilars all were at the forefront. These categories also continue to dominate costs, requiring us to really just adapt our strategy. So we explored various options with the vendor with our vendor selection process. We recognized that we were going to have that true clinical expertise. Our prescription drug choice transparency would be at the forefront. We were going to get that robust member support. And of course, the strong ROI that is truly helpful in presenting this to some of the key decision makers within the company. And it just overall aligned with our corporate vision. Our PBM and our broker were on board, highly recommended the vendor as our trusted advisor with the prescription drug landscape. We really delved in, and we knew that the formulary being used was going to help us have that solution. So if I can get this right this time. Yay, I'm getting there. All right, so we had opportunity, right? About 2,000, just over 2,000 of our 7,000 employee base were enrolled into our healthcare program, which aligned and concurrently, obviously, with prescription drug coverage. Of those, we had about almost 1,300 that had prescriptions. So we had already we knew we had an annualized spending of over $4 million, and we were going to see a capture rate that would yield us, hopefully, the projected just over $600,000 in savings per year. So, they really exceeded our expectations by about 12% with that total savings. They offered us some very good choices and options, like staying on top of your current meds while using a coupon and filling at a cheaper pharmacy, getting a new prescription for a different dosage, like gels or creams, potentially getting a higher dosage and then splitting those tablets, AKA the pill split technology, as a savings message, obviously, and switching to a generic or just looking up new scripts that were comparable and more economical. We did things like being creative. We created that nice video with my colleague so that associates had the process very simplified for them, how it was going to benefit them, how to enroll in the program, and why we as a company chose that program. I really did experience a true wow factor. It was a clear implementation. We had ready to go communication, multi-channel rollout, a seamless coordination with our broker, our PBM was on board, strong engagement truly right out of the gate. It is what I call a true clear purple dot experience, which was the campaign we used to create awareness, to offer this prescription assistance to our associates. It was a significant impact on their overall well-being and productivity, right? They're on their feet all day, selling our product, and they just needed to know that we were there for them when they needed us, and that whatever the prescription was, we could help them navigate to landing the treatment that they needed. So, by implementing this well-structured program, we helped staff in tremendous ways. And the reveal is script, AKA Purple Dot, which they don't have, but they are in the back. Please take a moment to visit them, and thank you for your time.
Thanks so much, Elisa. And last but not least, we have Andre speaking on behalf of Tyson Foods.
Hi, everybody. I'm pinch hitting here the last hour, so bear with me. And also, I know I'm the last person between you and lunch, so I'll get this going here. And there's a clicker. So Tyson has always demonstrated a strong commitment to the health and well-being of its employees through a comprehensive array of programs and benefits. They undertook a total HR transformation in 2023, and they wanted to reevaluate all employee benefits to ensure that they were truly servicing the needs of their 183,000 members. They wanted to tackle the rising pharmacy costs. As you all know, GLP-1 and specialty spend, certainly they were seeing a 12% to 14% annual increase, driven largely by those specialty drugs and GLP-1 medications. They were facing challenges with their former PBM as the PBM could not provide the transparency that they needed. There were no clear answers or access to detailed claims data, and the lack of visibility left the benefits team at Tyson Foods unable to make informed decisions. They also wanted to make sure that they're taking care of their members. They have 120,000 employees speaking 62 different languages, 65% of which live in rural areas. So they needed a solution that was equitable, accessible, and scalable. And then there was also a lack of innovation, no cost management solutions from their previous PBM partner to combat rising costs of specialty drugs. So all of these compounding issues really pushed Tyson to look for a strategic PBM partner. Tyson Foods wanted a partner that had unmatched member experience, providing personalized clinical support to members to really guide them to high quality, low cost drugs. They were looking for a most aligned PBM model, one that increased transparency by providing an aligned pricing model with no hidden costs, while also providing members access to high quality drugs. And they were also interested in implementing innovative cost management solutions. And then they were looking for better clinical rigor. So they wanted a partner that could collaborate with their 8 health clinics that served 40,000 members. So really, they wanted to guide members to better outcomes while driving down their costs is really what was a key value for them. And then also with that, they wanted premier transition support. So they really wanted a partner that could provide implementation support given all the simultaneous transitions, because they were also navigating a new medical carrier, a new fertility benefits provider, and then they were also experiencing consultant changes as well. So they really wanted to try to streamline communications, minimize confusion from employees during that transition, because, you know, one transition is one transition, but if you're managing multiple transitions, that can be probably pretty burdensome for the HR team, but then also for their employees as well. So once Tyson made the decision to onboard to their new strategic partner, they prioritized high impact changes. So they were able to cut their pharmacy costs by providing members with more affordable options at the point of sale. They brought their GLP-1 management under control by doing some things such as eliminating inappropriate claims for patients that don't meet criteria for that, limiting 30-day supplies, and then guiding members to weight management and lifestyle programs. So it's not just one thing to provide the drug, but then also surround them holistically is really what was core and critical to Tyson Foods. And then they also increased transparency just by being able to operate as a fiduciary to maximize savings. They were able to identify top cost drivers in their plan, and they deployed cost-cutting solutions. So they were provided with straightforward reporting from their PBM in order to make informed decisions on acquisition costs and overall spending on high-cost drugs. They found a PBM that was truly neutral, which enabled use of any pharmacy location, not just those pharmacies owned by a specific PBM. And they were also able to just improve cost transparency and reduce member confusion all around. And then the most critical thing about this is that they were able to integrate with Tyson's on-site clinics, empowering them to prescribe cost-effective medications directly and working directly with the PBM, cutting out any sort of feedback issues. They were able to go directly to the PBM. Collaboration, streamlined prior authorizations, and an overall improved care continuity. So they were able to use proactive overrides to resolve urgent access issues, and then employees experience a seamless connection between their providers and then also the pharmacy. And then just want to touch on biosimilar transition as well. There was a lot of hesitation around Humira. They were hesitant at first because of all of the changes that they had going on internally, but they were able to launch a mid-year switch to biosimilars, specifically Humira. And in 45 days, 100% of their members transitioned successfully. So that resulted in annual savings post-transition of $6.4 million, which is staggering number. And then it just overall transformed the member experience. They were able to conduct outreach and educate their members in preferred languages. Pharmacist teams provided support via phone, email, or through an app. Members also received real-time help resolving coverage and access issues on demand. And then the clinical programs support members with chronic conditions and medication adherence, and again, just wrap them in that holistic care that they were looking for and that they weren't getting from their previous PBM. So I say all that to just kind of wrap it up here. You can see the results on the screen. You know, within a year, Tyson Foods achieved $17.3 million in year-over-year pharmacy savings, 13.5% reduction in pharmacy costs, member out-of-pocket savings, 4.5%, 100% satisfaction from their internal benefits team during the implementation, because benefits teams are pretty lean. And so the PBM lifted kind of the burden from that team during the transition. So the main takeaway for other employers is clear. A transparent member-first approach doesn't just control costs, it also improves the experience for employees. So thank you. And I'm from Right Way, but that was just from perspective of Tyson Foods. So just want to make that clear.
Thank you so much, Andre. Really appreciate all three of your insights. And I would tell you, starting perhaps with you, Amy, just to tee up some questions and get your feedback. The common denominator is everyone's seeing escalating costs on their pharmacy spend year over year with no end in sight. So, Amy, for you, There are many ways employers try to rein in the pharmacy drug spend. What stood out to you about a more proactive pharmacist-led model? That'd be with Walrus, of course, which was the big reveal.
Not sure. Is this working? Okay. Yeah, I think what stood out to us was really removing the barriers to care for that proactive model. We really just wanted to work with another vendor that fit within our strategy to find somebody that could help our employees with a resource in ways that our PBM couldn't. And so I think that proactive, personalized touch, getting the additional education out available to employees at their fingertips was really key, very innovative, and providing, like I said, employees with that resource to help manage their day-to-day life, which, really provides them with that empowerment to help their overall health and outcomes and further, reduce their side effects in the long term and spend as well.
That's wonderful. And Lisa, one of the key considerations for any employer when they're contemplating perhaps implementing a new vendor partner is, what's the burden of the lift? Is it, heavy lift, low lift? Particularly with what you shared with us on Scripta, it appears based on, the experience, the implementation process was an easy lift. Just curious, did you get any member feedback and how communications with the members was coordinated to really ensure a smooth transition for everybody to take full advantage of it?
Yes, Jason, I agree. Definitely an easy lift. And employees started getting on board almost ahead of time. So just the project plan that was laid out really helped ensure that understanding. And to the point, to answer your question, I did get calls, how did we go about this? What caused this? And I says, your voice is being heard. And so then they started receiving their savings reports, and that really helped them settle well with knowing that it's working, right? And that they have other alternatives that can be, economical for them. So some great feedback, yes, already just in the first about 3 months.
That's wonderful. And Andre, why was transparency such a critical requirement for Tyson Foods in selecting a new PBM partner in Right Way?
Can you hear me? So I think they were just going through a lot of things internally, certainly those changes that I had mentioned, but then also when they're looking at their spend overall and seeing that the costs were going out of control for them, they really wanted a partner that could provide that transparency, give them that data that they were looking for, so that they can make informed decisions on behalf of their employee base and their members. And I think that was probably the most critical thing for Tyson Foods in selecting their partner.
And I'll stick with you for one more question, Andre. What advice would they give on communicating complex benefit changes clearly? Obviously, there was a range of transition that they had to understand and, know where to go for what. And, if you could share some perspective on that, that'd be great.
Sure. Speaking on behalf of Tyson Foods, I think making it simple, making it scalable, and just making sure that you're communicating with the employee base, because they're likely in the dark as well. They probably don't know what's going on. So making sure that you're keeping all lines of communication open, whether that be through direct mailers, phone outreach, email, just making sure that you're communicating these changes early and often will be helpful in minimizing or mitigating disruption, because nobody likes change. But if you're able to be proactive with your approach and what you're doing, I think that can really make a difference for your employees overall.
That's great. And Amy, what advice would you give to other employers who are feeling stuck when it comes to pharmacy spend escalating year over year?
Sure. I mean, that one's tough. We're all dealing with costs that we can't control, that we've heard a lot about today: litigation, PBM pricing models, GLP-1s. I think the advice that we've taken to heart is really just to get the information out there, coming to forums such as this, networking with your peers at MBGH, Just trying to get all the information that you can at your fingertips, learning about the market space, what's new. Don't be afraid to, reevaluate your programs and make sure that your partners fit within your strategy, cause disruption, but really just be sure you're really getting all the information.
That's great. Now, Lisa, one thing that I found very impressive with really all three of the presentations, but certainly yours as well, was it appears to me, it was clearly evident that you're all demonstrating quantitative outcomes. You're tracking improvements and savings. And, there was a list of different opportunities that offered perhaps maybe medication optimization, improved adherence, perhaps switching to a lower cost medication. So all that, to say there's a range of good, but from your experience, perhaps what advice would you share with, the other employers that are here today in regards to, your experience with Scripta on a go-forward basis?
Well, obviously it was a great experience, so I definitely would recommend Scripta. But when it comes to my experience with them, they just laid out a great project plan, all of the materials. For us being a retail organization, it's very important and usually hard for us to navigate getting communication out. It can be very costly, but we did plan in to do mailing, so we did both to the home using, I can't say it enough, the purple dot, because that's what I always say to our associates, as well as to the stores. So we had posters in the stores that clearly communicated these savings and how to navigate getting enrolled, because we didn't want to do a forced enrollment. We wanted them to do it on their own and just know, we're not going to send out another abundance of email communication. We're just going to make you aware that we have this great offering and afford you the ability to sign up. And we're seeing an abundance of voluntary participation, which I think is great, and it solidifies the direction that we went with.
Okay, Andre, what's one decision Tyson made early on that proved critical to success?
I think for Tyson Foods, involving their on-site health clinics in everything, creating that like feedback loop between the clinics and then the pharmacy providers and members, they're really able to drive better outcomes for their employees, and then while also minimizing costs and reducing costs. So I think that probably was a critical element of their whole implementation, implementing those 8 health clinics with the PBM.
And then one more for you, Andre. How have these results influenced Tyson's broader benefits philosophy?
I think overall, just looking at their experience from the prior PBM, there was a real need for data and having that data to really drive true health outcomes. I think that's probably one critical piece that they probably would say, being able to get that data can really help you manage your benefits, but then probably other areas of their benefits as well, just by having that data to drive solution.
That's great. And Amy, obviously there's a range of PBMs, there's a range of vendor solutions in the marketplace. So when evaluating partners, what were you hoping to achieve for your team members and your organization that ultimately obviously led you to Walrus and seeing the great outcomes that you've seen?
Sure. So we spend a lot of time talking with new vendors that are innovative in the employer market. And so we really liked that Walrus was innovative and gave us that ability to add that additional resource for our employees to identify that gap in care that we felt we saw. Internally, we do have a lot of vendors within our ecosystem. So when we look to vendors, we also feel it's really important that they work together. So we'll often, when implementing, set them up on a call with some of our other vendor partners, or maybe they have referral sheets that they share with each other. So we do feel it's really important for our vendors to get to know each other so they can make those warm handoffs and referrals within our ecosystem. We're also cognizant that adding in new vendors in our space requires another login, another username to remember. So we really want to make sure that we're working with somebody that will bring in that value to make that worthwhile, to create that additional step if needed for our employees. And lastly, I'd like to add that we're pretty focused on our communications at Fortune Brands, and we like our vendors, to work with us on those communications to really ensure that we're reaching our diverse workforce. A simple marketing strategy just doesn't work for our population. Similarly, we have manufacturing where we need to reach outside of, in email. So working with our vendors to provide those targeted communications is really important, and Walrus does that for us.
That's great. And before we wrap it up here with our questions and answers, we're going to open it up for you in just a moment. But Elisa, any final thoughts or words of wisdom to the employers out there or the consultants?
I think we are finding that there are many great options out there today, and the three of us are speaking to that. And, this is a great opportunity to visit each one and make, hopefully make the next choice for you, and that we're available for questions as well as the vendors that we chose. Employees need us. They value our expertise and our diligence. And if we put our minds to it, we have the resources available to utilize and get them where they need to be health-wise.
Awesome. I would just also suggest to everyone out there that this year is probably one of the hottest PBM RFP selling seasons I've ever seen in my career, which is awesome. I think it creates opportunity for everyone. And the question becomes, you don't always need to pick a PBM, implement, and then try to figure out, does it make sense to perhaps layer in, like 1 year later, another solution and another solution, another solution. I would tell you firsthand, I deliberately took the approach to tuck in a solution that could supplement what my PBM choice was back in 2021 at Boeing. And it worked seamlessly, and it harmonized the communication altogether. So I would just encourage you, don't feel like you have to stagger it over time to contemplate these solutions that we talked about today in concert with perhaps others that could fit into that ecosystem on a go-forward basis. So let's open it up to the audience, virtual or in person. Any questions for our panel here today?
I think everybody's hungry. They want to go to lunch.
Awesome. Well, thanks so much for your time. Have a great lunch. We'll see you later.
Sorry. We have another sponsor message. This is a complex problem. Like Cheryl said earlier, it's going to take a multi-layered, solution, and getting started, taking those steps, researching, baby steps moving forward. If it seems like too big of a mountain, there's something you could do. So with that, I'm going to share one more sponsor message before we go to lunch.
Looking to lower your pharmacy spend? When it comes to evidence-based pharmacy risk management, RX Results does all the heavy lifting. Our proven Take Aim model gives you control to significantly and immediately reduce your pharmacy spend. Take Aim Step 1 is Analyze. A good plan starts with knowing where you are today. Leveraging proprietary informatics and clinical expertise, RX Results identifies trends, highlights concerns, and turns your claims data into actionable insights. A pharmacy risk analysis provides a clear line of sight into your plan's risk and exposure. Are you ready to take aim and take control? Reduce pharmacy spend. All you need, all in one place.
All right, great. So make sure you get those prize cards on your table filled out. Visit the exhibitors. We've got Mark Plager back here in the back, also with MHPC. You can say hi to him. And we will reconvene about a few minutes before 1:10. And Cheryl's got one announcement as well.
Some of the pharmaceutical companies that we work very closely with on our project and in other ways have created resources for cell and gene therapy. I was reminded that J&J have a great toolkit She's going to be Rebecca Lucan-Stewart, my colleague, will be putting information on the table. I'm inviting any pharma member to send information to us. We will be using it as part of the action brief resources we've already created. And I'll be talking a little bit more about our employer action brief on ultra high cost therapy shortly. Enjoy lunch. So we couldn't have a pharmacy benefits program without something about biosimilars. And that's especially relevant to us because over the last 2 years or 18 months, we've worked on a pretty progressive biosimilars initiative with a group of our employer members and tracking their stories. And Sandoz is a biosimilar manufacturer. And April, are you like on a medical liaison kind of outcomes person? So she really understood where the skeletons were buried, and we were able to address some of the challenges of that. And if you have not seen the employer action brief we launched about in April, I think, of this year, check it out on our website under resources. I don't know if it's in the app, but we do have a link to it on this PowerPoint. So let me start by introducing April. Then I'm going to tell you just a tiny bit about the project. And then we're just going to do a rapid fire Q&A for about 15 minutes. And then we'll move on to our next session. But I didn't want to miss out on having us share a little bit about this. April Kunze serves as the Director of Medical Market Access and Strategic Alliances at Sandoz. In her role, she is a field medical expert to leadership of managed market and strategic alliance accounts. She provides applicable clinical data and real-world evidence regarding Sandoz marketed and pipeline products. So, as I said earlier, for 2 years or so, we've been focusing on this project to work with an employer advisory group. We wanted to identify best practices in the biosimilar space and where the landscape is today. And this was important because employers as plan sponsors are fiduciary. And it's that F word again, and you're going to hear me probably say it again and again and again. But if we're not delivering the best product at the best price, we're putting ourselves at risk. So I am going to sit down with my microphone. Sorry, guys. And we're going to banter. Okay. I want to level set. And let's start a little bit about what the research says about the clinical efficacy of biosimilars versus branded reference products, as you would call them. You shared with us during our April when we launched the employer action brief that switching to biosimilars has no impact on clinical outcomes for patients. What does the research say?
So that's a great question. And as you guys may or may not know, biosimilars are somewhat new to the US. In 2010, the BCPIA was written to allow for biosimilar development and approval. And since that time, the first one was launched in 2015. So we're 10 years into this market in the US with launched products. But globally, they've been around for quite a while. And if we look at the Association of Accessible Medicines, they did a report in 2024, and they noted that there were no unique clinical challenges, specifically meaning no differences in safety or efficacy, now that we have over 3 billion days of patient experience. So if you think about this is in 2024 with the launch of Humira biosimilars, or adalimumab, as I'll refer to them. Those patient days have gone up quite exponentially. And then we've recently launched Stelara biosimilars in the US, or ustekinumab. And so I think we're, starting to exceed probably into my guess would be 3.5 to 4 billion patient days. On top of that, it's allowed access for over 500 million patients that could not have had therapies before to now have therapies. So it's making healthcare more accessible. And then the last point is that there's recent information because of the robust data we have globally and within the US. There's been many published studies, meta-analysis, et cetera, that have said that because there's no differences in safety or efficacy, they're no longer requiring clinical trials or the phase 3 clinical trials for FDA approval. on some molecules. So it's still a molecule by molecule decision, but we have some exciting ones in the pipeline where they've actually said you don't need to do the phase 3 clinical study as long as your analytical characterization and your pharmacodynamic and kinetic studies are up to par. They will approve without that phase 3 data because it's been so good.
Excellent. That's great news. During the project, you helped us understand some of the challenges and opportunities employers have had embracing and increasing adoption of biosimilars, and the stories were outstanding. More importantly, we wanted to learn how they could work around those things, especially with their PBMs who, make more money on brand drugs in some cases. What were the key pearls that we learned from our employer experts in the group around these challenges?
Yeah, so it was really fun. And this is part of the reason I started working with you, Cheryl, from MBGH. As Cheryl said, I work with Sandoz right now, but I came from the PBM space, developing formularies. And it was always a struggle, right? There's this push and pull, and that's been noted many times here today already. So it's been really fun to hear what the employers are doing and how they're getting creative with their solutions. So we heard one employer that gave cash incentives. So they worked with their PBM to give up to $1,000 for the patients who switched. And they found that highly successful, and they still saw quite a bit of savings to the health plan or to the employer themselves by doing this, but it really reduced that noise, right? So the members were actually asking, can I switch? Can I do this? Will I get the cash card? And it was kind of staggered. My understanding was $500 at first fill and then $500 on refill. So it was not just a one-time, but to keep them on therapy and moving forward. So I thought that was a really creative solution. Another thing they did is they had a nurse navigator that went with them to doctor's appointments and would help them through some of the challenges. And so if their local physicians needed to be educated, that patient could take the nurse navigator with them to their appointments. And that also helps smooth the transition into biosimilars. So that was a creative approach by a relatively small employer, like mid-size, I should say. Another one decided to direct contract. We've heard that today. And that's a novel thing within the, from a manufacturer standpoint. I can tell you that challenge the manufacturing from a sense of, oh, wow, it's not just access to the PBMs, it's access to employers directly. And so that was a way of kind of changing conversation, if you will, within this space that was really exciting to hear and learn from. Another employer worked with their PBM to customize their formulary. So we heard earlier that you don't have to make every decision, but you can make some decisions if you want to, and others fully customize. But they have a solution to support biosimilars. They customize their formulary to have a biosimilar only strategy right away, like right after the adalimumab launches. And they had a high deductible health plan. Most of their patients or their members were high deductible health plan. So the patients or members saw that immediate reduction in their out-of-pocket costs. And so without doing a cash incentive, they were able to basically incentivize them through their lower out-of-pocket costs. So all three of these scenarios, every one of them said the thing that was surprising is there was essentially no noise. The employees were happy with the changes. They were easily transitioned and had over 90% conversion.
And I assume the employees or family members were also paying less because they were on a biosimilar.
Right.
Out of their out-of-pocket. We know that some intermediaries like PBMs don't want to integrate biosimilars into their formulary because they make significant rebates. And I mentioned this earlier from the branded products. How can employers demand this switch?
That is a great question. I have loved hearing and seeing the discussions about biosimilars interwoven throughout this whole conference today as one of the biggest cost savings measures, right? But I will say this, that the IQVIA report from April of 24 noted that high volume biosimilars see most fills and favorable coverage at non-big three PBMs. And so as we've seen, the big three tend to focus more on rebates, whereas we've heard others that focus more on low cost. I thought the presentation by the lawyer was amazing because that's one of the big things that I think from a transparency perspective, when you look at rebate guarantees, even though they say they're passing 100% back, that's just with the PBM. And so that vertical integration we saw on that slide is really what employers need to know and understand, right? Is that if the rebates or any sort of fees are based on a percentage of the WAC, a biosimilar will never be the most advantageous financial situation for that payer, right? However, for the employer, you are going to pay more because you're not going to get those rebates back or those fees back. You're going to be paying that, right? Because you're paying for the script. And so I think one of the big things is to understand how the integration is, where the fees are, and also how different PBMs or different models may take some of those pricing aspects out and instead do flat fees instead of based on a percentage of WAC. So I think the biggest thing for employers to take away today is just understand where those dollars are going. Follow the money. I've heard you say that a lot. Follow the money. And so you'll see, we've seen health solutions and other things here that have really are removing parts of those vertical integration pieces and managing just those specific things and able to show quite a bit of savings.
Excellent. I'm skipping a question, so don't, read your notes on that question that I'm skipping. Part of today's program is about ultra-high cost therapies, and oncology drugs fall under that category. Talk about what's going on with oncology biosimilars and what does the cost saving look like for employers?
Yeah, so oncology biosimilars is an exciting frontier. We're starting to see more and more come off patent. In 2028, 2029, Keytruda and Opdivo will both be coming off of patent. And so there's multiple biosimilar manufacturers already developing in that space. And in fact, Keytruda is one of the drugs that the FDA has said that to many manufacturers that they don't have to do the phase 3 clinical development, the human trials. So that will make the streamlining process a lot better for manufacturers to bring them in a more affordable and faster way. However, patent thickets, as you know, a lot of these oncology drugs have multiple indications, and so patent thickets can really slow things down. So there's some legislation right now on the Hill that they're trying to minimize those patent thickets. In the US, some of these patents are between 35 and 150 patents, and a biosimilar manufacturer would have to win against all of those, not just one. And that's why we see a lot of delay in the US compared to some of the other countries. So the oncology market, I will say, is one of the best adopters of biosimilars. Oncologists have been very pro-biosimilar. We've seen with rituximab, Herceptin biosimilars, trastuzumab. And so it's one of those markets that's a good one to be in because they see the value, they see the patient accessibility and cost reductions.
So this is going to be a rapid fire because I want to have time for one or two questions.
Yep.
What does the biosimilar pipeline look like for all drugs, and especially for high cost specialty drugs? And where do you see them headed?
Okay.
Part, but you got 1 minute.
Okay, I can do this quickly. There's a good news and a bad news to this question. The bad news I'll start with first is that when you look at biosimilars in general, there's 118 biologics that are expected to lose patent protection, which is about 235 billion in sales opportunities for biosimilar. However, if you look between 2025 and 2034, right now, there are only 12 molecules set to lose patent protection that have biosimilars in development. So this shows you this whole sustainability issue, right? Like we need to make this easier. We need to have a sustainable market. What I can say is that in 25, we've seen 3 biosimilars that have come to market: Stelara, ustekinumab, Prolia, and Xgeva, which are denosumab biosimilars, and then Xolair for asthma and immunology. So that's 3 in 1 year, which is great. We expect to have some more in MS, diabetes, and other TNFs and interleukins for autoimmune disease. And then, like I said, hopefully we'll clear the path in the future here, make things a little easier so that more of those molecules coming off patent will have the opportunity to have biosimilars. But it's got to be sustainable.
We understand. We have time for one very brief question and one very brief answer. Do we have any questions in the audience? Well, if you don't, I want to hold up the brief and I want to encourage you to take a look at it because there are full-page stories in this brief from the 3 or 4 employers that work with us on this project. And they were extremely, extremely passionate about it, passionate about what they discovered, how they got around it, what changes they had to make, what frustrations they had, and what their outcomes were. Let us thank her for tolerating this rapid fire. Okay, so I am now going to introduce the person, wait, let me switch. The person that has worked very, very closely with me on this project that I have been talking about. Tom Sondergeld is a global benefit leader with over 30 years of experience in transforming the program structure, strategy, and distribution mechanism at jumbo employers like Walgreens, Aon, and Hewitt. He has been consulting with innovative startups, transparent PBMs, employer groups, and large employers, using his years of benefit leadership to help businesses improve offerings to members and users. He is a past board chair of MBGH and a board member, and he is currently advising us. And I am very proud to be working with you, and I am grateful. And I did, over Memorial Day weekend, have his teacup Yorkie for 6 nights. Adorable, just like having a baby. Never could leave him, but he was adorable and I loved it. Come on up, Tom. And while Tom's coming up, and why don't you ask or I'll ask our panelists to come up and get started. I have a sponsor message from Employers Health. Employers Health is a leading group purchasing organization for pharmacy benefits. As an independent employer-founded organization, Employers Health is aligned with the interests of our clients while remaining transparent in our business practices. With more than 400 clients across the country and working with PBM suppliers, CVS Health, OptumRx, and Med Impact, Employers Health provides the expertise. You guys can come up. Come on up. I'll give you a hat. Expertise, guidance, and increasing purchasing power that maximizes the value its clients achieve from their pharmacy benefit plans. And we've had Employers Health in our purchasing arm for quite a few years, along with a few of the other vendors that you see here today. And I shall now move forward to that and then that. Thank you.
Yes. So great, everybody. So just to recall from what Cheryl said, our resources are listed on the app. If you look down to resources and then you go to action briefs, you'll see our newly posted action briefs on cell and gene therapy. But I'm happy to have these 3 experts here, one of which I found recently just through reading an article and contacted her through LinkedIn. So Erin, appreciate you being here. Greg and Kirby, longtime friends and colleagues and know this business really well. We're going to kind of turn our attention to the actual funding models that employers are starting to see, or we're starting to see in the marketplace that might solve for some of these massively charged drugs, but have tremendous value. And I want to kind of call that out, and the group will call that out as well, because while these things cost a lot of money, these are transformative drugs that change people's lives. When do we ever get to do that well, right? A GLP-1 doesn't even touch what these things can do. So I'm going to turn it over to each of them, have them introduce themselves. I'll start with Erin, and just introduce what you do and how you kind of play into this space. And then I'll bring up the funding models and we can take a look at them.
Thank you. Hi, I'm Erin Lapata. I'm with a company called Precision AQ. What we do is help to support life science manufacturers in bringing products to market and supporting gaining access primarily through payer coverage, but we think a lot about the employer perspective as well, given that you guys are the ultimate payers. And so as part of my job there, I had the opportunity to leverage some of our market research capabilities. And so over the past, 5 years now, I've done a number of research opportunities, some in collaboration with the Academy of Managed Care Pharmacy, in really understanding where both health insurers and employers are in adopting some of these models. And I've also done work in digging into what have the challenges been to date with these models over time. So excited to hopefully share some of that today.
Good afternoon, everyone. So I'm Kirby Yang. I'm a pharmacist by training, and I work for a company called Outcome RX. And first of all, disclaimer, we have nothing to do with PBM, specialty pharmacies. We do not dispense any drugs. So what we are, however, is an independent company, and we are an insurance company. We only focus on cell and gene-based therapies, no GLP-1s, thankfully. So besides the reinsurance portion of what we offer for cell and gene-based therapies, we also incorporate a very intensive cost as well as care management solution as well. So with that, I'll turn over to Greg here.
Thanks, Kirby. I think when they were trying to put the panel together, they're like, we need somebody who's cute and sweet. And they unfortunately picked me, and I don't even think I can fill that gap because I'm not near as smart as
That's
the rest
why
of the
I'm
folks
here.
up here.
That's
I was trying to steal that, Tom.
Aaron.
I wanted
Aaron.
Yeah,
Aaron.
yes. But I like Kirby, I'm a pharmacist by training. I work for a PBM, but we have spent a lot of time looking at the cell and gene therapy space, thinking through it as far as it relates to, I really liked the intro here. We've got these curative therapies that are not being used. And I think there's a better path forward. And I'm excited to be part of this panel to talk through what that might look like.
Yeah, so for the next 20 or half an hour or so, we're just going to chat. I don't have a preconceived concept here. I maybe have a few questions, but really I want to kind of bring up the financial models that we have identified that we could find in the market. There's probably more because there's a lot of development. They're in the brief. If you want to call these up, they're both in the snapshot and in the brief. And we really think that these are the next wave. And I'd really like the group to talk about initially for a couple of minutes, the one that you think has probably got the most promise for where you tend to reside. You all have different focuses. Kirby. I'm not working. Am I not working? Does this work? Oh. I've never been told that before. I usually am pretty loud. We have these two sheets. I'll show the first one, just cover them all. There's amortization, outcomes-based, reinsurance, and then we have the next four with subscription models, warranties that pretty much come from the manufacturers, risk pooling, the MERP that we talked about earlier that we were researching, but now there's so many of them, we're going to just rely on some third party, and then third party contracting and negotiating. So we'll go backwards this time. I'll start with Greg. Greg, if you want to just start and pick one or two that you think are the most promising or where you see, or if there's someone we missed, we'd love to include more.
Yeah, no, thanks, Tom. I suck at following directions too, because I think especially as we look across the room, right, there is not a one size fits all approach to this. I think there's plenty of options out there because we do need options. We work with Luke at AT&T, and he's a great guy. If you don't know Luke, you should get to know him. If AT&T got a $4 million cell and gene therapy hitting their, benefit somewhere, he wouldn't even notice, right? Like it's just not even impactful to how much AT&T spends on benefits. But at the same time, if you went to Luke and said, we've got this, PMPM model that you can build a risk pool around, and we want you to enroll your 400,000 employees and dependents, and he's going to be like, no way in hell. Like it doesn't make any sense for him to do it. So I do think having these choices is starting to at least allow employers to say, what is my own risk tolerance? What do I want to do? Maybe I do want to have a PMPM model and I just want to not think about it again. And I know that our risk is taken care of. And I know exactly what that amount's going to be every year. And I can talk with our CFO and it's taken care of. Other employers might be okay taking on the entire cost of that just because they're a different size group, and that's okay. And then I fundamentally think there's probably also people in the middle who I've always equated in simpleton terms to like, they're okay buying a beach house, right? Like you've always got the second home. You probably don't have to buy the second home every year. And at the same time, I don't want to have to pay the full cost of the second home today. And I want to be able to kind of mortgage that and, put my risk over the next couple of years and not take it on a single year of the balance sheet. And I think there's a lot of different ways it's going to continue to play out. But I like that we put up the options because I think the options really matter because depending on what you guys need for your own company, one of these options is going to be right for you. And I don't think it's, as I said, a one size fits all approach.
Yeah, I think you're absolutely right. I think I was talking in the back with a group on my table, and it is not going to be one answer. Like, if I was back at Walgreens again, it would probably I'm going to leverage the warranties, leverage maybe some risk pooling, maybe on some classes that are really risky for me that don't get lasered out of a stop loss provision. And then maybe look at some patient navigation like Kirby's team does. That really, this is a complicated process. Read our brief. There's a section in there. Go look at some of the great work that companies like Johnson & Johnson and a few others are doing that have they put the card on your table. They have cell and gene therapy pathways, and they're talking about the patient journey. That patient journey is really important for us because not only it is the therapy, they're gone from home and they're probably taking a family member with them. You have to pay for that. Their quality of life changes. Their comorbidities have to be cared for while they're away. So this is going to be a lot of different things. And I think that you're absolutely right, Greg. I love the way you framed that. Kirby.
Yeah, so every single employer is reviewing or planning for next year's benefit plans. Those of us in the insurance business call this the selling season. And so being that what it is, the looking at all the different options that are available, what it's telling us is that today, and even into next year, there is no single best-in-class solution. There's a lot of parts and pieces, and it takes a very knowledgeable broker or benefits consultant or even a TPA to be able to cobble this together based on what every individual employer needs are going to be for cell and gene-based therapy. Most important thing is make sure that you cover the product. I mean, I saw a survey from MBGH that said over 90% of employers surveyed feel that covering CGTs is the right thing to do. And so these are individually solutions that may or may not be available to employers or only certain employers. So navigating through what's available and then customizing it to fit your particular, whether it's risk mitigation, whether or not it's improving the member experience or patient experience, that's going to take some careful planning and navigation with somebody that really knows about cell and gene-based therapy. So for those of us in the insurance business, as we're heading into the selling season, stop loss by far and away is the first line of defense for these excessive costs. It's not innovative. It's been around for a while. But I think it's important to understand there's stop loss and then there's reinsurance. Those are not two of the same products. There's very specific differences between the two. And we think that what we're seeing is that a combination of stop loss and reinsurance. And there's many different permutations on how that could work itself into. And so again, working with a really capable, knowledgeable, experienced benefit consultant or broker is paramount to choosing the right solution for this coming year and the year after. What happens after that? We're likely going to see continued innovation in these payment models, and we'll get closer to that elusive best-in-class solution.
Yeah, and I think one of the things important to point out is we found this to be the case too, is that, you know, stop loss, there's some condition specific stop loss that's coming out where the vendor or partner is willing to put risk on the plan and carry the risk for carrying the disease, right? And getting somebody to a better place. So there's some really interesting things coming out from stop loss in that area as well that you should be aware of. Erin?
Thanks. At the risk of sounding like a broken record, I definitely echo the comments of the panelists in that there's not, a one size fits all solution. I think what I want to add to that is, I think part of the reason is that these various models are all, at least the way we have them kind of broken out in these components, are solving for different things. So in some of the survey work I did in looking at where the priorities were for both employers and insurers for these models, the number one need is helping to manage the actuarial risk. So we talked about how these are lightning strike events. It's hard to predict when you may see a claim given the small prevalence of some of these conditions. So helping to manage that. The second is helping to address the cost. I mean, let's be real, we're talking about therapies that are millions of dollars. And so helping to support that affordability is important. Tracking outcomes data is a critical piece of this. And some of the tracking is most important when we consider some of these models that are outcomes-based or performance-based. That means that payment will be tied to the patient's response to therapy. And going back to the point that I think whether talking about stakeholder to stakeholder or product to product, there's going to be a need for different models. So within some of these products, the science is exciting. The mechanisms, there's proof of concept for the mechanisms that they're going to do what they're supposed to do, but there's still a lot of uncertainty about will patients respond? And then the million-dollar question in my mind is, how long will that response last? What is the durability? And so being able to track the outcomes is critical for, again, these contracts where payment will be tied to that. But I think as healthcare stakeholders in general, we're also very invested in understanding the science of some of these products, definitely with things like gene therapies. But even when you look into the oncology pipeline, we have personalized vaccines coming to market that are going to be used very early for early stage disease as part of adjuvant care, right after a patient gets the surgery. And so I think there are a lot of questions that we need to answer, such as what is the value of that over time? And then tracking those outcomes and thinking about the portability of both the contract and being able to manage and track that patient over time is a big challenge that has come up as we've asked different stakeholders around adoption of these products. And then last, I know we've talked a little bit about the coordination of care and the need there. So again, all of these different models kind of do different things. And so I think some of the solutions we're seeing in the marketplace do bring some of these pieces together through a vendor to make it easier on the employer or the plan that's kind of putting these into place. So I think that's where we're probably going in terms of what will be available. I think, another thing I wanted to share is some of the findings that we had around what was like trends in interest of these different models. What I thought was really interesting the last round that we did the research was that the annuity and amortization models was growing. I think this is one that probably has some of the biggest challenges to implementing because you're spreading that cost over time. There's a lot of questions about what happens if the patient leaves, an employer. How do you track that patient over time? How do you even get that data, right? And when we're thinking about tracking outcomes, what does that even mean? How are we going to, be able to define whether someone's responded or not responded? So these are all questions that I think everyone is committed to working through. But tracking that over time is definitely going to be a challenge. And so, but we've seen a lot of interest in this. So where we only had about 21% of our respondents utilizing or, at least starting to have discussions around those contracts, the respondents that were looking to implement that over the short or the long term was about 58%. So that's, to me, a very fast growing area. What's also interesting about annuity and amortization models is they sometimes are not compatible with stop loss. So there's some concerns there because the stop loss is usually based on an annual contract. And so there's more complexity to kind of work out there as well. So I do want to call that out for this group. Warranties is another model that's really increasing. And one of the reasons there is it's, to me, one of the easiest ones to put into place because it doesn't involve alignment of stakeholders on a contract or terms. Essentially, the manufacturer just offers that warranty as a guarantee to provide payment should the patient not respond or not reach a certain performance milestone. And so these are a little bit more simpler to get stood up, but it also takes the opportunity for the employer or other stakeholders to kind of have a say in what they're looking for within that contract. The other concern I sort of have around those is like oftentimes the patient or the provider have to be the ones to submit the claim, should the patient not respond. So I think there's just a lot of need. It kind of goes back to the coordination of care and making sure you're monitoring and tracking these patients. And so should you have a patient that doesn't respond adequately, making sure that the payer, and in some cases, the patient can be refunded some of the costs associated for the therapy. So I think that just kind of goes back to, there's a lot of opportunity, I think, to have multiple models utilized because they are all addressing different aspects of the concern here.
Great, thank you. And I think we'll also get you a link to Erin's paper, the paper that she did with her colleagues. It's really well done, and that's why I wanted to bring her here today. These guys have all done a great job. So I want everybody to do something really quick. I just want you to shake your arms, shake off that pricing problem. We're going to shift away from cost. Cost doesn't matter. You're now at Boeing, and you've got a lot of money. And your plan is $2 billion. So who cares about a $4 million claim, as Greg said? We're not there. It's not, as Rebecca told me while we were planning for our tomorrow's meeting, this isn't just about cost. This is about the improvement of somebody's life and the value that this brings to people who have struggled with disease for a very long time in their life. So now we're going to turn to the more emotional kind of curvature away from cost, because these things, this is not like GLP-1, where it's temporarily solving a problem because people don't like to exercise or do the work that they're supposed to do. This is curative potentially, right? We don't know for sure. We haven't had it long enough. But even if it's for 2 or 5 years, it's curative, and the value of somebody's life who's suffered with MS and pain every single day, couldn't get to work, or their spouse couldn't get to work because they're taking care of their spouse. The value that it brings to you as an employer is massive, because I will tell you, once you change somebody's life with benefits, they are yours for a very long time because they love you. They're not on Glassdoor. They're not complaining about your plan. They're on all the blogs telling you how wonderful this benefit plan is, and they changed their life. So I want us to think about that. And so I want to go into that side of get away from the financial models. Are going to be there. They're going to solve themselves. We always do. Employee benefits has always kind of figured out a way to take care of ourselves. Now it's this curative nature, but the complexity of getting to that cure. How can we be most helpful for these patients who are going through this with their families? It's usually remote. It's usually somewhere else. How can we lend a hand? What things do you guys see as most beneficial to help them navigate this, get through this journey, make sure they're successful in their post-treatment and all the things they need? I'll start with Kirby.
So I'll read something off the brief, and I did review the 12-page or however many pages of brief, and I'll read this directly so I don't misquote it. Essentially, employer perspectives on what's important. And number 3 is excellent patient experience. The most important solution cited by employers again and again is the need for an excellent patient experience. The word excellent is very important. So how I interpret that is the patient journey for an ultra-rare disease. We're not even at rare disease. We're talking about ultra-rare disease, is incredibly complex, not just for the patient, but essentially the entire family. So we look at, as employers, we look at members, we look at dependents. But here in this case, when we talk about ultra-rare diseases, we're talking about the entire family. So somebody in the family gets a diagnosis, the entire family is involved. If you look at gene therapies, they mostly affect newborns, pediatrics, adolescents, okay, children of very young age. So that's the patient. What about the family member? And all that's involved. And so mapping out total cost of care, I know that's an often used term, is critically important for cell and gene-based therapies, but also navigating not just the patient, but the family members through this incredible patient journey is very paramount. And not just throw a case manager at it, but throw a case manager that's got ultra-rare disease experience, someone who's actually experienced the trials and tribulations of someone who goes through a gene therapy or cell therapy. And so I think being able to offer that highly personalized experience is of utmost important in this disease category, therapy category.
Thank you, Kirby. We'll go to Erin next.
Sure, thank you. Definitely agree, Kirby, with those points. This journey is very complex because for most cell and gene therapies, they're only going to be available at a limited centers of excellence or credentialed sites, and that's what we want, right? We want the experts in these fields to be administering this medication. But what that means is probably the provider that the patient has been diagnosed by initially and has been working with is not necessarily going to be the provider that administers that medication. So I think transitions of care in this space is going to be something to really focus on, making sure that the right patient gets referred at the right time from their current specialist to a center of excellence to be evaluated for therapy. And then again, the monitoring after the fact. I alluded to the importance of tracking outcomes for these patients and making sure that we can monitor the durability of effect, but also from the patient perspective, making sure that, they don't kind of become lost to follow-up just because they received something that has curative potential. We want to make sure they're continuing to be monitored because there are, in some cases, safety concerns, or if they don't, have an effect for as long as we want to make sure that they're in the care of their correct provider so that they can get whatever course is needed following that. So I think thinking about the transitions of care for these patients and however we can support that, whether it's through care management, through collaborations with centers of excellence, and even some of these models include elements of that care coordination as well. So keeping that patient journey in mind will be critical.
And Greg.
Thanks, Tom. Again, echoing what's already been said, but maybe saying it in a little bit different way. I think there's a couple things here. We keep talking about the fact that there's the cost of the drug, and then this patient and likely their family's got to end up somewhere, right? And so the facility fees associated with these could be incredibly impactful too. And as a sidebar, usually when I'm talking in front of a group of people, I'm talking more on the PBM side. And I say, you know what, the PBM industry can actually be really simple. But like the industry's made chaos because their mantra is in chaos, there's profit. So they want to make it sound really hard and difficult. Well, cell and gene therapy, I'd like to say it's simple, but that's actually kind of really hard and difficult because every one of these drugs has a different patient journey. So as we're talking up here, it's not like there's a patient journey for every disease, every therapy, every drug. Some, it's as simple as you go in and you take a 3-hour infusion and you stay a little bit, you leave. Others, they have to basically destroy your immune system and you're inpatient for 4 months. And then they have to send your genes off to a lab to make stuff specifically for your genes to come back to be reinfused. So, you know, if you think about it, this is not just the typical, there's a cost of therapy and somebody's got this inpatient visit and then they're done. That's not it. One of the most impactful stories I heard that I think hopefully brings this home is there's a family in very rural West Virginia who had a newborn with spinal muscular atrophy, SMA. Novartis makes a drug called Zolgensma. Closest children's hospital they could get to was Columbus Children's Hospital. So they have to go to Columbus. Where do you stay, right? So mom and dad, who's going to work? Somebody still has to stay home and work. So how do they get time off work for this? Because this is usually a couple weeks. So when we're talking even about employee benefits for this, how do we address that problem? How do we address where they're going to stay when they're in Columbus? Because they don't know anybody in Columbus. What are they going to eat? Do they have a stipend for food? Is that on them? Like, how do all these things work out? Because that's what really matters. Well, this young family had a pretty bad experience in Columbus. Ended up getting the Zolgensma, went back to West Virginia and never came back. They didn't come back. And again, pharma really wants that data. So they want to see the durability and they want to see if these drugs work, right? The payer wants to see that data and wants to know how the patient's doing because they invested pretty heavily in this, but it was such a bad experience on that family that they just were like, we don't want to go back. So there is, Tom, I love the way you phrased it. I mean, there is a massive human component to the family associated with this. And we do have to think about the global benefits associated with this care differently because there's so many little things that are going to go into it. And I know you guys heard Drew speak from Deloitte earlier today, and he's one of the smartest guys in the space. Really know and respect him. And we've talked a couple times too. Like, I do think there has to be a contract between the family and the payer, right? Because if you guys are going to pay for this and pharma wants to see the outcomes, like they need to go back for that follow-up care, right? If the money is going to be spent to make these people's lives better, then we need to go all in because there's no halfway on these, right? It's not like a cholesterol medicine where you can kind of take it sometimes and then pray next time you go see your doctor, you just didn't eat enough red meat that your cholesterol got better. Like, no, this is an all or nothing thing. And we have to treat it as such. So it is thinking about the entire patient journey differently. But again, every patient journey on these cell and genes is going to be a little different. And so then you have to do that different. So I know that's like the worst answer ever, but this is a space to be really thoughtful because we have to be if we're going to get it right.
Yeah, and those genes are not Levi's. You're not sending Levi's to the cleaner. We have a couple minutes for questions. I just want to caution everybody, instead of thinking about this from the cost forward, think about this from the patient back. And then how you're going to solve the cost problem after you've thought about the patient back. That's the best thing I ever learned. So we have a couple minutes for questions. I don't want to take too much time, but.
I have an online question here. How does an employer with 6,500 employees go direct to a manufacturer to come up with performance-based contract? I know you can't answer this in 60 seconds, but she'd like to understand the mechanics. She doesn't think her broker would be able to do this. So what would be a starting point there?
Greg, do you want to try to?
Callous maybe, but the answer is you don't.
Yeah.
I mean, Pharma is not situated to deal with 6,500 life employers all across the country and try to contract against that and then report against it and data against it. Like the bad answer is that's not a solution. We've got to think through something different, but Pharma is just not, in my opinion, I'm not Pharma, so they might speak differently, but they're not situated to get hundreds and thousands of contracts with individual employers all over the place and then try to manage that. It's just not gonna happen.
So I'll add to that. And that up until maybe a month ago, it was my reaction as well. Pharma really doesn't want to create individual contracts with employers. But surprisingly, at an insurance-based conference, there was an example from a panel of manufacturers that they cited. They didn't identify the manufacturer, but they cited a single value-based agreement with a large employer. Had no idea what that means in terms of the number of members that are within it. So this may signal an opportunity for self-insured employers to start banding together and looking at the potential of value-based agreements or warranties. And by the way, those are two very different products as well. But I get a sense that things are changing ever so slightly, that manufacturers may be more receptive if we can deliver an audience of employers that are self-insured, that either have a choice. Do they cover or they don't cover? And so you've got the leverage. So being able to bring together a group of solidly uniform employers is maybe a signal to the manufacturers. Stop looking at the health plans because there's a lot of challenges, as Greg has pointed out.
Yeah, these are very rare diseases and they're very rare treatments that apply to the diseases. So the likelihood of being in a population of 6,500, pretty small. The likelihood of being in a population of 100,000, pretty good. The population of being in a population of 1 million is even better. So if we as coalitions can band together, if employers could ever figure out how to work together and talk through problems and issues together and get to a resolution, we could go to Pharma together and help solve some of the anxiety there. But partnering with Pharma is really important because they have the warranties and they also have the patient journey better than anybody does. So I want to thank everybody very much. One more
Online question.
Yay.
And this is probably in our action brief, but how common is it for employers to be covering cell and gene therapy, and maybe speak to small, mid, large?
Yeah, I think our survey was pretty overwhelming, wasn't it, Cheryl? I think. Yeah, I think it was above 50%. I think we're finding a lot, but you're finding much more prevalent in the larger employers, the jumbos, right? And as you go down market, it's sketchy. It's risky because you think about being a 2,000 member employer, one claim is going to drown you. So I think that there's probably a lot there. But we are going to be doing another survey, and in that survey is one of that question again. So we'll see trend after that survey this summer. Okay, everybody, great, good. Thank you all so much. Feel free to ask them questions. They're here for the rest of the day.
And I'm going to ask my next panel to come on up, and I'll introduce them in a second. But my comment about costs, or excuse me, who's covering them, is those are the therapies that are out there today. The pipeline is huge. The potential is even bigger. And that's why we have to start laying a foundation for the future, or we're just not going to cover them. And you could be impacted by retaining employees because they're going to go to an employer that is covering them. And I promise I will look up that information from our survey to share that. So I wanted to share very quickly another one of our sponsors, and I have a description on who they are, and I want to thank them. Health Strategy is the premier pharmacy benefits consultant firm that helps self-funded employers reduce costs, improve health outcomes, and gain control over their pharmacy benefit. Their independent, data-driven approach combines deep clinical expertise with proprietary technology to deliver actionable insights, transparent performance measurement, and contract accountability. Clients rely on them to eliminate waste, optimize spend, and make confident, informed decisions in a complex and ever-changing healthcare environment. And they are also one of the groups that are part of our purchasing model. So before we get started, just know that we're going to be talking about a project that we started a few years ago with my good friend and colleague, Karen Van Khalil from the Florida Alliance for Healthcare Value on oncology. And we called it the Oncology Learning Collaborative. Let me jump ahead. Here are wonderful speakers who I will introduce in just a second. The coalition collaboration included 6 employer work group meetings. She had 3 with her employers. I had 3 with my employers. These are the employers. Then we conducted 4 employer member educational webinars, and I'll show you the placemat in a second that talks about the key areas we focused our efforts. The employer guide was a guide and insights for oncology management on the far right, and you can see our goal was to focus on what employers were doing in these areas. There were other initiatives in the marketplace that were very good, but they were very clinical and academic, and they didn't speak to the employer in the same way. And she and I recognized we needed to learn from other employers what they were doing so that we could get that knowledge and information out to the market. This is the placemat about the guide. I'm not going to go into a lot of information because you have the slides, but we did a lot of research. I want to thank our 3 sponsors, Genentech, Merck, and Pfizer. And we hope we can continue doing this because I know Karen is consistently updating the resources and the stories in the program. But here are the 7 areas we focused our efforts. So we talked earlier, last night at dinner, we talked about cancer and what employers were doing, and everybody talked about prevention. In fact, I've been giving presentations where I'm sharing those stories about screenings and tobacco cessation, which we might not immediately think of related to cancer, but those are the things you can do at the most basic level. And then the diagnosis, what tests, treatments are available, the treatments. We've seen significant increases in the treatment area, navigating care and management, survivorship and return to work, and paying for care. You can see that it talks in the far right corner that we're hearing directly from employers on this. I'm going to add whatever these folks say if I find something compelling or new or a quote to that resource. You can't click here because I snipping tooled that. But the good news is right here, I've got the links to all of these, and we'll make sure we get them on the app as well. So with that said, I am going to introduce Sandra Morris, president and owner of About Quality Benefits Design. She's a senior advisor for the Get the Medication Right Institute. Is that still correct, or is this an old description? Okay. And she managed design and delivery of Procter & Gamble's U.S. benefits for 25 years. She is a board advisory member, as well as a registered nurse, certified professional manager, and certified health coach, and a good friend of mine. And really, all 3 of you are good friends of mine. I love you. Okay. Rosa Novo is the administrative benefits director for Miami-Dade County Public Schools. And for 40 years, almost 40 years, she has been at the forefront of creating strategic health solutions, negotiating contracts, and overseeing the creation and implementation of the district's wellness program. As the 3rd largest school district in the nation, her organization is part of a large community. Her leadership has been instrumental in shaping the district's health and wellness initiatives. And I know Brett mentioned her earlier as going on the Hill with us. And let me tell you, when she speaks, really down to earth, really important and passionate, and they are listening. So thank you for that. Maybe I can get some of my members to come with me now. Sherry Samuels first just retired, literally a month ago, just retired. She was the VP of Total Rewards at Sargento Cheese. She is a registered nurse, a certified employee benefits specialist through the International Foundation, as well as a professional in human resources through SHRM. She served as the president of the MBGH Board of Directors for 2 years and is now a lifetime achievement board member. And many of you have heard me say, you never really leave MBGH. So there are a number of other lifetime board members in here, and she will continue to collaborate with us on things. So thank you, ladies, for being with me. Do you want to add anything to what I said about you just now? No? Okay. Well, I think it's on. So I'm going to. There we go. Thank you. So I'm going to start by asking you to share your top 3 strategies that you conducted that you felt were game changers in helping your population address cancer, and how did it impact the outcomes? And Sandra, I'm going to start with you. Okay, Rosa, I'm going to start with you.
Got it. Okay, you have to push it up. So, good afternoon, everyone. Cheryl, thank you. I said last night that I feel that I am home. The partnership that we have between the Florida Alliance and the MBGH and other coalitions, other siblings coalition. Someone corrected me today. We always say sister coalitions. It should be sibling coalitions.
Right.
So sibling coalitions it is. You see? Yeah, I think we all should. But it really, right, it's warm hearting. So thank you for inviting me again. Proud to be the board chair of the Florida Alliance for Healthcare Value and for the partnership that we have. A year ago, we were here when we first released this document. And like Cheryl said, is a living, breathing document. We're constantly evaluating what to include. Last month, we were with our sibling coalition in Texas, and they worked on a project, and which we want to share with you, Cheryl. They worked on a project identifying a study with the city of Plano, focusing on preventive and on screening and what outcomes were there. So that's something that we want to bring to the discussion to include in the placemat. But to answer your question, for me, it's 3 areas. Number 1 is awareness. Number 2 is the integrated platform that I offer. And number 3, it's really food as medicine, which is a new aspect of healthcare overall. It's not new, but it's getting momentum out there. When it comes to awareness, you may think, okay, awareness, no big deal, right? People know that cancer exists. That is true. But at least in my great district and with other employers, people know, unfortunately, when they're needing to understand care. They're needing to understand where to go, or they're needing to understand what's the cost. So something we've done at Miami-Dade County Public Schools is that we've elevated that awareness, and it's giving us amazing results. So everyone, not only us that are involved in this amazing business of healthcare, but everyone, I would say, everyone knows that October is Breast Cancer Awareness, right? You would agree? Is that a yes? We're awake? Okay. So why is that? Because of all the information that's out there, right? You even have professional sports dressing in pink. You have pink uniforms that little kids, you see them wearing. So little kids already know that October is Pink Month. So we do a lot of communication like a lot of employers, right, in the month of October. And we have mammal mobile units that go out there and all that. But I thought, okay, it's more than breast cancer. It's overall cancer. Because at Miami-Dade County Public Schools, I'm spending over $80 million in cancer care, which 16 million of that 80 million plus is specifically on prescription. Okay, prescription running through medical and prescription running as standalone. I mean, today's event has been amazing. They were speaking. I was thinking, yep, I've heard that. Specialty on generic. I'm like, how do you figure that, right? But it's the amazing business we're in. So what I said was, okay, how about focusing on everything else? Let me use this momentum that is October, the awareness of breast cancer awareness, and let me use it to educate on screening, on the importance of having to focus on other cancers. So what we've done at Miami-Dade County Public Schools is that we have what we call, and this will be the third year, MDCPS Goes Pink. And that is in the month of November, following breast cancer awareness. And we have our own police force. So we have our cops cars out there, going out through the district. We have 500 locations, of which 400 are actual schools. So they're out in the schools and about, and kids, are seeing the vehicle. We have the mammal mobile unit, but we also focus on colonoscopies, right? Something that we do at the school board that I have not come across another employer that doesn't. And if you do, I would love to speak to you at the end of the day, is that we cover 100% preventative and diagnostic mammographies, colonoscopy, cervical cancer screening, the Pap test, and anything related to PSA, PSA-free, and neurologist visits for the annual for the gentleman. We cover all that 100%. Does anybody in the audience does that today? You do? I would love to speak to you guys. It's the first time I see hands. I encourage every employer to do so. As a result, my mammographies are at 78% adherence. I have seen an increase of 11% in breast cancer, and we think that is because of that early detection. I haven't looked at the first time mammography, if those have led to cancer detection, but have seen an 11% increase. I have seen a decrease from 72 to 68% on colonoscopies. But the challenge is you have to take 2 days off of work, right? So I always advise individuals go on a Monday. So you prep on Sunday, but there's only so many Mondays, right, available to have the test. We have seen an increase, and I don't know if anybody else, if they've seen it, but an increase in brain cancer of 4%. And I really haven't done anything in the space of brain cancer education, but we're seeing an increase in utilization, right? In screening, appropriate age and gender screening. We're seeing outcomes that we haven't seen before. We are seeing an increase in early detection, saving lives, and it's all that tied to the awareness. So you would think awareness, but awareness is giving us results. When it comes to integrated, yes, a lot of the healthcare carriers offer the reach out at the time that the claim hits the system. You have a health coach, a care advocate, whatever flavor of the Baskin Robbins, it's out there, because sometimes the same thing is named differently across the carriers, but at the end it's the same type of service. But what we do is that I have on-site representatives in my office, for all the carrier, for all the programs that I offer. And as soon as that first call comes in, someone inquiring, right? I think, I have to go for a biopsy, or I think this may happen, or I have this, in the family as a trade. What do I do? The medical carrier on-site reps will connect that person with the disability rep. We'll connect them with the life insurance rep. We'll connect them with the leave representative to make sure they don't lose their coverage while they're out and not getting a paycheck, right? When it comes to the life insurance, if needed, we connect them with the end of life programs that we offer, right? With accelerated benefit offering. We cover funeral homes 100%. So we provide them with all those resources, and it's a one-stop shop for the individual. Like our friends in the prior session, said, it's about the individual. We're in the business of public health, is taking care of people. I don't report to HR. I am a finance department. I report directly to the CFO, which is difficult, right? Because everything is about the numbers, even though we've come a very long way in our partnership. But it is about the people. So caring for the people, right? My last thing, which is food is medicine, something that we launched after, the last time we were here talking about the placemat, is that we started offering a food is medicine campaign specifically on breast cancer prevention. And we have 184 individuals enrolled. We've had 2 individuals that have ended up having, cancer, early detection of cancer, possible cancer. I don't know the results today, but we are moving in that direction, bringing in the awareness, bringing in the integration, and bringing in the conversation of food into the delivery of healthcare.
Sherry, do you want to go next? You're going to be punished.
Wow, how do I follow that, right? Rosa, you're a rock star. So at Sargento, we have always focused on wellness and prevention. I was hired as the occupational health nurse wellness director. That was my title over 30 years ago. So much like Rosa is explaining, with school district, we have had deep roots within wellness and prevention. A flurry of things, not just Breast Cancer Awareness Month, but every, national health observances. Every month, things are going out on the block, which is our employee portal, things to help support employees and their family members with not only prevention, but screenings that are there, whether they be the mobile mammos or the mobile dermatology. Being in rural areas, it's hard for people to get to these specialists or to even get to their screenings. And so just making it easy, accessible, and affordable. You guys have heard me say that before. Remove all the barriers, bring it on site whenever we can, use our on-site health and wellness center to do those screenings whenever all possible is something that we have done and really has been successful, has found, the mobile mammos have found, breast cancer. Our PSA screenings are done in our on-site health and wellness center during our biometric screenings for age, obviously age and gender. We do a lot of things like that from a wellness prevention. We incentivize them in some cases by giving them points for attending like lunch and learns or, doing a puzzle on the block or whatever. And they can take those points and use them for cash awards or PTO. And cash is king, but PTO rules. So they will attend these lunch and learns and different things, just even sometimes, or do stuff on the LMS, the learning management system, to get points. And then hopefully they're learning or they're bringing it back for their family members and learning how to do those things. So that is kind of an interesting little twist. We've also added, to Rosa's point, we have always been a very paternalistic organization, sometimes a little over the top, but that's who we are as an employer and people know it. So the patient experience is number one, and the patient experience in the HR experience is number one, and it needs to be one and the same. The benefits team may have all this knowledge of all this stuff going on. And one of the things that I did when I was there was I created this inventory of all of the different things that we have to help support an employee and their family member with cancer. And it's shocked me, all of the different things. I used the placemat with the 7 different facets or areas of focus and just highlighted all of the different things that we do, many of which Rosa already talked about, or adding dental benefits for aftercare where the chemo has destroyed their teeth and now they need to have 7 cavities filled, which exceeds the dental benefit. All of those different things, looking across the whole spectrum of our benefit offerings and identifying where we could support them. Mental health provider in the on-site health and wellness center for the employees and their families, all of those things. So that was interesting to me. And we've now taken this, I'll call it an inventory of care, and the team is developing patient journeys because personalized medicine requires personalized support, and each person is different. So while we might know things in the employee benefits team, which is small but mighty, the HR BPs or the talent partners, the others that are actually interfacing with the employees on a daily basis, they don't know. I forgot half the things that I was putting into this inventory. So sharing that with the employee experience team, making sure they're aware of it. We do benefits university so that we teach the HRBPs and the talent partners what's out there, bringing together, somebody said earlier, making sure that, I think Amy from Fortune Brand, making sure that the benefit partners, the vendors know what each other is doing and to do warm transfers and make sure where everybody's on the same page. So being a conductor in your orchestra is really important so that everybody's experience is a positive experience and that they get the experience that they need. So that those 2 things, and then we implemented a couple of things, which I'll wait until we talk about plan design changes, but we implemented a couple of things that also helped improve experience with employees and their family members. So
Well, I know we have both of your stories in the toolkit. I'm going to be asking you to share any new things that you've done and reach out to people like Rosemary out there who's doing some cool stuff as well, I think, and gather those stories. Sandra, you had 25 plus years at Procter and Gamble and you did a lot of things in this area. The market has changed, but some things never change. You also work a lot with smaller to mid-sized employers. What are you sharing with them and hearing from them?
Well, I think with P&G, we were well ahead of the game in a lot of things. For example, colonoscopies. I mean, it was 1990s when we started covering colonoscopies of all types at 100%, mainly because it was causing such a claims issue when they did diagnostics and all, and mammograms, those types of things. But today, I mean, there's really four major areas that I focus in on when talking with the employers. One is the whole preventive piece and making sure that they are covering the preventive benefits, of course, that are recommended to be covered by the task force, but also going beyond that and mining their data to look at, are there other things that are driving costs that we could nip in the bud a lot sooner and save a lot of lost productivity and as well as claims dollars. For example, skin cancer. I now live in Texas. A lot of my employer base is in Texas. It is a huge issue in Texas because a lot of the families are, from the oil fields and places like that. And we just like to stay outside in Texas, period. You're always in the sun. So preventive screenings for skin cancer check by a board certified dermatologist, cover it at 100%. Take away any barrier that could be there for someone to actually get the care that they might need, particularly based on their demographics and their family histories. The other thing is biomarker testing or any genetically related test associated with cancer care. The first thing we do is do an overall assessment of their plan design, including every exclusion to the plan, because I have found that many employers still have an exclusion in their plan design that says they exclude genetic testing. This is genetic testing when you're doing biomarkers and things like that. And a biomarker test tells you in many of the cases whether or not a treatment is going to be effective for an individual. And there's nothing worse than someone being treated for cancer only to find out that they were being treated by a drug that would not ever work for their genetic makeup, not to mention all of the side effects and things like that they caused for the individual, as well as the cost for the individual and the companies. So it needs to be covered. It makes sure that there are not barriers to it right now, so that if one is ordered, that it can go through the process quickly and get the results quickly, so that treatment can be much more exact for your covered members when they're starting cancer care. And the oncologists are all very much aware of the tests that are out there. They still are hesitant to order them, though, because they find out that they've ordered them and the person goes for them and then they weren't covered. And they don't understand why should they not be covered? And then they go through a very long appeal process trying to get coverage reinstated and that type of thing. I think the second big recommendation is take a look at the advocacy or / navigation programs that are out there for cancer care. When a person gets a diagnosis of cancer, they freeze. There is no clear thinking in their head from that point on for a long time, nor is there the same for any of their family members. And it helps so much to have someone that can start them thinking in the right direction on, okay, these are probably the things that are going to be part of your treatment plan. Let's talk about, are you interested in centers of excellence? If so, we need to get that ball rolling and those types of things. And those programs are irreplaceable for people that have been diagnosed with cancer or their family members have. The third is something that is always a little controversial when I say this, but I encourage my employers to eliminate prior authorizations when it comes to oncology. Folks, oncologists are not going to order medications that they shouldn't order. I mean, it's just that simple. The only part of PA that I believe is still important is to ask the question, has the appropriate biomarker or genetic or whatever testing been done? And if not, that needs to be done as part of the treatment plan. That's all you should really be doing. I mean, you're wasting, I would just encourage you to go back to your medical plan and ask the question, of all of these drugs, oncology drugs that have gone through a prior authorization process, how many of them were approved? And I guarantee you're in the high 98, 99% were approved. Why are you paying for that? And why are you delaying the care of your members for something that is going to be approved anyway? It is a waste of money. PAs go much too far in a lot of the cases and you're paying for those PAs, whether you're paying for them individually, which some contracts you pay a per PA price, or you're paying for them as being built into it. And if you're eliminating a lot of the PAs, you also should have good reason to decrease your administrative cost for a lot of those, both on the pharma and the medical side. So that's the big key items that I talk about a lot.
That's a lot. That was good. All three of those were great. We do have a biomarkers personalized medicine employer action brief, and we also just launched earlier this year skin cancer one. And you were instrumental in helping us with that because often employers don't think about skin cancer, and it's a big deal. And then it can be too late, and then you might have some disfiguring condition or worse. It's interesting. I was at another conference recently where they talked about prior auths and we've ignored it all this time. Didn't feel like we could do a lot with it. And I always tell that story that you guys have shared, especially you, Sandra, about if they're approving 90 to 98% of it, why are you paying them? They want to get paid. They make a lot of money on that. The question is, just do a little research and you can fix that. I've got a quick question, and I'm going to ask you to limit your answer to 1 or 2 minutes. What is the one plan design change that you believe made an impact for your organization and its members? And you might have just mentioned it, but tell us a little more about it if you have already mentioned it. And I'm going to start with you, Sherry.
All right. A couple of things that we did do was I tried to eliminate the PAs with the navigation service giving pushback, not the plan, because what we did was then because they want to obviously make sure that they're getting the right care and all of this stuff and get them into the system. We had them guarantee us that the cancer PAs, everything is going through the navigation service now. So it's not like hodgepodge through the carrier, through the PBM, through the navigation, all through the navigation service, and that they would do it within 24 hours. So it wasn't delaying care, and they don't charge us for the PAs. It's built into the admin costs. So that was one thing that I confirmed, although I couldn't get rid of the PAs. I did try it, just so you know.
Because it's baked into how much money they want to make?
Perhaps, but maybe they said it was more clinical, that they wanted to make sure that they, got them into the right care and that they were working with the providers and all of that stuff. Probably a little bit of both, but I left it at that as long as they could get me 24 hours. And, scheduling for some of these tests is not 24 hours anyway. So I didn't think it was any harm, by having that in there. The other thing, 2 things that we did was we implemented pharmacogenomic testing. We did it for mental health, for oncology and cardiovascular, the 3 things. With oncology, Sandra brought up the point, the last thing you want for oncology or mental health is to start somebody on the wrong medication and to find out it's not working. So the pharmacogenetic testing, we offered it for all of our employees, anybody that would be eligible. I think it was age 18 and older on the plan. And we had about 50 people that did take us up on that for the various conditions, some oncology, of course, as well. But our numbers, we only have 4,400 belly buttons on our plan. We're relatively small, so we didn't have a lot from an oncology. I think it was more mental health and cardiovascular that did implement that. And that certainly has helped maybe them and their providers get them onto the right medication to help with their therapeutic course of action. And then the third thing that we did, let me see, now I just lost. Expert cancer care. Oh, through the navigation service, we implemented expert cancer care service. So that it's kind of like Best Doctors used to be, the second opinion just for cancer care. That will bring anybody with newly diagnosed cancer in and their records would be reviewed by the expert across the country for wherever that expert might sit. There might only be one or two of these experts in the country, depending on what you're diagnosed with. And we've had 3 people, all 3 individuals that have utilized have had a treatment change of course with their provider, of course, included. And one was enrolled into a clinical trial, and many times they may not have been eligible or able, understanding how to get into a clinical trial without this support. So I think that has helped us in more ways than we know. Again, relatively small population. Rosa would probably have a better, impact, but certainly for our population, those 3 things were instrumental in making a difference.
Excellent. How about you, Sandra?
Well, again, I can't stress too much how important I think, the whole genetic testing piece of this is, particularly for cancer. It's just, you can't, if we want to serve our fiduciary duties, then we certainly should have that as part of the coverage in the plan design, because it takes away waste of plan resources. It takes away waste of quality of life for your members. It impacts in so many different ways. And it is the state of the art today to drive treatment. So, I would encourage you to specifically start asking particularly the medical and in some cases your PBMs as well. How is this being integrated into the plan, and how are our members being communicated to in terms of the availability of the testing to determine the right drug at the right time for the right person in the right way?
And that biomarker should be a full panel.
Yes.
I've had the experience where they will only authorize, based on the diagnosis, a subset of the biomarker or biomarkers. And sometimes if they do a biopsy, they may only have a small sample, and now they've wasted their opportunity to do another biomarker testing because the sample size is too small. So having a full panel at the very beginning is extremely important. Just open it up. And I've had to argue with our carrier on that.
Well, you never know what the future will hold in terms of the developments that are happening in treatment. And, one drug can be found to be very effective for a huge area of cancer care that it's not found to be effective in today, and next month it is. You need to have, that comprehensive testing to be able to do that. And I would also say, looking at, programs in terms of the back in P&G days, it was Best Doctors. I mean, I piloted that program for just to see how it would work and what the member experience was be. And we did it for actually a gentleman that was in our HR department that had been diagnosed with brain cancer. And we found out that not only was he on the wrong medication, but he had the wrong diagnosis. And he was already undergoing treatment at that time. And it all came out of that analysis of that type of program with experts looking at his case.
Rosa, how about you?
Sure. So I know we only have a few minutes. The PA conversation is like a whole summit in itself. I hear the same thing from my carriers, and I just released my RFP on Monday, and that is one of the requests to be able to remove PA for certain services or tied to certain conditions, which they've all said they cannot do. So we'll see what that ends up. And it's all about quality, right? It's not because they're making money. And it isn't the administrative fee, but when you break down the administrative fee, there is that component. So how you negotiate that component. So again, it's a whole summit conversation. But just in a few minutes, we do cover behavioral health at 100%. At Miami-Dade County Public Schools, everything related to behavioral health is $0 out of pocket for the member or anyone covered under the plan. Something that I shared last year and would like to provide an update is the movement on infusion medications from hospital-based to standalone facility. I started, last year's negotiation because I negotiate with the 5 unions and I sit at the table with the hospitals. I said, no longer am I going to pay for this infusion therapy at hospital-based facility. The hospitals saw the writing on the wall and they came to the table and we started with a 15% decrement in the cost and the overall cost of the procedure. I do have one hospital that is pushing back. So we'll be back at the table, pretty soon with them. But the mental health, extremely important. The PA, extremely important. Something else, second opinion, third opinion, unlimited, no PA for opinion. I've heard from some employers, no, you only get 2 or 3. No, it is a scary, like you said, my friend. You hear it. I had a biopsy done 2 years ago. And until I didn't get the results, I said, oh my God, what am I facing? I mean, you face what you have to face, but what am I facing? So yeah, a lot of things go through your head. So that integrated solution with the mental health component, right? Extremely important. So more to come on the standalone facilities, hopefully changing the industry from that standpoint.
Do we have any questions in the audience? Here's an opportunity to ask them about what they've done in certain areas or any questions on the phone, Paula? No questions. Oh, yes. Can someone bring Tara a microphone? You want to wear a cowboy hat, Tara, while you ask the question? I'm kidding.
I kind of do. This is, given all we've just discussed and all that you all talked about, it's fantastic and it's almost too much. Like, where do I start? But I want to ask actually what I think might be one of the I don't want to say easier to address, but non-pharmaceutical, non-medical plan change. Could you please tell me more about the Food as Medicine program? I'm curious if you used a partner with that or if that's something you've developed as a campaign internally, but I'd love to hear more.
So again, I'm in the cone of silence, but my current carrier is one of the 3 BUCAs. And in a partnership with Johns Hopkins University, we launched that program. We launched it not only for cancer. It's we have our wellness program. The wellness program belongs to us. It's not the carriers. So as part of that, we have our on-site coaches that are dedicated to our team. And through that avenues that we've brought in Food as Medicine for many different, aspects, for many different diagnoses. Yeah.
And I also would like to mention that one of the things that I did when I was at P&G was dedicated a portion of the new employee orientation to the different programs that we provided in terms of these spaces and made sure that they understood going in the door that they had access to these kinds of programs. But the other thing that I did was put in an annual recertification of our leadership within all of the managers within the company, to make sure that they stayed abreast of all of the programs that were out there, because the first person in a lot of times, particularly in a manufacturing site, the first person that's going to hear that an employee, either the employee or their family member, has been diagnosed with a serious condition is that manager. And they should be able to immediately say, hey, we've got benefits for that particular thing that can help you a lot at this phase that you're in of this newly diagnosed condition. And let's at least let me take you to the benefits department and let them help you get connected with what you need to know. But we actually tested our managers to make sure that they kept that knowledge and it was in front of them and in their brain all the time for those employees.
Cheryl, we have another question.
Oh.
Rosa, go ahead if you want.
No, go ahead.
Oh, no, you.
Yeah, you. So just, because like you said, a little passionate or whatever you want to call it, to the employers in the audience, it does take time. And I was having this conversation again with another sibling, friend, coalition member, but employers need to request the data. The carrier is going to say, oh, it's not maintained like that, not segmented like that, not stored like that, blah, 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 blah. We are the ones purchasing healthcare. I spend $447 million a year in healthcare, out of which $97 million in pharmacy only. It's a lot of dollars. And if they're being spent right, I'll spend double that. And I report to the CFO, and that's fine. But I don't know that it is. Okay, it stops with employers, and it stops with being a voice united through coalitions. If you're not a member yet, please reach out to Cheryl, reach out to any of our sibling coalitions. But employers need to understand they're the ones purchasing healthcare. They should have the data, mainly employers that are self-insured like myself. So don't stay quiet, be a voice in the community, and get engaged.
And I would also add to that, to push back when they say they can't do things like eliminate prior authorizations. They can do it, but they have to program it into their system, and they won't do it is more likely than they can't do it. However, what I always bring up to them is it is the employer's fiduciary responsibility to make sure that the benefits are being used prudently. And PAs that are being wasted in terms of paying administrative fees and is not prudent management of the plan assets. So I need to know that I'm doing PAs on only things that really should have PAs. And therefore, when I say, I've got a 97% approval rate every time the PA goes for this particular drug, you are wasting my benefit money. And it's my responsibility to make sure that doesn't happen. And if not, then I'll have you sign on as the fiduciary for this responsibility. And, if you want to take that fiduciary risk for us, okay.
And you can see why I invited them back this year, because they had new information, they're transparent, and they're passionate. Thank you so much, ladies. This was excellent. Oh, sure. Okay.
One more question.
You can answer it pretty quickly.
It actually isn't a question. It's just some more context. So Jane Lutz from Genentech, we were one of the sponsors. Thank you, ladies. But I also work very closely with our own benefits team. And you guys teed up my point perfectly around data. So going back to the years of COVID, and we knew cancer screenings were low or down or not happening, we decided to look a little closer at our data and looking at our screening rates. And not only were they low, we were finding that people were getting cancer below the age requirement to get the screening. And so that was shocking to us. We're a cancer company, but it was still very shocking to us. So one of the barriers that we removed is we've taken away every age restriction on all preventative cancer screenings. No one, I promise you, no one is going to get a colonoscopy if they don't need it. We have not, those rules got put into place over a year ago, and we have not seen any overuse or misuse of the screenings. So another thing to keep in mind.
Well, and I'll just end with the last question I was going to ask is, who is advising you on what new therapies and treatments are out there? And if you can give it in one word, I would love to hear it. Is it your EBC? Is it not your broker? Or maybe it is. Is it your carrier? Who is advising you? Sherry, starting with you. Quick answer. Advisor. Coalition. Research. And I would say coalitions are a huge resource, because you can not only go to the coalition that may have done work in this area, but also your sister employers. Let's thank this. Go ahead. Siblings.
Sibling coalition.
I'm going to work on that. Thank you so much. It's awesome. Okay, I am going to ask my colleague and friend, Tom, to come back up here. And I'm going to ask, by the way, again, here are all the resources available to you. Yes, Paula. We have a break now? No. Oh, I know. Yeah. I did. Oh, it said Tom. Yeah, Tom, you're not on yet. Sorry about that. But I'm going to hand this over to you.
All right. Good afternoon, everyone. My name is Dawn Weddle. I am the Vice President of MBGH, and it is certainly my honor to introduce these next two presenters. Do we have a video? All right. I'm sorry. I'm not sure if we had that. I'm just going to skip by that. We might come back to it. Rewind. I am here to introduce our next two presenters. And these two ladies that are sharing the stage with me are two ladies that have a lot of real life experiences. They've been on the front lines. They've seen firsthand the impact that high cost therapies and high catastrophic claims can have on an employer's bottom line. So they're here to share some of those experiences with us, but they're not just going to talk about the problem. They're also going to be sharing with us some of the things that employers can truly do to have an impact on those costs and drive change and drive some of these savings. Our first presenter is Dr. Christine Hale. Dr. Hale is an independent consultant. Most recently, she was the Senior Vice President and Chief Medical Officer at Lockton. In that role, she was the lead strategist for the clinical consulting team, and she was instrumental in using their data to find solutions and reduce waste and improve costs around healthcare spending. She also serves as one of the members of the Medical Directors Group of the National Alliance of Healthcare Purchaser Coalitions. So I've just started to get to know Dr. Hale over the last year or so, and I have to say, it's my assessment that Dr. Hale not only is a little disruptive and wild in her work life, I'd say she's got a little wild side in her personal life as well. And I had the opportunity to spend some time with her at the National Alliance Leadership Summit in Dallas a couple weeks ago. And we had an evening outing. We did a little line dancing. And I have to say, she was a little wild on the dance floor. I would say she has a combination style of line dancing, country line dance, paired with hip hop. If you haven't seen the video, Chris has the video that you can see it in real life. But that wasn't the wild outlaw story that she shared with us as part of her introduction. We found out that Dr. Hale is a Harley girl, or at least she used to be a Harley girl. So she co-owned a Harley Davidson motorcycle, not a Yamaha, not a Kawasaki, not a Honda. Like, this is the real deal. It's a Harley. So she rode the roads on her Harley for a number of years. And I'm just curious, is there anybody else out here that's ever ridden on a Harley? Oh, okay. These are your people. Anybody ever owned a Harley? All right. You've got one other person. Okay. So you are part of kind of an elusive group. Also, alongside Dr. Hale is Chris Severson. Chris is the Chief Executive Officer of our sibling coalition. Thank you, Rosa, the Nevada Business Group on Health. Oh gosh. Thank you, Paula. Oh, this is Dr. Hale on her Harley. Yes, we have that. Okay, so Chris is the Chief Executive Officer of the Nevada Business Group. She works directly with public and private employers in direct contracting for healthcare services, as well as employee and community health. Yeah, Chris has a little bit of a wild side too. And when she was telling me this story, I was sure that this happened years ago when she was, young and reckless. But no, this happened like in the last year, maybe even the last 6 months or so. But Chris is a hunter, and she and her husband and a couple of their children and another couple, I believe, were going to go out deer hunting. And they're in rural Nevada, and there was a very primo spot that they wanted to go to do their deer hunting. And there's basically two ways to get there. So there's a Route A, which is like the direct line, maybe goes through some private property. And then there's Route B that goes all the way around this private property, much larger or longer trek. So what does a group of really eager deer hunters do? Well, they take the most direct route. And en route, they encounter a fence. And not only is the fence closed, but it's locked. And unbeknownst to me in the story is she says, oh yeah, we had a bolt cutter with us. And that's just a whole nother story. But they happen to have a bolt cutter with them. So they cut the bolt They open the gate, they make their way through thinking, they really got away with something. Well, the rancher's wife somehow saw them in action, comes out, gun in tow, and I think gave them a piece of her mind, and finally let them get on their way. And these group of deer hunters went on to do their hunting. I did ask her the outcome of that hunting expedition, and no deer were ever injured in this story, but everybody survived. So that's our outlaw, Chris Severson, for you. And here she is on her expedition out hunting. So with that, I would like to turn it over to Dr. Hale to kick us off. We have a clicker.
Sit.
Oh, you're going to sit. I like that. Okay. Okay. You've heard a lot of good content. Thank you. Kim's got my back over there.
So we thought we would start with a couple of polling questions. Okay, so I'm going to kick us off with one, and then Chris has a couple after me. So let's see. And we're going to make you get up and down. Yes, you're welcome. We're going to make you stand up and sit down. So everyone stand up, please. Okay, if you have literally no idea what the most expensive pharmacy claimant drug they were on your plan, like not even a guess, sit down. Oh, good job, guys. Okay, if that top claimant was in excess of $50,000, keep standing. And if it was below 50,000, sit down. 100,000, 250,000. All right, a couple of people are sitting down. Let's go to 400,000, 700,000, $1 million, 2 million, 2.5 million. Okay, there are 4 people standing. I don't want to get to 0. 3 million. Okay, now there's 2. What was the drug? Do you know? Yep, gene therapy. Okay, what was yours? Whoa. Okay, $7 million for another gene therapy, by the way. So, high cost. So Chris and I have been co-leading, and along with others, the high cost claims initiative for the National Alliance of Healthcare Purchaser Coalitions for, we guessed last night, 5 or 6 years at this point. It's an interesting space to talk about pharmaceuticals in the high cost claim space, because I always, like when I first started doing work in this space 8 years ago, I was like, well, there's really 2 flavors of large claimants, right? And this especially matters if you're a small to mid-size employer who has stop loss, which, there's the shock and awe, big claim fell out of the sky into your lap, which is what a lot of you all probably purchased stop loss insurance for. And we talked about those earlier. Great conversation with Drew from Deloitte on, the risk that poses. But then you might have protection for that. So that is a concern, right? Especially if you don't have stop loss. And as he mentioned, stop loss, the plans, as far as I'm aware of, are all still covering gene therapies, but don't rely on that forever. The ones that keep me up more at night right now are the ones that are ongoing claims. So as was also discussed earlier, I'm a physician. I graduated medical school in the year 2000. And when I graduated, my autoimmune condition would have landed me in a wheelchair. I am now a seriously professional circus performer. Like, I dangle from the sky. Okay, you would never guess that I have this condition. So life-altering cancer, we didn't have these drugs that had people with metastatic cancer walking around for 10 years on basically making cancer a chronic disease. You either got better or you passed away, and that was the sad truth, right? So when I put my doctor hat on, these are miraculous therapies. But even if you have stop loss coverage, if you have an ongoing claimant that's in excess of whatever your stop loss deductible was, after the first year or 2, chances are you're going to actually get, that person's either going to get their own specific deductible called a laser, you're going to get some crazy renewal on the cost of your plan, or you will have a hard time finding coverage. Now, what's driving these? And yeah, I do have a clicker. Okay, great. So this is from one of my favorite reports. Now you'll get to see my nerdy side. So Sun Life, one of the largest third-party stop-loss carriers in the country, does this beautiful pediatrician-approved report. It comes out typically the first week of June or last week of May. The new one just came out, so you can go look it up. The footnote here has the name of it if you want to go look for it. It's in the slides. But what they do is they slice and dice their reimbursements, right? The claims that they paid over their clients' deductibles. Now, keep in mind, the deductibles are different, right? Typically based on size and risk tolerance, but we see, and I thought, wow, I was sitting here listening to the cancer panel thinking, wow, how appropriate is it that we are following the cancer panel? Because 8 out of the top 10, and this is, so the left-hand column is the rank for 23, and the second column is the rank for 24. And blue bars are the cancer drugs, okay? So 8 of the top 10, and let me tell you, these are not cell and gene therapies by and large. These are ongoing therapies, right? There's also some in here for blood disorders, and then those are the orange, and then the gray bars are other disorders. We have a few, like Tepezza is for autoimmune eye disease. There are also many others that are below this watermark where they're not typically paying out. In my experience, when I was in my prior role, our largest pharmacy claimant was $3.5 million a year, and it was ongoing. Right. So those of you who's like, yeah, I had a $3 million claimant, that was like, hopefully one and done. Right. This woman, she worked for a municipality, so public taxpayer dollars, $3.5 million a year. You know what we did? Amen. Hallelujah to the folks who just sat up here and said, you should be looking at site of care. And we'll talk about that again in a minute. But we were able to move the site of administration of this drug, new cost, $300,000 a year, by moving her to an outpatient infusion setting. That's a savings to the taxpayers of that municipality of $3 million a year into perpetuity, right? So this is what we're facing right now. Okay, so as we've been leading these large claim workshops, I have this kind of bucket, and hopefully this will be a little bit of a capstone because I know a lot of these things were mentioned throughout, and all the presentations today have been amazing. So I'm gonna try to tell you, first of all, data. I know we say that until we're blue in the face. It could not be more true. Even like in cancer, when, we look at the industry data, it's like 70% of cancers don't currently have a screening recommendation. Either there is no screening test, or as was mentioned by our friend at Genentech, like a lot of younger people that are not at the current recommended screening levels are coming up down with metastatic breast and colon cancer, right? And so if your problem is if you're investing all of your time in a bucket like screening and not thinking about the other ways to tackle the problem, but your data says that screening isn't going to fully answer the question, right? Then you should be expanding your horizons. So here's kind of a framework for you all. So we wanted to make this actionable. So this is going to be a framework that you can use to go through your data and start to think about what will have the most impact based on the drugs you're seeing, and the types of your plan design and your partners and the like. So my first category, and it was said earlier, I cannot say it again enough, make sure your patient has the right, or your member in this case, has the right diagnosis and that the drug they're on is actually working, okay? Like we had a $300,000 MS claimant who turns out didn't have MS. And furthermore, so $300,000 for at best, no effect, and at worst causing side effects. And even worse, this member had a structural back problem. Had it not been surgically addressed, would have lost the function of their legs. Okay, so make sure they have right diagnosis. Second opinions, I absolutely agree. Second opinions, if somebody wants one, they should get it. Access to clinical trials was also mentioned, and this can be a way. A lot of times this will come up, because people are saying, well, I'm seeing a doctor at insert name of very prominent academic center here, and they want to put me on this thing, but the plan is saying that it's not, it didn't get approved in the authorization. My next question is always like, well, let's see if there's a trial available, right? Like we may be able to access this therapy this way. Reviewing prior auth. And I think I have a slightly contrarian view, but not really. I'll explain on prior auth, which is we absolutely should either super streamline and automate in a good way, not denials, but approvals of things that are relatively lower cost and known to be effective for the condition they're treating. Where I have to caution people is I say, don't throw the baby out with the bathwater on this one, because we had a member who was on a very, very high cost. I think it was like $60,000 a month narcotic. And this narcotic is only FDA approved for end stage cancer. It's basically a palliative care drug, right? Why? Because it's so potent, you could die from taking it. Okay. So if you are at the end of your life with cancer and you're excruciating pain, take it all you want, right? We had this member, though, that when we integrated the medical and pharmacy data, and you absolutely have to do that when you're trying to understand the appropriateness, is that means that we looked and they had no history in 3 years of medical claims, no history of cancer diagnosis, no chemo, radiation, or surgical therapy. What they had was low back pain. So we looked, and I said to my nurse, well, first we talked to the PBM. I won't say which one it was. And we said, how do you perform your prior auth process? And this is something you absolutely should be asking about. Explain your prior authorization process. And they said, well, we called the doctor and the doctor said the member had cancer. And so we approved it. And we said, well, did you require any evidence, testing, biopsy, anything? No. So I was like, all right, let's go look this doc up. Well, sure enough, the doc was on probation with the medical board for overdosing and killing a patient. And furthermore, when we went to Dollars for Doctors, dollarsfordoctors.com, we found that they were getting paid an extraordinary amount of money by the manufacturer of said pharmaceutical. Now, I want to say the pharma partners in our room today are amazing. We know each other very well. It wasn't them. So, know that you're working with people that are top notch. Have to pay attention. Okay, and then pharmacogenomics was explained earlier. Agree, in cancer in particular, and cardiac, and a few other drug classes, like making sure that the way your body processes the drug is going to, you may need to either adjust the dose or choose a different therapeutic, right? Because it could actually harm you or that. Now, let me go super quick through the others because we have some really great content with Chris and a few more questions for you. So the other ones, biosimilars, I know you heard a talk on that earlier. Just keep an eye on that. And whether that's a lot of these things you can either do at a plan level, or you can say like for us, if our clients didn't want to do plan level changes, we would just say, all right, we're going to pick up the people that have, for example, the highest spend on the drug that has a biosimilar and just individually move those members, right? Acquisition, making sure that you're considering, at least, if you can't move site of care, I probably should have put site of care first, but in some cases you can't move the administration. And so, you're getting these massive markups on the infusions. Well, sometimes you can actually negotiate to have that drug procured and paid through the pharmacy benefit, so the member can stay where they are to get their infusion. But because it's procured through the pharmacy, there's no buy and bill. What's buy and bill? If you didn't catch it today at some point, because I stepped out for a few minutes, it means that the hospital that's procuring the drug, because they procure it through their own pharmacy, are allowed to mark up the cost of the drug as much as they want. And in the example I gave you, they were marking it up at 10x the cost of the drug. So purchasing through the pharmacy plan tends in having it, like, for example, delivered by name your PBM here and having it delivered to them, eliminates the ability to do that. And then finally, elimination of waste. This is a really big one on these high cost drugs. First of all, pro tip, if you're considering GLP-1s, you should also go look. A lot of these specialty drugs are weight-based. So you should go and look and see. I mean, I've had cases where nurses have come to me and said, Dr. Hale, this member's insert name of drug here is 2x the benchmark, but it's not overpriced. The member's BMI is 55 or 60, and that's why. And I'm like, well, if you have weight management benefits in place, you might want to think about making sure that that member has been outreached and is getting engaged, right? And then finally, oh, yeah. And we typically would recommend shorter initial authorizations if it was a new drug, because what you don't want to do is have an auth and get somebody on autofill of something, and then it turns out it doesn't work and they're just getting auto shipments of this really expensive drug. That actually happened to me personally, which I was like, whoa, guys, let's not do that. And then risk financing. I won't go through that because Drew did a lovely job of explaining that, but I just wanted to go through that with you. I'm not going to spend time on this next one other than to point out it's in your deck. This is a diagram from Houlihan Lokey. So I didn't make this chart, but I thought it was nice how it explained the different places. So AIC stands for Ambulatory Infusion Center. I will also note that, if you're able to move, first of all, most members love this, okay? Because instead of going to a hospital, potentially sitting in a big room with a whole bunch of other people that may be sick when you're immune suppressed, right? You can either go to a private infusion center that has weekend and evening hours and TVs in the room and Wi-Fi and refreshments, right? You can have it done in your physician office where you're going a lot anyway, or you can have it done at home. And I've had patients tell me like, yay, I get to watch Netflix in my jammies while they do my infusion. Woo! So a little more information on this page, but I'm going to turn it over to Chris.
Where do I begin? One thing that one of my pharmacy providers in our coalition, we do have affiliate members, and some of them are here in the room. But one of them came to me one day, and we were talking about GLP-1s, and I've got a couple thoughts on that. But first of all, they said, you know, most cancer drugs or most really high-cost drugs are based on weight. And, you know, if we did approve GLP-1s for weight, we could reduce the weight and therefore reduce the cost of the drugs, right? So if you make that kind of, because if the person weighs less, they take less. So it's just that's just a little bit of a push for adding GLP-1s into your plan, is if they do happen to be on a high cost medication that's weight-based, you could save there. People really come up with these amazing ideas. This is just, I don't know, I never would have thought of that on my own. So first of all, if everybody could stand up. So mine's going to be quick. If you know your PM, sit down. Nope, stand up. Stay stood up if you know your PM. Per member, per month cost.
So if you don't know.
If you don't know it, sit down. If you know the impact of your rebates on your PM, stay standing. Okay, what was my other one? If you know the name, and I know some of you do know the name of the drug, your high cost drug, stay standing. If you know the manufacturer of the drug that is your high cost drug, stay standing. If you've ever thought about contacting that manufacturer of your high cost drug, stay standing. Good job. Good job. So just so you know, okay, Sherry, you can sit down because so I have in Nevada, we have medium to small self-insured employers, and they just, as Dr. Hale said, they just are fed up, right? With the elimination of the ACA cap, right? That $1 million cap, the costs have just gotten skyrocketing. And we're going to talk about medical claims in June, this is June, in July with this group. But it's just really becoming, I am afraid for the future of employer-sponsored health plans. Because especially if you're a public entity or if you're a smaller employer, you just can't take it anymore. So I don't know what the answer is. I think I came from the benefits area. So I was an employer most of my life. And if somebody came to me and said, we'll give, as your employee, you take $15,000 or $20,000 a year and go buy your own, I would have said, hallelujah, right? Get it off my plate. They can do whatever they want, and I don't have to worry about these escalating costs and these high cost claims and all those other things that we have to deal with. So Cheryl asked me to, where do we go? Cheryl asked me to talk a little bit about our organization, and I may have gone a little bit overboard and I may have gotten a little slide heavy. So I'm going to go a little bit fast. In our organization, we are two organizations very similar to MBGH. Both are nonprofit. MBGH is our community health, population health, education. We have a data platform that our employers use as well. And Nevada Health Partners is strictly contracting. So we have direct hospital. We usually get in excess of 60% discount in our rates. We have ancillary services, and then we also have our own pharmacy program. And that's what I'm mostly going to talk about today. These are our employers. You'll see we're really small, and we're very heavily public. 2 school districts, a county, a city, airport authority. And these are the contracts that we provide direct contracts for. So you can see all of these. And I think my friend from Gateway is here today. Are you here? Wave. We're going to talk about how wonderful you are. So I want to talk about our PBM contracting. So if you've been involved in PBM contracting or living through it right now, like Rosa is, it takes constant vigilance. And every year before we would go to PBM negotiations or RFP, we would have to do a program called PBM 101 so that we could bring all of our employers up to speed. What's AWP? What's rebate? How does this all play together? When I started in the coalition 9 years ago, my employers said, we want a 0 increase in pharmacy this year. And I went, oh crap, that's going to be really hard. Then I met up with a guy, some of you may or may not know him, his name's Kevin Hooks, and he actually started a PBM way back when, and he was doing our PBM 101, and we talked about doing something different, and that's what we're going to talk about today. The contracts are confusing, they're hard, there are hidden provisions, or there's things that are not listed that are the same as hidden provisions, right, that you get hit with. Well, if it's not listed, right? And then I think that they count on employers being overwhelmed. And then there's the brokers and consultants, which kind of, I can only speak to those in Northern Nevada, but some of them are just not as vigilant, or they steer the employers where it's best for them, not necessarily the employer. So why did we decide to question it? We started doing our education. We had a long history of contracting with PBMs. We're small, so we didn't necessarily get the rates or the customer service that we felt we were deserving. And so we decided that we wanted to do something different. And we couldn't wait for PBM and pharma legislation, which is really a good thing because we'd still be there. And we had a strong desire to stop the cycle and take care of our own destiny. So this is an old PBM model, right? Traditional PBM, you have the customer, which in this case is the employer. Then you have the PBM, and then behind that curtain, you have the retail pharmacy, the mail and specialty, and the manufacturers, right? You don't see all of those pieces. So, oops, went the wrong way. And when one piece controls end to end, there is always places where they can play the system. I don't know how else to say it, but play the system. So let's say they quote us a rebate rate on drugs. Well, when they go to the manufacturer, they're going to consolidate all of their employers into one and get a really, really, really good rebate, right? Rebate price. And but they don't pass that on because they only passed on to us what we were guaranteed. So you really needed to separate it. So also PBM disclosure of profit. I don't need to talk to you guys about that. I think you probably all know that. What we decided to do was to break apart the PBM model into 3 separate contracts. So we have a pharmacy benefit administrator, which is Maxor, who's changing their name down to Vital One or something. And they administer our claims, just like a TPA would. They also administer our specialty and mail order. We have a rebate aggregator, which is Gateway, who we love, and we contract with Gateway separately. Most PBMs, or all PBMs, have a rebate aggregator behind the scenes. And they're there, you just don't know it. And then we have a pharmacy network called True Choice. And so we broke it up into 3 separate pieces so that we could see the handoff between one another, right? So nothing was really hidden. We could see all the pieces. And let me tell you, we've got a great deal with Gateway, just saying, with Gateway, and they charge us just a small percentage of the actual rebates that we get to administer this plan. The pharmacy benefit administrator, we pay a flat dollar fee, right, to them to administer our claims. And the network is just like a PPO network. So really, this pharmacy model is very much similar to a PPO, where the pharmacy benefit administrator is the TPA, the network is the network, and then the rebate aggregator, I don't think there's an equivalent in the medical field, but it's phenomenal. And we also have a pharmacy consultant who oversees the handoffs between the 3 to make sure there's no shenanigans, as I'd like to say. I think Cheryl told me, what was it, egregious? Is that my word? Yeah, I heard her say egregious dealings one time, and I thought, I just love that word. So our new model is where we break out the retail pharmacy, the pharmacy manufacturers, and the customers. And the only thing that's behind the curtain is the mail and specialty. I'm going to not lie right here, and I'm going to say we have not cracked the specialty nut. That is still a problem for us. Because if we take the specialty away from the PBA, what's their incentive to process our claims, right, at a very reasonable rate? So we're still working on that. The administrator, talked about that. The pharmacy network, they do the AWP, the 30 or 90-day option, and they do have an open network or a custom network. And the open network means you can go to any pharmacy, and every pharmacy in town in Reno is a provider, or actually, I don't know of any pharmacies that they aren't contracted with. Then they offer a limited network, which is anybody but CVS or anybody but Walgreens. So you can get a better deal. None of our employers took the limited network. When we started in on this, there was a couple that didn't even have a formulary. So they just paid for everything. And then the network also charges an access fee, just like a PPO network. Let's see. The rebate aggregator, we meet and contract with them. And what this has done is this allows us to develop our own formularies, right? So the PBM doesn't tell us what our formulary is going to be. We meet with our rebate aggregator and we talk about formularies and we tell the pharmacy benefit administrator what our formulary will be. So it really does give you control. I would use the term stupid drugs, and anybody who knows Lauren Vela, who was with Pacific Business Group on Health, she coined that term, I think. And it's those drugs that have no added value to your plan. So I'm going to talk about let's do Duexis, and it's ibuprofen and like omeprazole or whatever combined into one. So if you're taking anti-inflammatories and you get an upset stomach, you can take this and it'll, all in one pill. Well, that one pill costs, I don't know, hundreds of times more than you could buy either of those products at the pharmacy or over the counter. So we took a list of what we called stupid drugs to Gateway and to Maxor and said, we don't want to cover any of these drugs anymore. So we do have complete control of the formulary, and it is very liberating, I'm just going to say. How it works, we hold the contract. So I hold the Maxor Gateway True Choice contract, and our employers sign a participation agreement to participate in that contract. And that's the same with all of our contracts. We actually hold the contract, and our employers pick and choose which contracts they would like to participate with. Our employers ask for renewals a year in advance because they don't ever want to go away from the system. And there are virtually no calls or complaints. I don't know about you guys, but it's worth a ton to not have calls from your members saying something's not being done right. Our employers were really leery because they're thinking, am I going to have to manage 3 contracts instead of 1? And they really don't. It's really seamless. We do that. Let's see, how's it working? Great. I'm just going to say great. And I have to give Maxor credit. It was the easiest implementation in my history of work in human resources and benefits, which is 40 years probably now. So the easiest implementation ever. We also have knowledge control over the data aggregation and reporting, and knowledge is control. So we also have a data network where our employers dump all of their data, their medical, their pharmacy, and everything into a data management program. And then also I get data aggregation. So for those employers that are in the data program, I get roll-up numbers. So I get to see what everybody is doing on an individual basis, but I can also see the roll-up numbers on pharmacy so that we can really see if there are issues or problems. And I have to say, I learn stuff all the time, but like we have a diabetes program that we do through MBGH, and our adherence level is over 85% on diabetes drugs. That's huge, huge. And so we're doing something right. This is one of the things that I get every month. And you'll see it's got the months on the left, and then it talks about, the different categories. And you'll see plan costs, let's see, what was it? Oh, plan cost, PMPM, and utilization. So this is a report I get every month. We also talk about traditional drugs, and this is how the traditional drugs look. So we have access to great data. Then we have the specialty information, right? How many specialty drugs are we using? And then we get what kind of pharmacy. Are they using mail order? Are they using specialty, or are they using retail pharmacy? I told you I was a little bit slide heavy. And then this is brand and generic utilization. But this is the one that I look at all the time. This is the top 20 drugs by cost. And I can't remember what that top one was. I can't see it from here. But I actually found some of the high cost drugs, and then I looked them up to find out who the manufacturer was, because I wanted to know if there were bad players in the manufacturing market, right? Were there some manufacturers that were always on this list, or not? And it was really helpful. And I can talk to my pharmacy reps that are part of our program. If anybody knows anybody at AstraZeneca, let me know, because I need to give them a call about one of the drugs that is being prescribed and to find out if they've got a program. Then we have top 20 drugs by utilization. And this is not surprising: albuterol, amoxicillin, prednisone. So these are just by number of prescriptions. Then drugs by therapeutic class, cost by therapeutic class. This is also a good one. This is cost by doctor, right? So you can find out who's writing the most prescriptions and who's writing the most expensive prescriptions. So again, knowledge is power. Reno is not that big. So we know these doctors. So, if we have an issue, we can, meet with them or call them or talk to them. When we put this in, we saw a 29% decrease in overall spend at implementation, which is great. We also have had a chance to look at what is the rebate impact on our PMPM, right? So for a lot of our employers, they would take the rebates with this hand and they would do their PMPM over here, but they never married the two. And I'll use one example that I'm talking to my employers about, and that is, if you look at the GLP-1s, right? I'm just going to make up numbers, right? Let's say it's $1,500 per month, right? Well, you get a rebate that's anywhere from $500 to $750 a month. So really the cost of GLP-1s is really only $750 a month. So sometimes when you look at those things just on the surface value of the cost and don't consider all of the pieces together, you don't get a good picture of what you should and should not cover. So impact of rebates on PMPM is about $30 a month. We do suffer from high cost drugs. However, our PMPM 9 years later is still 30% below the national trend. And I think that says a lot for a plan that's been in place for 9 years. And I still say it's because we broke them apart. So they don't play the games with the rebates and the AWPs and all of that. So that was I tried to do it fast. You'll get these numbers. And any questions?
Any questions from the audience or online? Looks like, Paula, you have a question?
Yeah, I have a question from online. They're asking what legislation is in process to help protect plans from the hospital charge abuse related to prescriptions?
Well, I can only talk about Nevada, and they actually, because we're small, our legislature only meets for 4 months every other year. And we just had a legislative cycle. I know, pretty bizarre. In a way, it's good because you don't have to deal with it all the time. On the flip side, you only have 4 months, right? So you got to get your name in and get your bills in early. They had a price protection bill that was going to be applicable for public agencies only, and it had a percent of Medicare that they were going to be able to charge. So Nevada's looking at it. It didn't pass this year, but I worked in a public agency, and you kind of got to bring it forward 1 year, right? And then you got to wait. You know it's not going to pass the first year. And then you bring it back the next time and they'll talk about it, right? And then maybe by the third time, which for us is 6 years, right? They'll actually pass it because sometimes there's a lot of bureaucracy in public agencies. So I hope that answers the question.
Thanks, Chris. Why don't we give these two ladies a roaring round of applause? Thank you so much. The good news is, Chris has another comment. Please do.
Go back to my slides, please. Nope. Back in to the end. It's after the questions.
Oh, I was going to do a little plug, but you do a plug.
So Dr. Hager will be doing a webinar. Bring it way down because I'm not talking. Oh, hello. Dr. Hale and I will be back to talk to you July 10th, not physically, but, via Zoom or whatever you use. And we want to talk about high cost claims. And in preparation, I would ask, what is it that keeps you up at night, right? So I was a benefit administrator. I was an HR director. And, we used to I could sort of figure out we'd have about 4 high cost claims a year, right? That might hit our stop loss. That has tripled by now. So is that what's keeping you up at night? Is it the high cost of drugs? Is it cancer treatments? We just like to know, if you can start thinking about that now. Secondly is, what is your stop loss threshold and how many claims are hitting stop loss? What are the top disease states? If you know the disease states for your employers, what are the top ones? One of the things that I like to talk about is never events, right? The best thing would be to never have those events. And Sherry, you talked about a couple of years ago, I was in Florida at the Florida Alliance, and I was on a panel and I heard a guy talk about multi-cancer early detection screening. I got that all out this time. I have a really hard time with that. And one of our employers has actually implemented multi-detection cancer screening for their employees. And it's about $800 a person. And they screen for over 50 different types of cancer in one blood test. Says if you can catch it at stage 1 or 2 instead of stage 4, you're not going to have these high cost claims, right? So start thinking about anything that you can do to have a never event. Rosa, paying for the colonoscopies, right? So Washoe County did 500 tests and they had, I think, 7 come back positive, which doesn't sound like a lot, but 7 early stage cancers versus late stage cancers is a ton of money, Plus, it's better for the patient. And I'm just going to, I have a hard time getting off the stage, don't I, Cheryl? And by the way, my husband said, "Cut the effing gate," is what he said when we were hunting. So it wasn't me; it was my husband, but I was part of it. Anyway, I will leave it there. And are you doing anything to mitigate those issues?
And we will send out these questions to those registered for the roundtable.
So this event is actually part of our monthly roundtable series. So if you are an employer member of MBGH and have registered for the roundtable series, this meeting is already on your calendars. But if you haven't registered and you want to attend one of our roundtables for the first time, please let us know. So we're going to be heading into break. But before we do that, I'd like to share a message from one of our sponsors. We don't have a video from the sponsor, but I do want you to learn a little bit more about them. So this sponsor is Razor Metrics, and they deliver innovative pharmacy cost containment solutions that quickly reduce drug expenses. Its proprietary technology identifies savings through medication switching, deprescribing, and decoupling, adapting to each client's plan, preferences, and formulary. Seamlessly integrating into prescriber workflows, Razor Metrics enhances healthcare decisions while lowering medication costs for members and plan sponsors. Based in Austin, Texas, Razor Metrics serves self-funded employers' health plans, PBMs, and organizations to improve pharmacy benefit efficiency and value. So with that, we're going to go into break. I do want to mention at the end of the break, we'll be collecting all of the prize drawing cards. Little birdie told me that we only have one completed card in our little hat out there. So if you haven't completed your card, please do. You're going to have a chance to win some great prizes. Remember that Yeti and gift cards. They're all going to be coming your way through the prize drawing at the end of today. We'll see you back here at 3:40. Thank you.
Okay, folks, we're going to sit back down, eat our popcorn, have our final drink, and our final session of the day. I'm pretty excited because we always save the best for last. We've got 3 outstanding employers who are going to share their experience on this project that we've been working on and kind of wrap things up for the day. Our moderator is Tom again. Sandra, go. Yeah, come on up, Tom. And then we've also got some panelists. Are they out there yet? Dan and Sherry and Jason, I think, right? Here she's coming. I have a few things I need to do while we wait anyway. So we have a quick vignette from our sponsor, RX Savings Solution.
A lot of people are out there and living their lives and maybe not on medications, and then all of a sudden there's a life change and it's a $300 prescription for them to pick up, and then they don't know what to do.
If our members have their RX Savings Solutions app on their phone or mobile device, they are able to look up their medication real time in the doctor's office and be able to find alternatives and have that conversation with the provider.
To get into the clinical weeds of something, but then also know how does that fit in the puzzle.
all of the pharmacy benefits. Whether it's in oncology or in autoimmune, when those guidelines shift, we need to shift too.
If you like apps, you can get us on the app. If you like desktop, you can get us on the desktop. If you want to call us, you can call us.
We have a fully dedicated team here that wants to help, and that's what they do every day.
You're trusting us with your members and our patients, and we take pride in that.
We also have another one that we couldn't get to earlier, and that is a word from Prism Health Group.
There are savings.
We are done. Okay. Well, no big surprise that our next slide is a reminder about the two new resources. The one in the middle there is kind of an overview of ultra high cost therapies and the marketplace. The one on the right is everything employer reflections, employer stories, employer quotes, and the direction of the marketplace. So please take advantage of these resources. Tom and I will be continuing to work on this project. And we did launch a resource on 340B, and I wanted to share it again today. This is also available in the fact sheet is in that link at the bottom. If you don't know a lot about this, I strongly recommend you learn more. And with that, we welcome Tom, and you have some sharing to do.
Yeah, I think we're just gonna skim through these. I wanted you guys to just have the slides that kind of accompany the ultra high cost therapy brief. But before we begin that, I do, did you want to say, oh, you're going to click me? Oh,
Do you want me to
I get
just
a
go
clicker.
through these?
No, this
really
is awesome. No, thank you. I love a clicker. So first of all, I do have to apologize. I made a comment about GLP-1s in the last session that was kind of insensitive and kind of a microaggression, and I apologize. I'm on a GLP-1 myself. I am just a firm believer that GLP-1s should be paired with life cycle management, and we should not allow our members to be on GLP-1s for their life, right? It should be a goal that gets them to the right place so that they can self-sustain as much as possible. So that's just a belief of mine. It's not a criticism, and I didn't mean any microaggression whatsoever. So I apologize very humbly for speaking too fast about that controversial drug. So the landscape is pretty intense. And again, I put these slides in here. There's a number of slides. I put a number of slides in here. It's an accompaniment to the two briefs that we released recently. Take your time to read them. They make great reading material when you're sitting around doing nothing else. But you know, there's just a huge pathway here. Right now, there's close to 3,200 molecule-driven ultra high-cost therapies in the chain. And even if 10% make it, that's still a pretty significant amount of high-cost drugs that are over $100,000, $500,000 a piece, not just cell and gene therapies, but all ultra high-cost, like beyond specialty kind of only drugs. And so the path forward is pretty interesting. With the FDA kind of taking a new approach with the new administration, drugs are going to get approved a lot faster, potentially. So you could see this stuff coming through a lot faster. So, you know, I think we talked about this. These are not typical patients, right? We all know this, that the genetic testing requirements are just really rigorous and sometimes really can be challenging for members. They do have to go to specialized care centers for the most part. And navigation is so important because this is tricky. I've had some members who are very good at healthcare get very lost in the milieu of this on hemophilia medication. And so it's just really important that we think about ultra high touch navigation for people that are kind of going through some of this stuff, because this is pretty intense. What we've seen from our interviews, we did about maybe 50 to 100 interviews. We've got a few more to do, but in this past year under Workstream 1, we interviewed everybody. We just talked to everybody we could. Alex was a pretty big part of this before she moved on to other stuff. And, PBMs and health plans have said a lot of stuff about what they're thinking about, PBMs particularly, because most of these drugs, especially the cell and gene therapies, do not go through the PBM at all. They go through the medical plan because they're a therapy and a treatment. And so it's not really a drug like our typical drugs. Now, the high-cost specialty drugs are still being managed by PBMs, and they have some programs they're looking at. Certainly, they've all started their own GPOs, and they're buying drugs at discounts and hopefully not putting up huge spread pricing. But I will give you a caution: GPOs cannot be audited. So if you ever want to figure out what's going on in the GPO, just be careful, because you kind of get stuck there. Novel solutions, that are out there. We've seen quite a few. You can read through them. There's a couple of vendors, one of them you heard from earlier today, who are just looking at really neat ways to help people navigate through this solution. And I was just talking to a gentleman earlier today, we're going to connect further on, that actually they have a pathway to help people using AI to find both treatments and test, what do they call those things when you have a new drug and it's come to market? Trials. Yes, trials, which are really hard to find. They help find trials, and it's kind of cool. And I think we're going to explore that a lot more too. Pharmaceutical manufacturers certainly leaning in quite a bit here. A lot of them have developed specific sites that you can go to learn about the patient journey, to learn about the medications. CAR-T and all the stuff that's being done there is really kind of taken on a very novel approach to managing the patient through the process and the family. Then consulting firms, I'm not so sure that I've seen a big rush to kind of solve for this. They certainly have, their own pharmacy groups, especially the big four, and they certainly have their own concentration on specialty pharmacy. But when it comes to cell and gene therapy and some of the ultra high cost therapies, and even a position on biosimilars, I haven't seen a lot of them take a huge position, but I think it will come because this is a big deal. And then we did talk to ICER, and ICER is working on some really neat payment and contracting models that we should really watch, because I think they're going to be very interesting. Again, the patient journey is so, I put 2 slides in here. I like to believe in repetition, because I think if you see it 3 times, you'll believe it. And I think we have to constantly think about the patient journey and what that's going to involve for these folks. And, some of these are pretty rigorous positions that we put people through. The financial impact is big, especially if there's a massive copay or coinsurance along with some of these therapies. If they're in a high deductible plan, you got to kind of watch for that. They can get consumed right away. And if they don't have the money, it can be a real challenge. There's stop loss challenges all over the place. We heard about it today. There's benefit design pressure for covering these or not covering these. Your CFO may have a position that's different than your CHRO. And so it's really just aligning across the organization as you build these coverage policies. And then market evolution, it's just going to come so fast. COVID was developed fast, and we accelerated the pace with which we are able to do these things. And so that's going to come to market a lot faster. Continued growth and innovation. Again, there's 3,700 things out there. Some of those are going to get approved, and we're going to have to deal with this onslaught in the next couple of years of this cascading effect of multiple coming to market at a time. Escalating costs and financial implications, emerging payment models that we all kind of have to navigate through and maybe do different things. Again, like I said earlier, I think that there's not one payment model that's going to work for everybody. You might have many in your benefit plan. So it's worth looking at all that and making sure you're aware of it. Regulatory and policy influences. With this current administration and with everything that's going on in the health space, and then potential cutbacks with Medicaid, there is going to be pressure on our side to deal with some of this stuff in the commercial market. And so we've got to kind of watch for some of the things that are coming down from the regulatory perspective. The administration has said they still want to go after PBMs and they want to get rid of the middleman. So we kind of got to watch for what that's going to look like if that ever comes back up again. And then market trends and cost drivers. We all know what these are. Like ultra high cost therapies and specialty drugs are starting to consume our pharmacy benefit. And when I first started in this 30 years ago, if specialty pharmacy was 10% of my cost, I was in trouble, right? Now it's almost 50 or 70%. And so you've kind of got to really understand what that's doing and how to shift people around to biosimilars and other solutions. And then we did just show you what the landscape is looking like across these various groups as they kind of have different stakeholder interests in ultra high cost therapies, or UHCTX as we're calling it. And then employer strategies, there's just a lot. You know, you can try the traditional utilization management type stuff, prior authorization, step therapies, but some of that's not going to work. Some of these don't have step therapies that you can like step into, and putting prior authorizations on something that is kind of like should be done is like just putting a block in the way of the therapy. And some of these things are timed, right? They have to be at the right moment and when the person is ready. And if you give up that behavioral moment when that member is ready for their change, and now you've put a prior authorization in place, you will now impact their behavior change moment. And if any of you have ever tried to quit anything, smoking, biting your nails, whatever it is, you know that you had to repeat that thing 6 or 7 times. And that if you weren't ready to change, you were not going to change. Doesn't matter if your mom, like I used to roll my eyes a lot. Sorry. Oh, am I going too far? Okay. But anyhow, I used to roll my eyes a lot. My mom made me stand in front of a mirror when my friends arrived, and I had to roll my eyes 50 times in front of them while they watched me do it in the mirror. I stopped rolling my eyes. So there's a lot of stuff in here, and I really want to get to the group here because these guys have a lot of knowledge and they're in the front lines right now and doing this stuff. So I really don't have a pathway for the discussion here. I really just want to open it up to them, open it up to all of you. This is the end of our day. You've heard a lot of stuff. I'd like Dan to start and then go to Sherry and then go to Jason and have them just go through what they thought was the most impactful today, what nuggets they would like you to take away from here today, and state anything you'd like about what you're doing to kind of solve for this in your organization.
Sure, I'm happy to start. Dan Denser, I'm manager of health and wellness benefits at United Airlines. We hope everyone got here safely and returns home safely on our airline. The interesting thing here today is I think the common theme was what's coming down the pike, if it's not already here for you, is going to be very, very expensive. Okay. And you can't avoid it. You can't run away from it. And you can't put your head in the sand. You have to be prepared to take on those costs in the most appropriate way for your organization. A company like United Airlines might be able to handle 5 or 10 of these types of claims without it really hitting us too hard. But a smaller company, one claim could put them under. So you really have to pay attention to what you're doing. I'd also say review your contracts. Insurance companies, especially in a stop loss type of situation, if you have a couple of stop loss claims, what are they going to do? They're going to change the terms of the contract because they're eating those costs. They don't want to do that. So make sure you're looking at your contracts and you're paying attention to those. What we're doing at United right now is we're reviewing the options that are out there. We're not a big fan of stop loss ourselves, but perhaps a risk pool. Perhaps there are performance guarantees around the drugs or direct to manufacturer contracts that we can work with on these medications to be able to help to handle those fiduciary responsibilities. Tom was very, very correct in saying these are medical expenses. Yes, they're done by pharmaceutical companies, but it's truly on the medical side that these processes claims get processed. Have you ever tried to really get exposure into the rebates on the medical side? Forget rebates. Let's have somebody else take care of procuring the medication and handling that. The other thought that we have is we don't have a lot of turnover, but I know a lot of people in this room do have turnover. Why can't you have a guarantee that follows that patient? You're not talking about tens of thousands of people here. You're talking about a limited number of people on a particular medication with a particular manufacturer at a particular center of excellence program. They're not going away. Even if they leave you after 2 years, they're still being treated by that doctor or by that facility, or being monitored at least for the data by those manufacturers and by those doctors. If they fall off, should I get my refund? Because it didn't work. It was promoted as a cure and it didn't work. So just something that we're kicking the tires on. We don't have a solution yet, but those are some of the different approaches that we're looking at with United.
Excellent, Dan. And I love your socks. They're very cute. Anyway, just retired from Sargento, Sherry with Sargento, or prior, formerly with Sargento, now kind of just helping MBGH and others, right? So one of the big things that I learned today is we're in this together, and we need to work together to solve for our own issues, right? Collectively, we can do more than any one of us can do alone. I think that's a Mother Teresa thing, right? Wasn't that one of her famous sayings? So working together is one of the things that I'm going to advocate for, any one of my employers that I'm affiliated with, to help us solve any kind of issues, whether they be today or going forward. High cost, yes. High impact, yes. However, high impact now, are they going to fail? Some of those medications that are out there, and I've heard that Zolgensma, as an example, is not a curative long-term for some of the patients that have been on it. So while it might be sold to us as curative now, is it truly curative forever? And how are we going to price that, right? We had an individual, I sat down when Chris was saying something because I didn't know one of the things, but then I stood right back up because I have tried to call Alexion, who is the maker of a specialty medication, Strensiq, which was costing us 2.7 in perpetuity. They did not know how to deal with me. Who are you? What do you want? We don't deal with employers. I'm like, oh my gosh. So it really was quite eye-opening for me. And I'm a bulldog. Like when I get something, I'm going to hold on to that bone and try and go. So I tried 5 different ways to get it. And finally, I got somebody give me a price reduction for this Strensiq. But it takes tenacity, it takes intestinal fortitude, and just a lot of, hard work, quite honestly, from you and your team members to do the right thing and to continually, fight the right fight. I don't think there's not one of us in this room that wants to not cover the medication, whether it be high cost specialty or cell and gene therapy. It's all the same thing. We want to do the right thing for our employees and their family members. We're all humans, and we can put ourselves into the shoes of those that might need it. What would we want for ourselves or our family members? We want that to be covered. But the cost, like Dan said, can bring some employers like Sargento, it was a significant hit when our medical spend, we had an individual with hemophilia that chugged through $8 million in 2 months. Our PBM spend at the time, or total medical spend, including PBM spend, was 17 million. When one person was more than 50% of the claims on 1-2 month, that was just ridiculous, right? So and that was in 2008. That wasn't, that was 17 years ago. So it's been there. It's going to continue to be there. We need to keep up to date with strategies that are out there and work together to help solve the problems. You've heard me say at the annual conference, details matter, and details in your contracts absolutely matter. So making sure you know your contracts, you know what's in them, you know every word. As Jason said, an and or an or can be really, really detrimental or helpful in certain cases. So making sure that you know what's in your contracts, absolutely important. And then just, I don't know, as though hope's a strategy, but hope and a prayer. Definitely, just keep up to date and hope and pray, I guess. A lot of praying. Jason?
Yeah, I think we're getting to a point in science that I always hoped we would get to. And that is, instead of treating a chronic illness and just treating the symptoms or trying to slow the progression, that you actually have science that can cure a disease. And I'm glad that we're getting there. In my opinion, that's long overdue. And I think we want, as Sherry mentioned, we want people to be able to get access to these therapies. But if you said, what's my biggest concern? Somebody mentioned earlier today, I think there were 30 existing gene and cell therapies on the market today and maybe 60 more coming between now and the next few years. But if you go out and look at other websites, there are over 4,000 in development right now. One of those is for type 1 diabetes, which we heard mentioned today, but one of those is for type 2 diabetes. So now you're talking about 0.5 to 1% of your population that may have type 1, maybe 10% that has type 2 diabetes. And if you think about other conditions, you might be talking about as much as 20% of your population that could be a candidate for gene and cell therapy. And if these are hundreds of thousands or millions of dollars, we have to figure out how we're going to fund that. So although we want people to get to the therapies, how are we going to do that? So I think that's my biggest concern. I was hoping that somewhere along the way there would be some governmental ideas on how to tackle this. I've seen some legislation concerning CMS strategies for Medicare and Medicaid, but I haven't really heard anything much about how we're going to help employers pay for this stuff. So as I think about, our approach to it, or at least my approach and how I think about funding these, it would be to look at the whole supply chain, starting all the way with the manufacturer and how do we get the best price for the therapy itself? How do you get the best price and quality guarantees from a COE who's going to administer it? Are you just going to allow people to go to any approved COE, even if they've only performed 5 or 10 of these types of therapies? Or would you want people to go to a COE that's performed dozens or hundreds, maybe thousands of the procedures? So I'm thinking about the manufacturer, I'm thinking about the COE, and I know prior auth and utilization management can be a barrier, but we heard today that 3 people that went for expert second opinion had to get their treatment adjusted because they were on the wrong treatment. And another one with brain cancer who was on the wrong treatment path. And then we heard a couple other examples today. And so if you're talking about very expensive cancer therapies, whether they're gene or cell therapy or not, I think you have to make sure that you're getting the right patients to the right therapies. And then the other question, and Sherry touched on this, if this is supposed to be curative, but in 5 years you start seeing deterioration, there are things the employers have to be thinking about. Would I pay for a second therapy? So if you got the first therapy, supposed to be curative, was promising for 5 years, but patient deteriorates, would you pay for a second therapy, a third therapy, or if these are multi-million-dollar therapies? So I think employers have to be thinking about this. Will you be covering these? If you are, what happens if it doesn't work? Would you pay for a second round of therapy or a third? And I think you have to be thinking about those. Other things you should be thinking about probably is, what if employees seek you out because you cover these medications? Each of you will have your own answer to that question about how you handle that. But what if that happens? If you're a large company or any company that decides to pay for multi-million-dollar therapies and now you have people seek you out for that, what would your approach to that be? So I think employers have to be thinking not only about will you cover the product, what's the value of the product, but philosophically, what do you do in those types of circumstances?
So really a complex set of things that we have to think through that usually are not core to benefit expertise. You have to kind of have some clinical advice. You have to have some financial advice that's a little beyond what we've had so far. And you have to have kind of like a nuanced approach about how you're going to retain and attract talent. And so it's kind of like this whole pull through that is going to matter a lot. We have about 20 minutes left. It's at the end of the day. We've had a long day. It would be a good idea to just open the floor up. You have three of some of the most best benefits people I've worked with in a long time, and you should ask questions of them and where their heads are thinking. So I'd really like to give the floor some extra time for all of you without us taking up time pontificating. It would be good for you to kind of like tell us what you heard from today and if there's any questions you have for the group. How does that sound? You have to ask questions though. I can't throw it out there and not have questions. Don't be afraid.
In terms of, yeah, it's me again. In terms of your perspectives related to what will happen with cell and gene therapies and what should happen. Or maybe it should be what should happen. No, it's what will happen and what should happen. Is that clear? Where do you think it's going for employers? Do you think that there'll be a good integrated system to offer it? Because there's so many moving parts. Will employers be able to afford them? Do you have any perspectives on it? And Dan just turned his microphone on, so he gets to go first.
So I'll start. I think we heard in one of the panel groups today that there isn't a comprehensive solution today that is a one size fits all. I think we're getting there. I think that if you think about the points on a fingertip, you got maybe 2 or 3 right now that are fully baked and ready to go, and you can work at trying to get some of those things together. But then I think within the next year or two, you will see solutions that are coming to the market that will more fully comprehend or complement the financial aspect of the cell and gene therapies, as well as the care aspect of the cell and gene therapies. But it's going to take a little while to get there. So in the meantime, we can't live in a vacuum. We have to talk with your fellow colleagues in our sibling coalitions. You have to make sure that you're working with your consultants, working with the communities at large to pay attention to what's going on. Because as soon as you get hit with one of these, it's gonna be a body blow, and you get hit by 2, it's gonna hurt even more. So you gotta be prepared.
And I would add to that, Dan, that internally educate your executive team and your benefits committee. We have a separate benefits committee that meet, quarterly to that. Make sure that they're fully aware so that they have your back and your board of directors, if you go that far, to ensure that they're aware of this and what's coming down the pike. And if you're unfortunate enough, like we were, and we became an employer of choice, which is an awesome thing, but you can't screen out for medical conditions before you extend an offer. So, and that's not appropriate. So I'm just saying it becomes a real thing, especially in a small town where people talk, that you need to make sure that your executive team is on board, understands, and is ready and prepared for it. When we had that claim that I was talking about before, the CFO went so far as to say, well, can we purchase the manufacturer? I went, we are not in medical, we are cheese. But he was willing to do whatever it took, knowing that the cost of this, they were actively engaged and involved in the conversation. So you've got to get them involved and understanding so that it's not just you and your team doing this. This is a corporate issue that will affect, my prediction, Cheryl, is it's going to affect every single employer within the next 5 to 10 years. How much, how many, I don't know, but certainly it is going to affect each and every, as Jason said, with the numbers of things that are being developed in AI rapidly advancing the science, which is a beautiful thing from a nurse, speaking from the nurse in me. It's a beautiful thing, but then the sheer number that it could potentially impact and the number that then will be on your plan that are eligible is kind of mind-blowing.
Cheryl's question was, where are we at today? And, as I look at the solutions that are being proposed, I'm not sure that they're good long-term solutions. I heard financing, for example. If you're paying for one or two of these a year, that might be an option. The way I think about that is you could put a $5,000 vacation on your credit card and spread that cost out over the year. But if you're taking 15 or 20 of those $5,000 vacations a year, at some point the bill comes due and you have to pay those. And so as you think about that pipeline of over 4,000 of these products, I'm not sure financing these out over time or a viable long-term strategy. And so other things I've heard are risk pools. I hope that works, but the way I was thinking about this as I was giving it some thought is we have roughly half of our employees that are salaried management office workers probably, and maybe half that are production workers. And the risk is different between those two pools. If we're talking about large numbers of these therapies coming to market, just putting my people into a risk pool seems like the ratio could still be the same. Like, so if I have, 10 cases a year in my population, then that number goes up each year because of all the therapies coming to the market, and eventually they get into the hundreds. That's going to be happening to all the other employers too. So I'm not sure that the risk pool really solves that problem either. So, between financing these out over long-term and risk pools, I don't know that those are real long-term financial strategies.
I just have one comment to add. So we can look back at history of the way we've responded to certain issues for how we might respond in the future. And if you, I'm a big study of HIV. It happened to be at a period of time in my life where I lost a lot of friends, and being gay, it was a tough issue. And in the 80s, it was hard, and nobody would listen to us, and we were stuck. And it wasn't until the 90s that there was public funding to manage the HIV crisis. And today we're on the precipice of solving that disease, solving it. And that's like a long time, but we did it, and we didn't do it on the backs of employers, and we didn't do it on the backs of everybody else. Sure, certain employers paid their portion, but a lot of HIV funding was generated in the public level by Congress and set aside in earmarked funds. And so I do think that whether or not you believe in where we're at with the government today, it doesn't have anything to do with that. It has everything to do with what public pressure puts on the Congress and the president that we have at any given time. And anytime there's pressure, there's a response. And it may take some time, but eventually I think there'll be enough of a response that there'll be some kind of a social measure that addresses some of these high costs, because that's how we do things in this country. We solve together. And so unless that falls apart, I don't know how that's going to happen. But you look back at history, and that's how I look at this particular issue in a little bit of a way.
I kind of look at it, think about the mortgage industry. When you first came out of the mortgage industry, you had 30-year fixed financing. That's it. Well, I don't like 30-year fixed. Well, how about 15? I don't like 15 either. How about a 5-year ARM? We'll do ARMs. So they listened to what was going on and they created something. The same thing's going to be happening here with cell and gene therapy. Products are going to be developed. And if there's something within the development that a particular large employer group or a pool of employers doesn't like, they're going to adjust, and they're going to figure out it's insurance. And insurance people always find a way to find a product or tailor a product to what we're looking to go for. It's just not there yet.
Just an online question, which is a loaded one. And I know we've talked about a few models, but maybe from the employer perspective, how do employers cover the large medical inflation expected for the next few years, probably the unforeseen future, without increasing cost share to employees?
We're still bound by the ACA rules that govern the amount we can charge an employee for coverage for certain pay grades and salaries. So I do think those boundaries are going to stay in place. I don't see them going away. It could, but I don't see them going away. The employer responsibility is still there and the boundaries are still there. We still have a responsibility under ERISA to do certain things and have certain provisions. And then there's affordability. And unless every single employer starts charging a ton, you're going to drive people away from you if you're the first one. And nobody wants to drive workforce away. No, our jobs as benefit people is to not do that, to create environments where we pull people in. And so if we make the price too high, I do think that though it's estimated that through 28, if the big bill goes in place, we're going to see increases that start in 27 in the double digits beyond where we're at today. And so if we start to see 12, 15, 18, 20% increases in our plans as self-funded employers because they're charging more to commercial market because the hospitals are broke, they're not getting Medicaid funding, then we will be in a different place. And we'll all have to pull together and find out our answer.
I would say that for our organization, for what I've experienced, we look at it holistically, the cost of medical prescription, all of the benefits are impacted, and then bonuses might be impacted. You know, even though we might not be able to increase the premiums because the affordability requirements are, we may have lower bonuses, we may have lower wage increases or merit increases because the budget is a holistic total rewards budget. Or as you've heard me say before, the CFO only makes me one pie, even though I've asked him to make me another one. He won't make me another pie. So we've got to figure it out within that. And unfortunately, it may be the cost of goods going up, you know, holistically across industries if we can't afford it. And we're stuck to, you know, increasing costs for premiums because of ACA or whatever. So, I mean, don't want to be doom and gloom, but that could potentially be down the road.
I saw reference to GLP-1 impact on costs today, and just GLP-1s alone, not talking about gene and cell therapy. What I remember from the slide was a 12 to 14% pharmacy trend driving up your overall healthcare cost. And so, you know, the employers can have a strategy on how much cost share, what percentage you're going to cover. But as that total cost gets bigger, you know, either you have to spread that cost out somewhere else, to Sherry's point, or you have to eat a whole lot of costs. And is that sustainable for an employer? And you know, it's not going to be when you're talking about the amount of cost associated with these gene and cell therapies. So I don't know the answer to the perfect answer to that question, but things we can at least think about.
Well, I just wanted to sit on the stage the whole day. I just wanted to do that. And so I'm doing it. And I've got one rapid fire question for all four of you. And it's got to be quick. Who has given you the best advice? Rosa talked about it being her coalition. You talked about it being an advisor. Who has given you the best advice and the most comprehensive advice about this area? Or maybe you don't feel like you've gotten great advice. Jason, I'm going to start with you.
It's not one, it's a combination. So in the research that we've done through MBGH here, that was very helpful. But I'm talking to everyone. I'm talking to my peers at other companies. We're talking to manufacturers. We're talking to everyone. So it's a combination.
Excellent. Sherry, anything to add?
I echo that. You made me say one word. So I said broker. Yeah, you said one word. And I'm a rule follower, remember?
So mean.
So I agree with Jason. It is all hands on deck, everything, and just be a sponge and soak it up and take everything and then push back where you can push back.
Okay, Dan?
Yeah, it's everybody. It's not one. It's consultants on the medical side, on the pharmacy side. It's coalition partners. It's reading materials. It's talking to colleagues, finding out what's going on out there and what the different approaches are and why. Ask the question of why. Why does that work for you? That's a very important question. And how?
And for me, it was just pharma manufacturers, probably the biggest influence.
Excellent. Let's thank this wonderful panel. Appreciate your help. And I am going to invite my colleagues up to give away some prizes.
All right, thanks, Cheryl. But first, we would like you to take 1 minute to give us feedback on today's program. So in your mobile app, on the polling card, on that top right, or no, top left, or the evaluation card, scrolling down like in the middle on the right, you can get to the evaluation. This will take you 60 seconds. Lori, you can time us. All right, I think our minute is up. If you still want to give us some feedback, keep going on that evaluation. But I do want to make sure we're out of here on time. So we do have some fabulous prizes to give away, and we have some winners to announce. So let's see, our first winner and the first prize is from Employers Health. Thank you, Employers Health. They have a $200 Sunglass Hut gift card. And that goes to Sandy Lahara. She's the Associate Benefit Director at Baxter. Are you here? Yes, you are. All right, you're going to be rocking those glasses. Scripta Insights provided a Wild West gift pack, and we're not even going to see it. They're going to ship it. But that is going to go to Rosa Novo. You know what? We're going to send it to her. She's so awesome. So she was our speaker from Miami-Dade. So, oh, she's here. She's just hiding. Okay, we'll find her. All right, from Razor Metrics, they provided a Yeti Hopper Flip Soft Cooler. And that is going to one of our virtual attendees, Teresa Chapin from Lilly, and she's the U.S. Benefit Design Manager. Way to go. Yay. All right. She asked some great questions during the day, and we really appreciate that from our virtual folks. Right Way provided a Yeti cooler. They're going to ship that to Amy Hatowski, Senior Benefits Analyst from Fortune Brands. All right, we have a $200 Amazon gift card from Walrus Health, and our winner there is Shaky Caboose. That was Matt Deegan. Way to go, Matt, from State Farm. He gave us his Wild West name. He gets extra points for that. All right, Health Strategy provided a wearable fitness health tracker and a 12-month prepaid subscription. That also goes to a virtual attendee, Heather Harmon, VP of HR, University Hospital. So thank you, Heather, for joining us. And we have one final prize from the Prism Health Group. The Yeti Tumbler is going to, another one of our speakers, Chris Severson, from our Sibling Coalition, Nevada Business Group on Health. So I just want to close by thanking all of you for being here today. I know it was a long day, but boy, we had a jam-packed day. We appreciate you staying to the bitter end. We really appreciate all the virtual attendees who were with us as well. A big, big shout out to our sponsors. As we've talked about, we can't do programs like this without them. And then let's just give another round of applause to our speakers because they were pretty darn awesome. And I'll close by saying, yes, it is the wild, wild west when it comes to managing ultra high cost therapies. But I do think that we can all be in this together. I think if we collaborate with each other, with coalitions, with other employers, if we continue to stay engaged and educate ourselves, and as Sherry said, educate those within our organizations, we can get on our horse, we can ride off into the sunset, and we're going to tackle this one way or another together. So thank you so much for being here, and we hope to see you soon. We have another program coming up in September, and that will be another time for us to get together. So thanks again. Have a great rest of your day and stay cool.